start with Hello everyone and a warm welcome to the day 2 sessions for the online CME by Indian Radiologist Oncoimaging Update Masterclass. We had a wonderful panel discussion and sessions yesterday with important topics pertaining to oncoimaging. And thank you all for being there till late night. The sessions were almost there till 11:45 p.m. We are thankful to all our national and international faculty members for taking out time and for all their efforts they took and shared their knowledge with our delegates. We have this time with us Professor Clement Sirens and Professor Andrea Laghi, who have shared their talks with us and will be also there for question answer sessions live. Not only this, we have various other speakers joining us. We are thankful to the organizing committee members and specifically to Sikandar sir for collating all these important topics together and bringing in the best from the field of oncoimaging so that we can get our updates in place. So yesterday we had covered these topics from biliary neoplasm onwards to breast malignant masses, gynec malignancies, ovarian neoplasms, solid renal lesions by Dr. Day, TNM staging insights by Dr. Chaturvedi sir, rectal imaging from Dr. Amit Chaudhary, and after which we had the sessions on percutaneous image guided biopsies and image assessment response in oncology. Because it was running late, the quiz we didn't conduct yesterday night and it will be taken in today. So stay tuned as there are prizes to be won. So this is the today's extensive program, which we are going to start in few minutes with the first lecture by Dr. Gaurav Goswami on peritoneal cancer index. We are thankful to all our educational partners for their constant support behind these academic events, specifically Bayers. Bayers has been with us over past many years, specifically during the pandemic times. They were really supportive. Few announcements to be made, which will be, details will be shared soon during the events. Breast imaging masterclass is coming up, which is 7th and 8th of May, again online event. The details and the links to register will be shared on the chat box. So this again 2 days event is registered with the Maharashtra Medical Council with the accreditation points, and extensively we'll be covering breast imaging related topic under the leadership of Dr. Shilpa. We are also coming up with the extensive 5 days program of MRI teaching course. So this will be our 21st year of the MRI teaching course, and I'll be sharing the details soon. The dates are in August of this year. So now I take the opportunity to welcome and introduce our first speaker for the day, Dr. Gaurav Goswami. Sir is consultant at Zydus Hospital, Ahmedabad. He is director and consultant of Star Diagnostics and Multi-Speciality Hospital. And his special interest is in image-guided interventions. He'll be talking about something very important pertaining to oncoimaging, that is peritoneal cancer index. We welcome you, sir, and over to you.
Thank you, Dr. Mitusha. Should I start my screen share?
Yes, sir. We can see your screen, sir.
Okay, just to scroll. Let's start, right? Okay, without wasting much of time, let me start the talk. Why to discuss this peritoneal cancer index? First of all, I would like to thank Oncoimaging Masterclass organizers, Dr. Deepak Patkar sir, Dr. Sanjeev Mani sir, Dr. Sikandar sir, and Dr. Mitusha for giving me opportunity to speak about this novel topic. Everybody reports peritoneal malignancy and peritoneal cancer, metastatic disease. But what specific we need to highlight and what specific we need to understand, that is the moral of this topic. That is moral of this discussion. We need to focus on the good understanding of a peritoneal, omental, and mesenteric anatomy, respective regional surgical landmarks, how to optimize the study. Most of the time, we are with the good scanners doing enough of a number of scans. We are good at the imaging. But to include a peritoneal cancer index and pause criteria in our reporting, that is must from today onwards for everyone. And when to evaluate after surgery or a chemo follow-up response evaluation, that is a specific point to be discussed. Just to start with peritoneum, omentum, and mesentery. Peritoneum is divided into two parts: parietal and visceral peritoneum, and that contains abdominal organs and surrounds the abdominal wall along the parietes. Omentum, that is again divided into greater and lesser omentum, and greater omentum is attached with the stomach, and the transverse colon hangs like an apron, and the lesser omentum attaches to the stomach duodenal bulb through the gastrohepatic and hepatoduodenal ligament. Try to understand this terminology GHL and HDL, as I'll be discussing few ligaments. I'll be using these short forms, and you won't believe these are very crucial ligaments for the surgical landmark point of view. Mesentery, dividing into three parts, that is a small bowel mesentery from ligaments of teats to IC wall, transverse mesocolon, that is from transverse colon to the retroperitoneal outline, and the sigmoid colon, that is sigmoid colon to post-pelvic walls. So mesentery into three parts: small bowel, transverse colon mesentery, and sigmoid colon mesentery. Let's just go through the peritoneal spaces. That is divided into three parts: supramesocolic space, inframesocolic space, and pelvic peritoneum. In supramesocolic spaces, there are multiple fissures and ligaments, which are of important surgical landmark, as well as the important to identify during your reporting. The fissures are fissure for ligamentum teres, ligamentum venosum, and fissure for gallbladder, or we can say gallbladder fossa. Supramesocolic ligaments are falciform triangular ligament, HDL, hepatoduodenal, and the gastrohepatic ligaments, gastrosplenic ligament, and phrenicocholic. These last two ligaments are an accessory ligaments. So we can consider a primary ligament and an accessory ligament. I'll be discussing the importance of this primary as well as the accessory ligaments as a potential space for deposit and the surgical landmark both. Right. This is the schematic diagram. On the right side, you can see supramesocolic compartment that is divided into three parts. Red is a right subhepatic space, orange is a left subhepatic space, and a yellow, right is a right subphrenic space, which is subdiaphragmatic space. Left is a subphrenic space, and underneath that yellow is a subhepatic space. The inframesocolic compartment and pelvic peritoneum is clubbed together. Green is right inframesocolic. The light green or pistachio color is a left inframesocolic space, and yellow is a pelvic peritoneum space. Just to sum up, peritoneal space in supramesocolic compartment is right and left subhepatic, subphrenic, perihepatic space, and the lesser sac, which is the space between the stomach and the peritoneum, pancreas. Fissures are ligamentum teres, ligamentum venosum, and fossa for gallbladder. Supramesocholic ligaments are falciform, HDL, GHL, and gastrosplenic and phrenicocholic. What to see in image now? The right and left subphrenic space, which is divided by the falciform ligament. You can see the green arrow on the either side, right and left, underneath the diaphragm. That is the right and left subphrenic spaces. The green arrowheads in the first images is a subhepatic space, medial to the gallbladder fossa and surrounding the caudate lobe. In the other images, small green arrowheads are there. That is the right subhepatic spaces and the left subdiaphragmatic spaces or left subphrenic space. The right and left subhepatic spaces are bounded by liver and kidney on the right side and left lobe of liver and the stomach on the left side. So these three major fissures, which is a important surgical landmark, where are the maximum ovarian deposits or metastatic peritoneal deposits can be seen. Fissure for ligamentum teres, which divides medial and lateral segment of the left lobe and attaches to the dorsal surface of falciform ligament, which is mostly on the posterior or posterior-medial aspect of the division of right and left lobe. Fissure for the ligamentum venosum, which separates the caudate lobe. So whenever you identify the deposit surrounding the caudate lobe, try to differentiate it from the gastrohepatic ligament, because again gastrohepatic ligament contains the major vessel and the lymph node. Fissure for gallbladder, which is the maximum potential site for the carcinomatosis because of the cranially concave space. Three primary major ligaments and three accessory ligaments of supramesocholic spaces, triangular and falciform ligament, which divides right and left lobe. Hepatoduodenal ligament, which contains coronary vein, left gastric artery, and left gastric lymph nodes. Gastrohepatic ligament, which contains common bile duct, common hepatic duct, hepatic artery, and portal vein, and the portal lymph nodes. So these three are triangular, falciform ligament, and HDL, gastrohepatic ligaments. These three are the major landmarks for the surgical point of view. Whereas gastrosplenic deposits, gastrocolic ligaments, and phrenicocholic ligaments are a suspensory or a accessory ligaments. And even if they can get resected, that is fine. You just go through the HIPEC or PIPEC for completion of the surgical process. Inframesocholic compartment, to understand the inframesocholic peritoneal space anatomy, it divides into right and left inframesocholic space, right and left paracholic gutters. So mesentery of the terminal ileum is the most dependent part, hence the most common site for the deposition. So always look at the right inframesocholic space at the terminal ileum, around the terminal ileum, and along the ileocholic vessels. Colon, which is again a predominantly ascending, transverse, and descending colon, defines the paracholic gutters. Right paracholic gutter is a wider, which gives more space to the travel fluid and pathology to the right subhepatic space and subphrenic space. So right and left paracholic gutters and right and left inframesocholic compartments. Coming to the pelvic peritoneal space anatomy, pelvic peritoneum reflects over the bladder, rectum, and uterus, placing them in extraperitoneal structure. Remember this, bladder, rectum, and uterus are the extraperitoneal structures. Reflection up to the pouch of Douglas in female and rectovesical pouch in male. So 2 points in the peritoneal anatomy: uterus, rectum, and bladder is an extraperitoneal structure. In male, you have to look for the pouch of Douglas, and in male, a rectovesical pouch. Any paravesical region or a pouch of Douglas, rectovesical pouch, and dome of bladder are inferior margins of the pelvic peritoneum. So don't consider paravesical pelvic deposit in below the level of urinary bladder or surrounding the uterus. You on MRI you will see the T2 hypointense line, which will demarcate the pelvic peritoneal cavity. Sigmoid mesentery, that is the part of mesenteric cavity, and sigmoid colon, which bounds the sigmoid colon to the posterior abdominal wall, and the commonest site of the sigmoid serosal deposits and the pelvic ileal loop deposits. What I have discussed, single slide sum up is what is the importance of right and left subphrenic space, diaphragmatic deposits. Right and left subhepatic space, liver capsule infiltration, chances of periportal extension through the foramen of Winslow. Lesser set, retrogastric disease, retromental disease. Periportal space around the hepatoduodenal ligament. You have to go for a portal vein patency identification, hepatic artery encasement. These are the checklist. You have to check the portal vein, you have to check the hepatic artery, common hepatic duct, cystic duct involvement, and whether there are nodes over there or not. Perigastric space around the gastrohepatic ligament. Check for the left gastric artery, coronary vein, if it is dilated or visible. Left gastric nodal infiltration is there or not. Splenic hilum, again, infiltration of a splenorenal and gastrosplenic ligaments. Perisplenic disease, up to the level of left dome of diaphragm, you have to see for the left subphrenic deposits and phrenicocholic infiltration. Actually, phrenicocholic infiltration is very well depicted in on an MRI. Left inframesocholic space, upper jejunum, majority of the ileal loops, mesentery, vessels and lymphatics. You have to check for inframesocholic space, lower jejunum and mesenteric vessels and lymphatics, sigmoid colon, serosal deposits within the pelvis. Coming to the purpose of this understanding of anatomy, that is a peritoneal cancer index and a surgical landmark, in which all cases we see peritoneal deposits or a primary peritoneal malignancies. So primary peritoneal malignancies, definitely it is rare, but in such a good diagnostic era of medical field, we get to see many other mesothelial malignancies, epithelial origin primary peritoneal malignancies, few rare desmoplastic small round cell tumors also, and leiomyomatosis peritonealis disseminata. Plenty of metastatic disease we have encountered in our practices: ovarian, PMP, that is pseudomyxoma peritoni, appendix, colorectal malignancies, stomach, pancreaticobiliary, cervix, endometrium, and in rarest case, breast and lungs. Before PCI, before peritoneal cancer index, you need to characterize the lesion. You characterize lesion into two parts. In any lesion, not only in malignancy, not only in body imaging, anywhere in the body, you always characterize lesion into two parts. One is either morphology, one is a morphology, and the other is density in CT or a signal intensity in MR. So whenever we mention a lesion appears like this on morphology and in signal intensity or a density. Same is here with the peritoneal malignancies or a metastatic disease. Morphology, we need to look for either there is a nodularity is there, associated scalloping of the underlying lesion, you need to check for calcification, whether it is present or not, thickening of the peritoneal pleats. So sometimes you don't find a mass-like lesion, but you may see a pleats of thickening, pleats of parietal thickening, or properitoneal, preperitoneal lines that you have to check for. Then whether these lesions are single, multiple, confluency, you have to mention. If a large confluent lesion creates a cake-like lesion, which is called omental cake, identify the mesenteric, omental, and parietal peritoneal retractions and try to demonstrate the lesion morphology along these retractions. Mass-like lesion, you have to measure the size. Visceral and serosal or a vascular deposit, you have to precisely mention with a specific columns, such as the mesentery involved, such of the this much segment or this much bulk of small bowel is involved. Vascular deposits up to this segment with or without partial or complete luminal encasement is there or not. So these are the things you have to mention in the morphology. Let's come to the density, whether the lesion is solid with or without necrosis or ascites. Many mass-like lesions, many large lesions may present like solid lesions. Omental cake, you may see some vascularity or a cystic spaces within that you have to mention in the in the density or signal intensity. Cystic lesions, sometimes purely appendicular cystic malignancies, mucinous deposits, PMPs, they club together and give a large cystic lesions. Mucinous lesions, you have to precisely mention. Many other time we just mentioned that diffuse fluid is there, or you have to mention mucinous so that an inadvertent tapping or inadvertent paracentesis doesn't occur in such patients. Then fluid density and intensity you have to mention. Septations, definitely yes. The role of imaging in CTMR is peritoneal cancer index, which is developed by the Paul Sugar-Baker, is one of the most important prognostic variables in the peritoneal surface oncology for selection of the cytoreductive surgeries and pertaining the benefits of the procedure. Through a surgical evaluation, though a surgical evaluation is a gold standard imaging, but it has some limitations. If a prior major invasive procedure has already been done, there are chances of under-evaluation in case of intraperitoneal adhesions. Scope negotiation is difficult. Sometimes large solid tumor which is occupying the space and not able to see beyond the lesion. Hence, the imaging is the primary modality for the assessment. Good quality abdominal CT and MR is fairly enough. I personally prefer positive oral contrast and rectal contrast just to demonstrate a better serosal deposit along the wall. And mannitol is also fine. Triphasic CT is must. Always take delayed scan to identify ureters and urinary bladder. Contrast MRI at my center we have done more than 200 peritoneal MRI done and published major articles in BMJ and ESO, European Journal of Surgical Oncology also. CEMR enterography or enteroclysis gives perfect, excellent identification. Diffusion shows the high cellular turnover, and contrast images are the key images to identify the silent lesions at subphrenic spaces, at parietes and pleats of peritoneal reflections. So how do you characterize the lesion? To divide it into easiest transformation, fluid, nodules, and mass-like lesions. That's it. Identify for the fluid whether it is present or absent. Fluid density, low density or high density. Mucinous, you have to precisely mention it is a mucinous fluid. Nodules, present or absent, and if present, then you have to mention the size. Fluid adjacent to the nodule. See, sometimes the fluid adjacent to the nodule is a key feature for the potential spread of that individual pathology from there to the other respective space where it is communicating to the either along the cranial or a caudal extension. Size criteria again divided into 4 parts. LS0, lesion size. LS stands for lesion size 0, it is no lesion. LS1, that is size less than 0.5 centimeter, that is size less than 5 mm. LS2 is size lesion up to 5 mm to 5 centimeter, and LS3 is lesion more than 5 centimeter. This is the chart. I have the Paul Sugar-Baker has divided the entire peritoneal space into the 13 regions, starting from 0 to 12. 1, 2, 3. These are the central right upper. I'll be discussing individual region with the images and size characterization and how to go for the total calculation. Let's start with the total region. It is 0 to 12, that is 13, and the PCI maximum is 0, minimum is 39. So 13 region into LS3, that is 39. Let's start with the region 0, which is central region. You can see the diffuse nodular and mass-like deposits. Sorry, diffuse nodular and mass-like deposits, which is marked in the green arrows. So you need to measure the largest lesion amongst them and in the longest dimension. Characterize them in the LS2 or LS3. This will fit into LS2, I think. The other image, a large mass-like lesion in the post-op CE ovary. This patient was a post-operated case and developed this large mass-like lesion, which was a CE ovary deposit on biopsy. And a single lesion more than 5 centimeter, you can consider it in the 0 central region with the LS3 size. The MRI, you can see in the first image, that is just a minute. Let me. I'm not getting the pointer. Okay. At the hernia site, there is a defect in the anterior-abdominal wall hernia. There is anterior-abdominal wall defect, and there is a deposit. You can see the mucinous deposit is seen very well in the anterior-abdominal wall, subcutaneous plane. The other image, there is a plaque-like thickening as well as the multiple lesions along the left. Am I audible?
Yes, sir, you're audible, sir.
Yes, yes. Do you know how to get the mouse? I am not able to get the mouse here.
Sir, on that slide screen, if you can do a right click, is it giving pointer option?
I got stuck.
It's a Mac computer, sir.
Yes, yes, it's Mac, but I think even I'm not able to change the slide. Okay, fine. Just go with this only. Then
we can see the pointer on this setup, like without
yes,
full screen.
no, but this one. Okay, then let's proceed. This is the central region, and you can see the plaque-like thickening in the second image. That there is extension of the disease along the same peritoneal space onto the left paracolic region. The third image, that is post-contrast MR, where you can see the large mass-like deposit within the parietes of anterior abdominal wall and along the surgical scar. The second region is right upper. You can see the deposits along the right peripatetic space and underlying scalloping of the liver capsule. Same right subdiaphragmatic and left subdiaphragmatic deposits are also marked here. We are focusing on the right upper, so right subdiaphragmatic deposits we need to mention. So most of the time CT always underreport the diaphragmatic deposit because of the undulation of the diaphragmatic surface. If we go for an MR of this patient, then you can see small enhancing nodular deposits or a continuously enhancing diaphragm slit. This is the MR image of same patient, which is the second image of MR. That is a contrast enhanced MR, and you can see the continuous diaphragmatic deposits, continuous diaphragmatic thickening is there. A very well visualized right subphrenic and subhepatic disease on the first image also. Again, right subphrenic, left subphrenic, and right subhepatic deposit, and right perihepatic deposits. So here you are not able to measure any lesion, so you can mention it as a LS1. Disease is there, but no measurable lesion. So fluid present, measurable nodules absent, measurable lesion no. Again, epigastric deposits, gastrohepatic recess, and along the gastrohepatic ligaments, and lesser sec deposits are very well seen. On the second image, you can see a large deposit between the posterior wall of stomach and the pancreas, and the anterior wall of pancreas. Epigastric again, gastrohepatic recess, and along the gastrohepatic ligament deposits are there. Lesser sec deposits are seen. In the second image, right upper corner, you can see the continuous peripheral thick wall organized collection or organized deposit is seen within the under surface of the stomach. Left upper, the marked lesion around the perisplenic region and perihepatic lesions are also marked. So don't consider perihepatic lesion, but the left upper deposits are considered. You can measure these lesions also. It is a peripherally enhancing cystic septated lesion. So I think the lesion must be of LS2, whereas in left upper and left flank deposits with perilesional fluid, you can see in the second image. See, such fluids track along the peritoneal space. So if a nodular lesion with the fluid around, you have to raise the possibility of the deposits wherever there is a fluid. Left upper lesion, complex cystic deposits you can see along the left lobe of liver and under surface of the left dome of diaphragm, a large enhancing lesion. Sorry, these are the PD fat set images, the last lower image, and you can see the fluid with embedded large mass-like lesion. Sometimes CT miss such kind of mucinous deposits in the presence of underlying fluid. Left flank lesion, you can see first image LS3 lesion, which is more than 5 centimeters in size in a longest dimension, and it is a solid lesion. On the second image, you can see a diffuse ascites with deposits along the left subphrenic space as well as in the paracolic regions. As I already mentioned, that in presence of fluid, you may miss solid or nodular deposits. Again, though this is a left lower peritoneum, it is not a left pelvic cavity right away. A very well enhancing nodular lesion in a post-operative case of a C rectum. So as I said, you may miss, there are chances of hidden lesions within the pre-existing dense fluid collection. So these are the MR images, post-contrast MR images in 3-plane. And you can see that there is a presence of enhancing mass-like nodular as well as the discrete nodular deposits within the presence of fluid, which extends along the entire peritoneal reflections. In the last image, you can easily see bladder and the deposit above the bladder along the peritoneal reflections. Region 6, large pelvic deposits in a case of postoperative CA. There is definite serosal involvement also. Whenever there is an overlapping disease, if you see a large lesion in the central region and the pelvic region, which encases the small bowel, mesentery, as well as the iliac loops and sigmoid, you have to characterize such lesions in all the regions. A postoperative case, first image, where you can see a plaque-like thickening of the parietes on the either side, right and left. The third image, as I already mentioned in the previous slide, the pelvic peritoneal deposits above the level of urinary bladder. Again, sigmoid mesentery deposits and sigmoid colonic serosal deposits are pelvic deposits. You can better characterize with the good quality distension of rectal and rectosigmoid loops by the rectal contrast administration, be it positive or a mannitol. Then pelvic deposits, pelvic entry omentum, which is hanging like an apron till the prevasical region. Here, this patient is female. You can see the uterus, and there is a rough arbitrary differentiation between the entry omentum and the uterus. The last image, this last two images, the lower two images shows, first is post-contrast image of a mucinous deposit along the colon. The definition of a colon is very poor on the post-contrast image, but if the same image you can see on MR pelvis, pre-contrast or a T2 weighted image, you can see a slit-like lumen with the long segment sigmoid deposits. Again, the region 7, right lower, primary appendicular malignancy with a retrocecal deposit, a small cystic deposit. Serosal deposit of CA ovary, a simple serosal deposit along the entry wall of a cecum. This is the second image is a measurable lesion. First image is again a measurable lesion, but you need to mention the fluid density, wherein the second image you need to mention the solid density. Again, right lower, the diffuse disease of PMP, pseudomyxoma peritoneum. You have to characterize all the lesions at all these places. Region 8, right flank. So LS3 lesion, which is a large measurable lesion, and LS2, which was the left flank. We need to focus for the region 8 right flank. So LS3 lesion on the right side, and the diffuse deposit with the fluid around in the right paracolic gutter. Coming to the 9, 10, 11, and 12, that is upper jejunum, lower jejunum, proximal ileum and the distal ileum. So you need to identify small serosal deposits along the mesenteric and antimesenteric wall. So whenever you characterize, you have to characterize according to the morphology, size criteria, intensity, and density. In addition to that, you have to mention that the lesion is along the mesenteric border and the antimesenteric border. Lower jejunal deposits in the region 10. Region 11 and 10, that is upper and lower ileal deposits. On the right side, you can see the proximal ileal deposits, proximal or mid-ileal deposits. And second image is the right pelvic deposit with surrounding the cecum and part of the IC wall and terminal ileum. How to practice? So this is what you already reports, but you need to practice. There is a website, e-promise evaluation, and in e-promise evaluation you just have to uh, uh, go to the peritoneal cancer index, e-promise peritoneal cancer index, and you mention region 1 this, region 2 this, region 4 this. It sums up the entire PCI calculation in this chart format, and gives you the end result. Or uh, uh, the image which I have already shown for the charting, that you can get the printout from the internet also, and try to fill it in the reporting. So coming to again important landmarks, a subcapsular liver implants adjacent to the right hepatic vein is a crucial point. Implants more than 1 centimeter at the level of diaphragm, lesser sac, porta hepatis, intersegmental fissures, gallbladder fossa, gastrosplenic and gastrohepatic ligaments are important. Extensive involvement of small bowel and origin and root of mesentery is important surgical landmark. Lymph node around the celiac axis, pelvic side walls, and the bladder trigone, that is again important. Pleural effusion, you need to get a cytology proven report first. What is the importance of PCI for the complete cytoreduction or the cytoreduction followed by HIPEC? So CTMR imaging works as a roadmap to the surgeon. How this helps to the surgeon? So we need to take a pause. What is pause? It is an assessment criteria to predict surgical outcome. What is the role of radiologist in surgical outcome? So this is the pause. All these findings are characterized by radiologists. No one can tell any other these findings other than you. Pause P stands for peritoneal cancer index, that you have to measure it out of 39. A, ascites and abdominal wall involvement, where the midline abdominal wall disease have better outcome than the lateral abdominal wall disease. U stands for unfavorable sites, that is a U score. Classification is again U1 and U2. Small bowel and mesenteric involvement, mild disease and extensive disease for small and bowel mesenteric, you have to characterize and you have to mention it in your report. Extraperitoneal metastasis, nodes, lungs, liver, pleura, and pericardial cavity, that is the E part of pause. Coming to the unfavorable sites, U1 and U2. So this is the table. I'll just go, what is the importance of U1 and U2 is, U1 sites increase the surgical complexity and may need complex surgery. For example, gastrectomy, Whipple's procedure, nephrectomy, ureteric implantation, cystectomy, and prostatectomy. And U2 sites are there to reduce the likelihood of a complete cytoreduction. You will not get a complete cytoreduction. So this chart is important. And for that, you need to understand the POM, peritoneal momentum and mesenteric anatomy and surgical landmarks. So concerning CT features in the patients with malignant peritoneal mesothelioma, so CCTF, that is again the part of pause. But in addition to all this PCI and pause, what we are concerned about the CT imaging or MR imaging features is there any obstructed small bowel? Yes or no? Is there any clumped small bowel mesentery? Yes or no? Is there any mesenteric infiltration? Is there any deep pelvic deposits? Infiltrated porta hepatis or a lesion size more than 5 centimeter in the lesser omentum. Mass more than 5 centimeter adjacent to the jejunum. Effusions. Enlarged cardiophrenic angle lymph nodes. Omental infiltration 2+ or 3+. That is a 2+, 3+ means any omental infiltration more than 2 omental cake size. Ascites 2+, 3+, that means a moderate to gross ascites. And abdominal mass more than 5 centimeter. Any isolated or a diffuse lesion size more than 5 centimeter. These are the concerning features for the surgeons. What is the importance? If a subcapsular liver implant is there adjacent to the right hepatic vein and around the porta, they have to go for segmental or lobar non-anatomical liver resection. So that's why that is important. Implant more than 1 centimeter in size, diaphragm, lesser sac, as I already mentioned, you have to go for segmental non-anatomical liver resection with or without diaphragmatic stripping, cholecystectomy, callots clearance, partial gastrectomy or complete gastrectomy, or Whipple's. Extensive involvement of small bowel, bowel resection with or without anastomosis. Sometimes patient may end up into the permanent stoma, or mesenterectomy have to be performed, or the patient goes in CRS, cytoreduction, as well as the HIPEC. Pelvic side walls, partial or complete cystectomy, bladder ileal conduits, DJ stenting they have to perform. So you need to get a good delayed images. Pelvic peritonectomy, they have to go for bowel resections and colonic stomas. Pleural effusions, if it is cytology proven, then pleurodesis with the diaphragmatic stripping is important. Uh, After all, whatever said and once the surgery is already completed, or a chemotherapy or a HIPEC is done, or CRS, whatever they have proceeded, when to go for a follow-up scan. If any intervention is done and there is an immediate scan, there is no time lag. Just go for the scan, check for the bleeds, check for the collections, check for the bowel leaks, and report it out. There is no point of assessing the disease in immediate scan. Remember this, no point of assessing disease in the immediate scan. If a surgeon says how much residual disease, you cannot say. Surgical response assessment, less than 2 weeks, try to avoid surgical assessment response. You may mistaken with the post-operative changes. But whatever the immediate post-operative complication were done or not done, try to look out for all these things. In the immediate surgical assessment response, within less than 2 weeks, at least try to save life, not to try to diagnose. Identify major identifying points for the life-threatening complications and just tell them come after 4 weeks. 4 weeks you need to identify in a religiously manner as whatever you have done in the prior scans. Try to go for MR peritoneum. MR peritoneum is an amazing tool to identify the surgical response assessment. With the background of histological subtype, see, whenever you response evaluation, you need to get a 3 points. You need histological subtype to identify the disease pattern. Spread. Previous imaging. Without previous imaging, do not attempt. Surgical details, whether it was a CC0, whether there was some residual disease with HIPEC, without HIPEC, what was the prior protocol for the imaging, continue with the then. And difference between identification of infective collections, abscesses, hemorrhagic collections, and peripheral enhancing cystic mesotheliomas, necrotic nodes, and peritoneal lesions is must. Again, coming to the surgical PCI, that is a gold standard, major invasive, but the tumor and the previous surgical intervention limits the assessment. Hence, the CT and MRI is again important landmark for the assessment. And the take-home message, which I've already shown in the first slide, we need, everyone is reporting such diseases and such malignancies, but you need to be extra cautious to mention PCI, try to follow the pause criteria. And if it is a response evaluation, focus on these 3 points where immediate post-op complication is there, less than 2 weeks, and more than 4 weeks criteria. And keep a chart along with you still, even after more than 150 MRs done on peritoneum and multiple scans in last 12 to 14 years I have done, I still keep one checklist along with me. Better not to miss a single finding, because it is a roadmap to the surgeon, and it gives immense intraoperative confidence to the surgeon with our good quality CT and MR, PCI, and pause assessment. So that's it from my side. I hope I have justified the talk, and I tried my best. If any other concern or any other specific points you need to discuss, please reach out to me. Thanks a lot. Thank you.
Thank you, sir, for this excellent talk and the detailed explanation, because peritoneum usually seems to be a complicated topic, which we miss to read in details, and then the details in which you have provided it and the references are really useful. I would request you to please answer the questions. They are coming up in the Q&A sections. You can type down the answer itself, sir, because they will be coming for next 5-10 minutes for the sake of
Sure,
time.
sure.
Yeah.
Sure.
Thank you.
Sure. Thank you.
Now it's time to move to the next topic for the day, and which is the role of the imaging in deciding the resectability in pancreatic ductal adenocarcinoma, yet another important and intricate topic. And for this, we have with us Dr. Samarjit Guman, sir, who is Senior Consultant Radiologist at Department of CT and MR, Sir Gangaram Hospital, New Delhi. His main areas of interest are body CT and MR, hepatobiliary imaging and liver transplant imaging, as well as head and neck imaging. He is Joint Secretary to Indian Society of Gastrointestinal and Abdominal Imaging, and he has multiple peer-reviewed publications and presentations at international national forums to his credit. He is somebody who is very well known in oncology forums at national and international levels. We welcome you, sir, and over to you.
Great, Mitusha. Thank you so much. I think I need to share my screen now. Is it
Yes.
possible?
Yeah, you can share. Sir.
Okay. So thank you very much for that kind introduction and for having me here. Like you said, my talk is role of imaging in deciding resectability. It's why are we so concerned about it? Because only 5% survival rate of pancreatic carcinoma of everyone who's diagnosed. And in patients with localized disease, that shoots up to 25%. So you get a five-fold increase if you are able to do an R0 resection. That means you're able to remove all disease. You get a five-fold increase in survival of these patients. Right? So who's going to say which patients will should go in for surgery and may achieve an R0 resection? That is the radiologist. And if you select your patients wrong, that means you come out with an R1 or R2 resection. You have subjected the patient to a Whipple's procedure, which itself has a mortality rate of 3%, without and all the associated morbidity, without giving them any survival benefit. So if you have a patient who has an R1 or R2 resection, their survival is similar as a patient with metastatic disease. So you have not achieved anything other than giving a lot of morbidity to your patient. So what are your imaging modalities? So everyone knows you have MD-CT now, you have MRI, you have PET-CT, and for pancreas you have EUS. So most of the people will tell you that MD-CT using sub-millimeter axial sections is the modality of choice for imaging patients for resectability with pancreatic carcinoma. You may get a patient who has had a CCT from outside, and if you're not able to provide the information required, it is suggested that you repeat it with at least a dual phase CT, because you can make a difference in up to 50% of patients. You will get findings which will change your management. MRI has a definite role in patients who have isodense mass lesions and in patients who have indeterminate liver lesions. And US, although the gastroenterologists are really pushing for it, all societies would say that use it only with CT or MR, don't use it as a substitute. Now about PET-CT. So PET-CT, you can combine it with the multi-detector CT. In that case, it is acceptable. Usually only MD-CT is enough, but PET-CT is indicated in those patients who have a very high CA 19.9, particularly in the absence of bowel obstruction, patients who have large tumors, large lymph nodes, or patients who you think have borderline resectable disease, which is a gray area, and you can decide to use PET for those patients. Basically, patients where you have a high index of suspicion for metastasis. Just a small slide that is the celiac axis, the common hepatic artery, the gastroduodenal artery, hepatic artery proper, left and right hepatic arteries. That is the superior mesenteric artery. All right. That is again the superior mesenteric artery showing you the fat planes around it. The retropancreatic splenic vein, the superior mesenteric vein, the portal vein, that is the superior mesenteric artery again. Superior mesenteric artery is on the left, the superior mesenteric vein is on the right. On axial images, this is the superior mesenteric artery with its intact fat plane. That is the portal confluence. And again, you see there is pancreas anteriorly, but nothing around this part of the confluence. Okay, so what about AJCC staging of pancreatic carcinoma, which underwent a change in the 8th edition? It is a size-based criteria now. Earlier, it was whether the tumor is within the pancreas or outside. So T1 is tumor less than 2 centimeters, T2 is tumors 2 to 4, T3 is more than 4, and T4 is tumor involves the celiac axis, superior mesenteric artery, common hepatic artery, regardless of size. So note over here that nobody is mentioning veins in the T4 classification of the tumor. And N1 is metastasis in up to 3 regional lymph nodes, and N2 is 4 or more regional lymph nodes. So this is the AJCC classification for those of us who are going to go in for exams. So less than 2, 2 to 4, and involving the artery. As you can see, the tumor has gone around the artery. So how did I decide that the tumor has gone around the artery, and how do we see vascular involvement when we are looking at our vessels? So abutment is universally taken. So if you have a 360-degree vessel like this, so abutment is taken as less than 180-degree involvement, and encasement is taken as more than 180-degree extension around the tumor. This does not always mean that you may not be able to take off the tumor. It just means that the chance of the artery being involved is much more. Now, there are two terms which are used when you're using pancreatic carcinoma resectability. One is tumor vessel interface, again, which means that how much of the tumor is touching the vessel, and solid tumor contact. And we will talk about these a little later. Even if you don't see tumor all around the vessel or more than 180 degrees around the vessel, if you get a tenting of the vessel like this, if you get a distortion or irregularity of the vessel, that almost always means that the vessel is involved by tumor. Coming back to our major topic of the day, which is resectability. There are three categories of resectability, of deciding resectability. Right? One is a clearly resectable patient. That means when the patient comes to you, there is a high chance of R0 resection. The fat plane around the artery is clear, the fat plane around the vein is clear, and in all normal circumstances, the surgeon should be able to remove this tumor and not leave any residual disease behind. If you are using not very stringent criteria, that means you are saying that everything should be clear, then this is fairly simple for us to see. Locally advanced disease is also fairly simple for us to see. That means that there is generally arterial involvement, and this is where the entire rub lies, borderline resectable disease, which are tumors at a higher risk of residual disease left behind or major vascular resection. The standard of care for borderline resectable disease nowadays is to do neoadjuvant therapy pre-resection. So before the patient goes for resection, in patients who you or I will categorize as borderline resectable, the patient will probably be sent for neoadjuvant chemotherapy. So you are literally deciding, again, what is going to happen to this patient. You're deciding the course of management. Right? So what are the criteria for resectability? So there are anatomical criteria, right? That is the most widely. So this is what a radiologist can see. We can see the anatomy. We can see the celiac axis, common hepatic artery, HAP, SMA. We can see the veins. There are also biologic criteria. So once you give them an anatomic report, if you have a patient who has a very high CA 19.9, more than 500, and they doesn't have obstructive jaundice, very likely that he has metastatic disease. And of course, if we say the patient is resectable, but the anesthetist says, this patient is in such a bad state that I cannot, take this patient up for surgery. That is the condition. So this is anatomic, biologic, and condition, ABC criteria for resectability. As radiologists, we are concerned mainly with the anatomic criteria, which is what we will be concentrating on. Now, who decides? What is the criteria? Where is the data? What is the literature that says that this is resectable, this is not resectable? Who is going to decide that? Right? So everybody has decided apparently to go in and make their own criteria. MD Anderson decided that we will make our own criteria. The National Comprehensive Cancer Network keeps updating these criteria. We are now at version 1 of 2022, which was, I think, released in February. Then there are the Society for Surgical Oncology, the American Hepatopancreaticobiliary Association, the Alliance for Clinical Trials in Oncology, and then there are the IAP consensus guidelines. There are also Japanese guidelines, but I mean, what I want to tell you is that there are multiple guidelines which tell you different classifications of resectability. What you need to do is sit down with your surgeon and decide, listen, what are you comfortable with operating? What are we going to send to neoadjuvant? What are we going to take upfront for resectability, right? But obviously, before we do that, we have to be a little aware of what are the different guidelines, what are the different criteria. These are the documents from which I have taken the criteria. Usually, the most commonly followed criteria is the NCCN or the National Comprehensive Cancer Network guideline, right? So the guidelines are divided into arterial involvement and venous involvement. Okay, so what is the arterial interface contact? What is the venous interface, or what is the venous contact? Okay. If you look at the resectable criteria for National Comprehensive Cancer Network guidelines, they will say that the SMA should be either less than 180 degrees with no irregularity. Remember, we said that if there is irregularity, there is involvement. So what they are saying is that the vein should not be involved. Even if it is just touching the vein, we can accept it. With arteries, there should be no contact. So SMA, CHA, celiac, we are saying no contact. If we say contact, then we will go on to borderline resectable. So if you have a vein with more than 180 degree contact or less than 180 degree contact with irregularity, which means you are actually saying that the vein is involved. Or if you have solid contact with IVC, which means that the IVC may be involved, we are putting this patient into the borderline resectable disease where we don't want to go ahead and do an upfront surgery. Less than 180 degree with SMA, less than 180 degree with variant anatomy, which is a specific thing for NCCN, which I agree that should be included. And I will show you why, right? Reconstructible CHA. And for body and tail tumors, it says that celiac axis of less than 180 degree we will accept. Earlier, this was more than 180 degrees also, but that has now gone into advanced disease. So I'm not going to go into all of these, but what I want to show you is that if you start at the top, right, it says for resectable, no involvement, no involvement. And if you come right at the bottom at ND Anderson, you say any involvement without occlusion. So these guys say that if the vein is narrowed on both sides, it is involved, it is encased, as long as it is not occluded, we can go ahead and resect. So there is a wide variability starting from no involvement to contact with no irregularity to less than 180 degrees to unilateral narrowing to no or to total almost total occlusion as long as there is a lumen. So this is again very confusing for us as radiologists, and you have to decide what is your institutional preference. However, again, as radiologist, if a surgeon asks you, by NCCN criteria, what is it? So you have to be able to know what the criteria are. Advanced disease, of course, means that either the artery is involved more than 180 degrees or you cannot reconstruct the vein. Now, reconstruct the vein is different for different people, and we will also look at reconstruction of vein. So just to recapitulate, for resectable disease, you can go from no involvement to any involvement without occlusion, but we usually go with the NCCN, that it is either no contact or less than 180 degree contact. And how does this translate for us into real life, right? So if you look at this tumor, okay, so only by these three criteria, this is totally resectable. Okay, by these three criteria, they will accept this as totally resectable. The NCCN will take this also as resectable. The IAP consensus will take unilateral narrowing as resectable, and MD Anderson will accept this also as resectable. So what you need to do is either you should have a template which should tell you that I will do no, I will just write that there is no abutment, less than 180 degree abutment, unilateral narrowing or bilateral narrowing without occlusion, or whatever your institutional preference is. But from a literature point of view, what I'm trying to tell you is there is a wide variability in what we will take as completely resectable. For borderline resectable disease in venous, there is more or less a consensus that anything that you can reconstruct, provided it does not involve the first jejunal vein or extend below the inferior border of the duodenum, is taken as resectable disease. So what is the first jejunal vein? We come back to our anatomy. So this is the superior mesenteric vein. This is where the gastrocolic trunk comes in. This is what is known as the ileal vein, and this first vein which comes from the left side and joins is the first jejunal vein, which is usually also at the level of the inferior margin of the duodenum. What you must know is the first jejunal vein can go either behind the SMA, this is the SMA, either it can go behind the SMA or it can go in front of the SMA. So not to be confused by this seems to be going behind, this seems to be going in front, you can have a variability. That is the duodenum, that is the upper margin, the mid portion of the duodenum and the inferior margin of the duodenum. There is also a classification system which says resectability according to where the lesion is located in the duodenum, but that would confuse matters, I think, a bit too much. It is already too confusing. But I just wanted to show you what the first jejunal vein looks like and how you see it according to duodenum. You can also look at the duodenum in the coronal plane. All right. So they say anything that can be reconstructed. So as radiologists, we must know a little bit of how reconstructions can happen, so that if the surgeon asks us, can I reconstruct this or not, you have a little bit of an idea about what he can do, so that you can guide him. So if there is a small abutment, you can just tear the vein, you can take off a bit of the vein and suture it. You can do an cut off a little bit of a vein and do end-to-end anastomosis. This would generally mean around 1.5 centimeters. Some surgeons can push it to 2. But if you have more than 1.5 centimeter of involvement, generally you would not like to tell the surgeon that you can do an end-to-end anastomosis, or you could do a primary closure. He would then probably have to do something like a tangential resection, or you have to resect a segment of the vein and put in a graft. So surgeons can do all of these. Again, it depends on your institutional preference and what your surgeon is comfortable with doing. Once you sit down and talk with your surgeon, are you capable of doing this? Are you capable of doing this? Are you capable of doing this? Then you will have a better idea of how to talk about resections. What is borderline resectable disease as far as arterial involvement goes? Less than 180 degree of SMA involvement. For common hepatic artery, you should be able to reconstruct. And for celiac, no contact or less than 180 degree of contact, depending on what you're using, right? Most surgeons will not like to touch the patient upfront if you say that there is tumor around the SMA, even if it is less than 180 degrees. They would like to send this patient to a neoadjuvant CT or RT or both. So our last topic is locally advanced disease. When do you say, no, I don't think this patient can go in for a surgery. You have to put this patient on palliation. So if you have anything your surgeon cannot reconstruct, remember we looked at what all reconstructions they can do. If the surgeon says, I cannot reconstruct this, then obviously there is venous involvement, non-reconstructible. It is locally advanced. Most surgeons will never touch anything that involves the first jejunal vein or involves the SMV below the inferior margin of the duodenum, right? Most surgeons. But here is a patient. You can see that this is the first jejunal vein. The ileal vein is involved. It has a tumor thrombus in it. There is, as you can very clearly see, no involvement of the SMA. But the SMV is almost occluded, right? Just look at this. The SMV is almost gone. There is a thrombus over here, but the first jejunal vein is preserved. So there is a whole paper that says that, even if you have either the ileal vein or the jejunal vein, which is patent, you can still go ahead and resect. This is just to tell you what all can be done. I would never suggest you tell your surgeon to do this or that this is an acceptable treatment. However, there are papers that say that either the jejunal vein or the ileal vein, if you can keep even one of them patent, your patient has a chance of survival. And you must remember that these patients have a 5-year survival rate of only 5% if you don't give them an R0 resection. So that is why there is so much of literature, there is so much of talk, and that is why I am also talking in this and I have been asked to talk, because there is a dramatic difference in life expectancy of patients who have an R0 resection versus those who don't. Okay. So SMA more than 180 degree contact, CHA non-reconstructible, celiac axis more than 180 degrees is locally resectable disease. So remember, arterial involvement is more important than venous involvement when you're looking at resection, unless there is involvement of the first jejunal vein or there is involvement of the SMV below the margin of the duodenum. And here is the duodenum, upper, mid, and lower duodenum. This is how we look at it. Okay, so arterial involvement is much more of an issue for surgeons because A, you cannot resect the artery, right? And secondly, the issue is also that there is a neural plexus around the artery, which we will also look at just now. Okay, in NCCN criteria, remember that I said that there is a different criteria for body and tail. Okay, and this is an older criteria which they have now revised and put this into unresectable disease. But if there is celiac axis involvement without involvement of aorta and patent GDI, you can resect So how can you resect this patient who has a celiac axis involvement? I mean, can you remove the entire celiac axis? Will the patient survive? Let's look at and see if this is possible. Here is a patient. This is the celiac axis. There is a tumor here which is involving the celiac axis. The aorta is not involved and the gastroduodenal artery is not involved. So the tumor is basically over here and this portion is all free. So this is a patient from our institution. This patient has had a celiac axis removal and you can see that the celiac axis is no longer present. There is a collection here in the pancreatic bed. The head is spared and the GDA is providing supply through vascular anastomosis to the hepatic artery proper and the left and right hepatic artery. So this is what is known as an Appleby procedure. So if you have an intact celiac axis, so you have an intact GDA, sorry, with involvement of the celiac axis, you can go ahead and attempt this. This is again not a very usual procedure to be done, but however, still carried out at certain times when the patient has celiac axis involvement and no metastatic disease, right? So that is why the NCCN has a different criteria for body and lesions versus head lesions, because you can go ahead and do this procedure. Okay. So I know that was a lot of information, lot of criteria, but if you have no contact with the vein and artery, it is always resectable. Nobody will say it is not resectable. If you have involvement of the first jejunal vein, it is always unresectable. Nobody will say that I'll resect this, right? If you have more than 180 degrees SMA involvement or celiac axis, it is always unresectable. And everything else goes to either neoadjuvant therapy or it goes to this line, how brave is your surgeon? Okay. So in summary, this is what we are looking at. So now there are lots of differences between various systems. Again, most differences in opinion occur in venous involvement. I'm not going to really go into much more of this because we will now, like I told you, NCCN has a separate criteria and we've also seen why it has that. Right. Now, what about neoadjuvant chemotherapy? Now, once you said this patient has borderline resectable disease, is our role over? Does the patient go away and that is the end of it for us and we can say, okay, now that this is your problem? It actually doesn't happen like that, right? So resectable patients with high risk features and all borderline resectable patients go for neoadjuvant chemotherapy according to the NCCN guidelines. So this patient generally will come back to you after the end of the CT-RT. And how do you decide now whether you tell this patient to go in for, tell the surgeon that you can take this patient for resection, or you say, no, this patient has not done well after neoadjuvant CT-RT. I would not recommend that you take this patient up for surgery. So there should be no metastatic disease in the interval, right? There can be mild increase in perivascular soft tissue. It is not a contraindication to resection in the setting of clinical improvement. So if a patient is doing well and there is mild or minimal increase in soft tissue, you can say, okay, you can consider these patients. Patients who have a stable or reduced CA 19.9 and no clear radiological progression. That means that the tumor has not increased in size and the CA 19.9 is reducing. For borderline resectable patients, even if you see that there is venous thrombosis, if it is reconstructible, it is not a contraindication to surgery, right? Patients with locally advanced disease sometimes may be considered with significant decrease in CA 19.9, great clinical improvement and no increase in tissue may also be considered for resection following neoadjuvant chemotherapy. So this is not an exact science. In the future, we are looking at things like perivascular halos. We are looking at reduced ADC of the tumors. We will look at reduced SUV max on the PET. We will look at increased tumor attenuation on CT. We can look at perfusion characteristics. All these can help us to decide in the future. There is literature coming out. How do you decide whether this patient has gone for whether this patient should be taken up for surgery after neoadjuvant CT-RT or not? Without that, this is how we look at it. Okay, this is how we decide in our institute and how literature says we should look at it. So you see this patient who has a big tumor here in the head of the pancreas. There is marked narrowing, almost complete occlusion of the superior mesenteric vein over here. Okay, same thing over here. There is a lot of tissue, and you can see this would obviously be very difficult to resect. After neoadjuvant CT and RT, you can see there is mild opening up of the tissue over here. Very, very subtle decrease in tissue over here. All right, and this is actually fantastic response of the CT-RT. Normally, you do not see even this much of clearing. So even if you get this much of subtle improvement, if the patient CA 19.9 is going down, if the patient has improved clinically, these are the patients who you say, yes, this patient has responded favorably to CT and RT. Remember, we are used to looking at tumor regression with the RECIST criteria, with the WHO criteria, where the tumor shrinks by 25%, 50%, etc. That is not going to happen in pancreatic tumors with a neoadjuvant CT and RT. You will, at the most, if the patient responding very well, you will get subtle changes like this. So look at this patient, look at the mild decrease in tissue, look at the mild increase in size of the portal vein. So you will get things like this. You will get subtle openings up. You will get little bit of increase in lumen. You will get the fact that tissue will not increase. The patient will be clinically better. The CA 19.9 will drop. And these are the patients who we as radiologists will say have good response to CT and RT and should be taken up for resection. Okay. Now, that is now coming to the next part of our talk. So remember, we said that there should be solid tumor contact with the artery or vein or the vessel to say that there is contact. What are the other side types of contact, right? You can get subtle haziness like this. Is this contact? Well, it could be a desmoplastic reaction. There could be a subtle pancreatitis. There could be lymphatic involvement, and there could be perineural spread. So perineural spread is something that I would like to talk about a little bit more. There are two peripancreatic neural plexuses. One that goes for, in the interest of simplicity, one that goes along the GTA to the common hepatic artery, then goes to the celiac axis. One goes from the posterior, in fact, inferior pancreatic or duodenal artery along the SMA, right? So that's the article in case you want to look at it some more. So what is the significance of these peripancreatic neural plexuses? Okay. So look at this patient who has a tumor in the head over here, but there is soft tissue even on this side of the SMA. So has the tumor actually gone all the way through? No, you can see the tumor is very well localized over here. But what you see is this perivascular rind of soft tissue. Okay, this perivascular rind of soft tissue, when you see it, this generally means that there is a perineural spread of tissue. If you see a cuff of thickness, a cuff of tissue more than 2 mm in thickness, it is almost always perineural spread, and this is a bad prognostic factor. Okay, this is actually tumor which has gone around the artery. So if you go ahead and resect the tumor over here also, this patient is not going to do well. And this is something that you should be looking at both around the SMA as well as the celiac axis, because this is a bad prognostic factor. And if you see it, generally our surgeons will not take this patient up for upfront resection, because these patients will almost certainly recur. Okay, so to keep a lookout for this is another good article in case you want to look at it. You can also have perineural spread from the tail of the pancreas, but it is more common around the head. Okay, so here is a patient who has a resectable pancreatic carcinoma only in the head. The vein and the artery were both free, right? But this patient has a celiac axis, marked celiac axis narrowing and stenosis due to a median arcuate ligament syndrome. And here is where the surgeon gets a googly. If you want to do a Whipple's procedure, I'm sure you all know that you have to tie off the GDA, right? When you tie off the GDA, this plexus, which is giving blood to the common hepatic artery, etc., will be tied off. So what will happen sometimes is that when you do a Whipple's, as soon as you tie off the GDA, the liver will start becoming ischemic. So when I was very, very young, this happened to me once, and since then I always look at the celiac axis. And in our institute, we always look at the celiac axis for resectable pancreatic head carcinomas. And if we feel there is a significant celiac axis stenosis, we will ask the surgeon to do a celiac axis release during surgery. This is another patient who has a resectable CA pancreas. You can see the artery and vein are far away. You do see something here though. Let's look at what that is. So here is the tumor, the vein is here, the artery is here, everything is far away. The tumor is really over here. But again, you see something going off from here. So always look at your right hepatic artery, particularly where is it coming from, what is happening, right? In this patient, this part of the artery was coming really close to the tumor. So we had to tell the surgeon to be very, very careful about whether this artery was involved or not. Even if this artery was not involved, normally what the surgeon does is they go ahead from the common hepatic artery, they see this coming down, they will generally think this is the GD and tie it off here. But because this posterior hepatic artery is arising from almost the GDA, we would tell the surgeon that try and go here and ligate it. So anatomical variations for arteries is something that you should be looking for very, very carefully. This patient had a small tumor, periampullary, which was resectable. This was going to go in for a Whipple's procedure, but in this case, the entire common hepatic artery was replaced to the superior mesenteric artery. You can see the celiac axis is here. It is dividing into the splenic and the left gastric. And what was more difficult for the surgeon was that this artery was coursing through the head of the pancreas. So he could not resect the head of the pancreas without sacrificing supply to the liver. So they actually had to shell this pancreas out. This caused pancreatitis. Then this patient had a pseudoaneurysm of this artery, had to be embolized, but finally survived. So again, anatomical variations can have a huge role to play when you're talking about resectability. It is not just anatomy of the tumor, it is anatomy of the other vessels as well. Here is another patient who had a tumor in the head of the pancreas. Okay, that's a well-defined mass in the head of the pancreas. This was again resectable, just abutting less than 180 degrees. So for us, it was resectable. But what you see is variant arterial anatomy. The right hepatic artery is replaced to the superior mesenteric artery, closely related to this tumor along its superior aspect. And over here, you can see it is involved. Okay, so we did tell the surgeon this, we did see this. But like I told you, the layer of resectability is such because the survival benefits are so much that this patient then went ahead and had a resection. Post-operatively, he had a bit of a stormy period, and you can see there is no right hepatic artery which is filling on the arterial phase images. Okay, and patient also had a small infarct, but the patient did survive. So going ahead and taking the risk was worth it. So in conclusion, the anatomic criteria deciding patient management in pancreatic carcinoma rarely rely very heavily on radiological inputs, and thus all patient management decisions should be taken by MDT, in which the radiologist should have a prominent role. The distinction between resectable, borderline resectable, and non-resectable disease at the end of everything is generally institutional specific, and it is also how comfortable you are with your surgeon and how comfortable your surgeon is doing surgeries. After some time, you should develop a bit of a rapport and know whether you should be sending this patient for upfront surgery or whether you should be saying for neoadjuvant CTRT or whether you should be just sending this patient for chemo. Thank you very much for your attention. And I'll take any questions if you have any.
Thank you.
Thank you.
Thank you for this absolutely wonderful talk, and not only the theoretical aspects, literature review, but the practical insights which you gave that were really awesome, and that will definitely come if we have an experienced panelist like you on the panel. So thank you once again. Right now, the questions are not there, but I would request you to please stay back for 5-10 minutes because they might come in the chat box.
Seem to have confused everyone thoroughly. No
yes.
questions.
Okay. Yeah. So you can write down the answers in the chat box, sir, if they just come in the next few minutes. Yeah. Thanks once again. So after this practically implied talk on deciding the resectability of the pancreatic ductal adenocarcinoma by Dr. Samarjit Human, let's move to the next speaker for the day. And before this, just wanted to remind about the upcoming breast imaging masterclass for all of those who are interested in breast imaging. This will be on 7th and 8th of May 2022, and we'll be releasing the brochures soon. Registrations have started, and this will be covering every aspect of breast imaging from the X-ray, mammogram part to ultrasound to interventions, MR, etc. Also, the 21st MRI teaching course, we are announcing the dates. It's August 6th, 7th, 13th, 14th. And this time it's going to be an extensive and hybrid event. So the first few days will be completely online, and the later half of the conference, that is 13th and 14th, we'll have online with on-site. So a good opportunity to meet our experts. And also, if you are not able to fly to Mumbai, the venue, you can still be online with us. Registrations are open, and I have shared the registration link on the chat box. We have an absolutely amazing offer for registration of you. If you are in a group of 4, you get a good discounted rate. And poster paper submissions are also there, and the last date for the same are 31st July 2022. With this, let's move to the next speaker, Dr. Professor Andrea Laghi. He is a professor and chairman, Diagnostic and Intervention Radiology, Sapienza University of Rome, Sant'Andrea Hospital, and a board certified nuclear medicine expert, vice president and executive committee of European Society of GI and Abdominal Radiology, past president of European Society of Oncologic Imaging. He is honorary member of Spanish Society of Gastrointestinal and Abdominal Radiology. He is the author of over 260 papers on peer-reviewed journals and 20 textbook chapters. Sir will be talking about response criteria in immunotherapy. Thank you, sir, for being with us today, and over to you.
And at first, let me thank Professor Parkar and the entire organizing committee for inviting me to be part of this Oncoimaging Update 2022. My name is Andrea Laghi. I'm professor and chairman of radiology at Sapienza University of Rome. So before discussing my lecture, let me show you where I work. I work in Rome, which is the capital city of Italy. You know Rome probably from the Vatican City, from the Colosseum. Those are located here in downtown. Unfortunately, my hospital is a little bit far away from downtown. It is located in the north part of Italy near the highway. The hospital is a mid-sized hospital, brand new, with more than 450 beds. Around 1,000 healthcare professionals work on the hospital, more than 500 doctors. We have an emergency room, which is number 5 in our city, with 58,000 patients per year. Our excellencies are thoracic surgery, number 1 in Italy, with more than 1,300 operations per year. Orthopedic surgery, you probably remember the victory of our national football team during the last European Championship in England. And this guy here is our orthopedic surgeon, who is also the orthopedic surgeon of our national football team. And of course, we have a very strong medical oncology. Our radiology is located in 2 different floors, main department and the emergency room, and we are well equipped with modern scanners. Now, let's go back to my topic, response criteria in immunotherapy. So why do we need objective criteria? Well, this is a need which was recognized by researchers a long time ago. So it was in 1979 when cytotoxic drugs were used for oncologic patients, when the WHO decided to release the first objective criteria. So criteria to make the assessment of response to therapy as more objective as possible. Those WHO criteria were updated by the RESIS committee in 2000 when the RESIS 1.0 criteria were released, updated in 2009 with the RESIS 1.1. All those criteria are based on changing tumor size. They are all built for clinical trials, not for assessing routine day-by-day evaluation of patients. And also the threshold defined by the different criteria are arbitrary thresholds. What is important that based on those criteria, we can categorize, or the oncologist can categorize patients in 4 different categories. Complete response, where there is a disappearance of the lesions. Partial response, where we have a reduction in size of the total tumor burden. Progressive disease, where we have an increase in size of a tumor burden, and the stable disease, when the criteria, they do not meet either the progressive, the partial response, or the progressive disease. Now, what is the main difference between WHO and RESIS criteria? Well, in WHO, the total tumor burden is the sum of the areas of the different target lesions. So for each single lesion, you have to measure both the longest and the smallest diameter. So you consider the area of the lesion. The total tumor burden is the sum of the areas of the different lesions. RESIS criteria made a dramatic change. They consider only the longest diameter. So the total tumor burden represents the sum of the longest diameters of the target lesions. Now, moving from a 2D to 1D analysis can be considered a downgrading, but it is not, and I will explain you why. So let's consider this lung cancer. Lung cancer, and we measure at time point 0 the longest diameter and the smallest diameter, 4 centimeters and 3 centimeters. So the area is 12 square centimeters. So at time point 1, we have another reader, and the measurement is 4.6 centimeters and 3.45. So the area is 15.8 square centimeters. So if we consider the difference between the 2 time points, we have a 32% increase in size. So this patient should be considered a patient in progression, because the cutoff defining a stable disease from and differentiating a stable disease from a progressive disease is 25%. So we calculate an increase in tumor burden of 32%. So it means this is a patient in progressive disease. You should stop the treatment of that patient. But this was a joke, and this image is exactly the same of this. So I just made a joke to show you how important is the measurement, and how the variability is affected by small errors in the measurement. But if we consider the same 2 lesions, but according to RESIS criteria, so according to the single dimension, the measurement of single dimension. So for example, we consider only 4.6 and 4 centimeters, so the longest diameter. Well, the difference is 15%. So there is still the same error in the measurement, but because we consider only 1 diameter, at the end, the calculation is plus 15%, which according to the cutoff for progressive disease of RESIS criteria, which is more than 20%, this patient is categorized as a stable disease. And in fact, since the image is exactly the same, the image on the left side and on the right side, this is in fact a patient with stable disease. So why the single measurement, the monodimensional measure is important? Because it reduces inter-observer variability. It makes our measurements more robust and more reproducible. And this was also demonstrated in another paper published more than 10 years ago, where the authors asked a group of radiologists to measure lung tumors within 15 minutes. So repeat the measurements to analyze the difference in the measurements on the same image by the same radiologist with a difference in time of 15 minutes. And what is interesting, of course, most of the radiologists, they measure more or less the same. So in most of the cases, there is not a change, but there were a small group of radiologists. When they re-measure the image, they increase the size by more than 20%. So it means that if you consider those two images as a potentially two different time points, those patients could be categorized as a patient in progression, although they are not, because it is exactly the same joke I did with you before. To minimize the inter-observer variability, now we have software which automatically measure the images, the lesions, and we can only they can support us in to reduce our variability. The other important point that the cytotoxic drugs had the cytotoxic effect. So the effect was a reduction in size of the lesion, but now we have anti-androgenetic drugs, for example, they reduce vascularity and not the size. So let me show you another example. This is a patient with a previous nephrectomy for renal cancer with metastasis in the lungs and at the level of the pancreas. So this is a large lesion on the pancreatic tail. After 3 cycles of sunitinib, both lesions, the largest one and the smallest one, are more or less the same size. So in terms of difference in total tumor burden is from 18 centimeter to 9.3 centimeters. So an overall reduction of 15%, which, as you know, it does not categorize that patient as a partial response because you need a reduction of more than 30%. But if you look at the images, they are very different. Size is smaller, but particularly you see that the density is much lower. So there is a reduction in the angiogenesis. Now, if you consider the RECIST criteria, of course, you should categorize this patient as a patient with a stable disease. But if you change criteria and you use, for example, the CHOI criteria, where you do not consider only the size, but you consider also the density of the lesion, if you have a decrease in size of more than 10% or a decrease in tumor density more than 15%, as in this case, this patient is categorized as a patient in partial response and not a patient with a stable disease. So it's always a matter of the criteria that you choose. And the same applies to immunotherapy, where you can have an increase in size of the lesion because of a tumor progression. You can have a decrease in size of the lesion because of a tumor response, but you can have an increase in the size of the lesion because of pseudo progression. So colonization of the lesion by inflammatory cells, which are good cells, this is not an increase in size because of the tumor progression, but because there is a treatment which is working. And this is extremely important because if you consider only the size and you consider this as a progression, then the patient should stop treatment. Let me show you an example from real life. This is a patient with an hepatocellular carcinoma undergoing treatment with avelumab, one of the available drugs in the immunotherapy. So I don't want to show you the images. Let me show you the tumor burden. Time point 0. Time point 1, so plus 18%, still a patient in stable disease. Then time point 2, so we have an increase of more than 20%. So this patient is in progression. If you consider the RECIST criteria, progressive disease, you should stop the treatment. The treatment goes on, and at the next time point, the patient has a stable disease because there is not big difference with the time point 2, but at time point 4, we have a clear decrease in size also compared with the time point 0. So this patient is in partial response. So this explains you what are the differences between immunotherapy and conventional therapy. So the evidence of a measurable anti-tumor activity may take longer than conventional cytotoxic drugs. So the discontinuation and early discontinuation of immunotherapeutic agent can be inappropriate. And of course, we can observe a treatment response or a partial response after a progressive disease, which is impossible with RECIST criteria. So this is the reason why RECIST criteria are inadequate to assess the response to therapy in patients undergoing immunotherapy. So for this reason, many years ago, in 2009, one researcher at that time immunotherapy was experimental for melanoma, for patients with melanoma, metastatic melanoma. He tried to modify the WHO criteria, defining what? First, new measurable lesions are incorporated in tumor burden. So if for RECIST criteria, a new lesion equals progressive disease. Well, according to the immune-related response criteria, a new lesion, measurable, so it means more than 5 millimeters, should be included in the tumor burden. So at that time point, you should sum up all the target lesion plus the sum of the diameters of the new measurable lesion. And again, a new non-measurable lesion is not considered a progression. Of course, the evaluation was still bidimensional, so you have to consider the area. And what is important, another concept, when you categorize a patient as a complete responder, partial responder, or patient with progressive disease, you should confirm, always confirm what you observe with another examination after 4 weeks. Of course, the immune-related response criteria had limitation because they were developed for patients in trials with immunotherapeutic agents in patients affected by melanoma. So they could not be applicable to other solid tumors. There were uncertainties about to consider lymph nodes. And of course, the bidimensional evaluation, the highly permissible number of lesions, were making the fact that these criteria had a poor reproducibility, inter-observer variability was extremely high, and they were also extremely time-consuming, so they could not be used outside clinical trials. This is the reason why in 2013, another author decided to modify the RECIST criteria. So they considered the same concept why we moved from WHO to RECIST 1.0. So they started considering only the largest diameter. And they also consider, according to the immune-related response criteria, that new lesions, they do not define progression, that the measurements of new lesion were included in the sum of the measurement, and they needed a confirmation at 4 weeks. So those were the so-called immune IR RECIST, immune-related RECIST criteria. At this point, there was a little bit of confusion because there were many criteria in place, and it was in 2017 when the RECIST committee decided to release the so-called iRECIST, so the modified RECIST 0.1 for patients undergoing immune-based therapeutics. So what are the iRECIST, which is now considered the best criteria to assess response to immunotherapy in clinical trials? First of all, the definition of measurable, non-measurable disease, number, and size of target lesion are exactly the same as per RECIST 1.1. The only point is that when you evaluate a new lesion, you record separately a new lesion, but you do not consider a new lesion a progression. When you have an unequivocal increase of a non-target lesion, is not immediately a progression, and this is exactly the same if you have a progressive disease of target lesion, when you have an increase in tumor burden more than 20%. So these criteria create a new category. The new category is named immune unconfirmed progressive disease. So what does it mean? It means that you have one of those three situation. Then you put the patient in this category, then you rescan the patient at 4-8 weeks, better 8 than 4. And then at that point, if the patient is still progressing, well, at that point, it becomes immune confirmed progressive disease. Otherwise, you can have a different evaluation. I will show you an example with a graphic, which is much simpler. So time point 0, time point 1, increase in tumor burden at 10%, stable disease. Time point 2, increase in tumor burden more than 20%, progressive disease, according to RECIST. According to iRECIST, you put the patient in this new category, immune unconfirmed progressive disease. Rescan the patient at 4-8 weeks. After 4-8 weeks, you can have still a progression, and so at that point the patient is progressing. It, of course, it leaves the trial, or the patient can remain more or less in the same situation. So it will remain in this situation of immune unconfirmed progressive disease, or it can reduce dramatically the size, the total tumor burden, and it becomes a partial responder. So you can have a partial response after a progressive disease, which was not possible using RECIST criteria. Another important point to consider when assessing the overall response at immunotherapy is the so-called best overall response, IBOR, which is the best time point response recorded from the start of the study treatment until the end of treatment. Now, let's see an example from real life. This is a patient with a melanoma with some pathologic tissue in the retrocranial area on the right side. This is a location of melanoma. You see the uptake on the FDG, so no doubts about that. Time point 1, marked reduction in the size of the tumor, but a new lesion in the spleen. And the lesion was not there at time point 0 because the CT was negative and the PET was negative as well. So this is a true new lesion. You record this lesion outside the tumor burden, but you consider a new lesion, immune, unconfirmed progressive disease. This is the new category. This is not a progressive disease. This is immune, unconfirmed progressive disease. Patient has a clinical benefit from the immunotherapy, and then we rescan the patient at 4-8 weeks, and the lesion has completely disappeared. So this is the reason why we should use iRECIST, because in this case we can avoid stopping the therapy, which has a clear benefit for the patient. There are only a few papers comparing the iRECIST with other criteria. This is a paper comparing iRECIST, immune-related RECIST, and RECIST 1.1 in patients with non-small cell lung cancer. And what is important is that RECIST 1.1 underestimates the benefit of immune checkpoint inhibitors in 11% of the progressive patients, whereas the other two, the iRECIST and immune-related RECIST criteria, have a better evaluation. What to do in clinical practice? Well, in clinical practice, we need to be more practical. Of course, RECIST and iRECIST are developed for clinical trials. In the real life, you have to consider case by case, because sometimes it cannot be justified an extensive use of a confirmatory CT. Of course, you do not have only imaging. The oncologists, they do not have only imaging to see if the patient is responding or not. In some specific cases, you should use a confirmatory CT. Otherwise, you can go on with your current approach. So this was for pseudoprogression. The other opposite situation is the hyperprogression. What is the hyperprogression? It's a paradoxical acceleration of tumor growth kinetics after the initiation of treatment. What does it mean? I have a patient in progression with a conventional therapy. I start immunotherapy. At this point, rather than decreasing the size of the tumor burden, I have an increase in tumor burden. But I consider this as an hyperprogression only if the acceleration is high. If the patient has the same kinetics, so there is no acceleration, so the progression is stable, is continuous, well, in this case, this is a conventional and normal progressive disease. If I see an acceleration compared with the kinetics before treatment, start of the treatment, then I can define it is as a hyperprogression. So how to define the kinetics? There are different algorithms or mathematical algorithms to calculate the hyperprogression. I have no time to enter into different details. What is important is that you see in the literature an extreme variability in the incidence of hyperprogression, and the variability depends on the fact that if you use one definition, for example, in this paper, one definition, B, you have an incidence of 5% on the same patient population. If you use a different definition of hyperprogression, then you can say that the incidence is high, up to 18%. So you have to be very careful. The incidence of hyperprogression is not very high, and the variability in the incidence depends also on the way the authors calculated the acceleration in kinetics. So we need to standardize the definition. That's an important point to understand better the real impact of the hyperprogression. And just to give you an idea, this is a patient with lung cancer with therapy with pembrolizumab at 5 weeks, and then at 12 weeks we have an explosion of the disease. Another important situation is the so-called dissociated response. So a mixed response. Now with the therapy and the combination of immunotherapy and conventional therapy, we see more and more dissociated response. What does it mean? It means that you have in the same patient some lesions which are reducing their size, some other lesions are increasing in size. There are no predictors. We cannot predict the patients who undergo a dissociated response and those who do not. The incidence is around 8–10%, still very difficult to say the real impact of dissociated response. We also don't know what to how to interpret the dissociated response. There is a paper, a recent paper from Japan showing that in patients with a dissociated response, the overall survival is better compared with patients with a true progressive disease. And that's important. That's reasonable, because in dissociated response, it means that there is a heterogeneous response of tumor to therapy. Some clones of cells are good responders, some others are bad responses. So at the end, probably the overall survival is definitely better compared with a patient with a clear clones of cells who are progressing without any difference. Now, that's what we can say with our criteria, iResist, which are the best criteria that we can use for assessing response in clinical trials. Of course, we need more. We need more in the future because we need a shift from morphology to function. We need to explore tumor vascularity. So I mean, we need to use more and more MR perfusion. Or CT perfusion or dual energy CT perfusion. We need to define and derive imaging biomarkers of perfusion to assess the response to therapy. We need to explore more tumor cellularity, for example, by using diffusion weighted imaging or intravoxel incoherent motion. So you can assess the response to therapy based on the modification of the ADC value, as in this case, rather than size. This is a large metastasis from colorectal cancer on the left of the liver. It is very dark on the pre-anti-androgenetic therapy. It maintains the same size after therapy, but it is very bright. So it means that there is a necrosis of the cells because the drug is working properly. Unfortunately, there are no data on perfusion, DVY, IVIM, and immunotherapy at the moment. The other point is radiomics. It is very popular. Radiomics, the creation of a radiomic signature, a mathematical signature of a tumor, to compare the signal of the tumor with the overall survival, with the prediction of the response to therapy. There is a very interesting paper from a French group who analyzed the different phenotypes of tumors, the so-called immune-inflamed, immune-excluded, and immune-desert. And you know that the immune-inflamed are those who respond better to therapy. So the question was, is it possible to identify immune-inflamed tumor based on radiomics? And without going into details, they were able to define that the patient with the definite radiomic, specific radiomic signature, showing that those are immune inflamed, have a better overall survival compared with the other tumors. So radiomic seems working, although of course there are limitations of the study, the heterogeneous cohort, and other secondary points. There is also another interesting paper in more than 1,000 patients with advanced melanoma and non-small cell lung cancer undergoing anti-PD-1 therapy. And again, the immunotherapy response could be predicted with a good accuracy, particularly using radiomics, which was much better than using the volumetric measurements. And that's true for both non-small cell lung cancer and melanoma tumors. Of course, we have to be careful with radiomics because all that glitters is not gold. There are some papers showing that there is an extreme variability in the features that we can collect. So stable features were detected in only 11% of the cases in a study from the States. And this is the heat map from our own study showing that there is extreme variability in the different radiomic features, only modifying the iterative reconstruction filters on our CT images. So in conclusion, radiologists need to be aware of the mechanism of action of new oncologic drugs, in particular immunotherapy. The assessments of response to therapy should be performed by specific criteria. In immunotherapy, pseudo and hyperprogression are uncommon, but they are real, so they affect the value of conventional RECIST criteria. And for the future, we expect important advances by functional images and radiomics. And with this, I thank you for your attention. Goodbye.
Thank you, sir, for being with us and for this absolutely wonderful talk on a relatively newer topic. We come across this, but we never take into the details of these and the advances. So thanks once again. With this, it's time to go ahead with the schedule. And we have with us our next speaker, Dr. Hemant Patel, sir, somebody who does not require any introduction, our past national president of Indian Radiological and Imaging Association, who had been instrumental in shaping the shape of IRIA and making it more reachable to the residents and young radiologists. He is Executive Counselor and Chairman, Education Committee, Asian Oceanic Society of Radiology, Executive Council Member of International Society of Radiology, an eminent radiologist, academicians, exemplary leader, and professional sportsman too. He's working as a director and consultant radiologist and professor at Gujarat Imaging Center, Ahmedabad, and he has served as vice president of IRIA, secretary, joint editor for IGRI as well. Several awards and orations to his credits. And we are thankful to him for taking out time, and the topic he's going to take is multi-parametric MRI of prostate. Before we go ahead, I would request Sikandar sir.
Good morning, everyone. Welcome, Hemant sir. You don't need any introduction, but for me, you are like one of my mentors in putting forward so many things what you have inculcated in academics. So with this short, I welcome you, sir, and over to you, sir.
Wonderful morning, and thank you so very much, Mitusha, for a kind introduction. And Sikandar, as usual, you know, you are ever energetic and great work as usual. And my best wishes to Oncoimaging Masterclass series. And today we are going to discuss about. Should I scare my?
Yes, sir. Yes, sir.
Okay. We will discuss about MP-MRI in the prostatic cancer, and as you know, prostatic cancer is. Can you see the screen? Okay.
Yes, sir. We can see your screen.
Okay.
Yeah.
So, as you know, prostatic cancer is a very common entity, and even the layman, they are also knowing about what is the PSA level and what should be the normal limit. There was an entire dedicated article in the Time magazine also on the prostatic cancer. Even if you go in the park, old gentlemen, they may be discussing about their PSA level and the values and what should be done further. There are many tools in radiology and clinically also and pathologically to check for the CA prostate. Most common is of course PSA and then the sonography, PSA density, lesion score, CT, MR, bone scan, and we need to check it out. What is the best tool as on today? Because digital rectal examination was the only tool available clinically few years back. If you look back, just feeling as the hard nodule, surgeon could, detect that this is the CA prostate, but now the data says that it's only having sensitivity of the 14%. Other thing is the PSA, of course, it's a very good marker, which will tell that, something is going wrong with the prostatic gland, but it doesn't say that, this is the CA prostate. It may be because of the prostatitis or some other reason also. So that is not the specific tool for the CA rectum. Sonography, of course, we do all the biopsy of the prostate using the sonographic guidance. At the same time, for the detection of cancerous nodule within the prostatic gland, sonography is not the best tool. I will tell you why. And as usual, biopsies, they are the final answer for any pathology. Same is true with the CA prostate. But here we are doing the blind biopsy, and there are so many negative biopsies, and it's in a big range. So as on today, so ultimately we confirm with the biopsy, but there are a lot of chances biopsies will be negative, even if patient is having the CA prostate. What is the wrong with ultrasonography? First of all, how the lesion look on sonography. Usually it appears as a hypoechoic or the dark lesion in the peripheral zone. And this is, when you see such kind of the lesion on sonography, transrectal sonography, mostly we are dealing with the CA prostate. Now the issue is then when the lesion, this lesion is isoechoic or the hyperechoic, then we cannot detect on specifically on in CA prostate cases. The hard fact is that when the lesion is more hyperechoic, then it's a more malignant or the more aggressive kind of the tumor, right? So we may miss the isoechoic lesion. We may not be sure about the hyperechoic lesion. So the sonography is not a good tool for detecting the CA prostate. Of course, we can take help of the sonography for guided biopsies. CT, on other hand, CT is a gold standard for almost all abdominal pathologies. However, for CA prostate, there is practically no role of the CT except to look for bone metastasis or when you are planning for the radiotherapy. Otherwise, there is no role of the CT. Now, on other hand, MR is an extremely good tool. Why? Because we can see the anatomy completely beautifully, minutely using the MR. You can just see, the peripheral zone, the central gland, fibromuscular stroma, all the structures we can discriminate beautifully, especially when we are using the newer technique, newer sequences, and higher strength MR. Then the images are even better. So MR, as on today, is a gold standard for the detection of prostatic cancer nodule. There was some inhibition from the radiology community, those who were doing the MR but not started doing the CA prostate evaluation, because they thought that it has to be have the prostatic MR is done only with the endorectal coil and related preparation. But now with the higher strength, with the phase direct coil and many new sequences, there is no need for the endorectal coil for the prostatic evaluation, and we can detect almost all the lesions within the prostate using the routine conventional MRI and the newer sequences. As far as preparation is going, then there is nothing specific preparation except we can ask patient for 4-hour fasting if needed. Bowel movement is more, then we may give the injectable buscopan. Otherwise, not much preparation. The common indication to go for the prostatic MR, when the prostate cancer is discovered by biopsy, and now surgeon, they need further information for the staging of the cancer. There is the top-notch indication as on today. When it's suspected from the PSA and surgeon is asking you to evaluate further, and on that basis they will do the biopsy, which is the emerging trend as on today, and we are looking forward that this will be the main indication down the line. When there is the history of negative biopsies, when the PSA level is high, biopsy turned out to be the negative, then still it's a very rocketing high PSA, it's a sustained raised PSA over a period of time, then there has to be despite of the negative biopsy, we can go for the MR examination, and we can check it out whether there is a CA prostate there or not. And when patient is operated for the CA prostate with the radical prostatectomy, and now there is recurrent PSA level, we need to check about whether there is the recurrent tumor is there or not, and we may go for the MR. So these are the basic common indication for going for the MRI prostate in the cancer suspected cases. Now, how it looks on MR, the prostate gland itself, it gives the extremely good discrimination. As I said, the peripheral zone, which is bright on the T2, having the more fluid content, and it's very easy, and this is the area where most of the cancer occurs. 80% of the cancers of CA prostate, they will be lying in the peripheral zone. This is the central gland, and most anteriorly, this is the anterior fibromuscular stroma. Now, fibrous tissue anywhere in the body, it appears dark. So this is the dark, which is lying anteriorly, and this is the fibromuscular stroma. Peripheral zone, it appears bright because of the higher fluid content, and here it may be the bubbly appearance because of normal hypertrophic gland. So it's very easy anatomy on the MR: peripheral zone, central gland, and anterior fibromuscular stroma, right? So apart from this, we have to identify the prostatic capsule and the surgical capsule, which is easy to identify on MR. Another two important structure to identify, that is the neurovascular bundle. Why? Because there is the extension of the tumor, especially the T3 tumors. They will extend into the neurovascular bundle in the 5 o'clock or the 7 o'clock position. So we need to identify on the anatomy, and this is the typical appearance of the neurovascular bundle in the 5 o'clock position. Another important structure is seminal vesicle. We need to cover in all the studies when we are doing the MR prostate evaluation. Okay, now here these are the same patient, two data set, T1 weighted, T2 weighted, on T1 weighted. Just like CT, we can't discriminate or differentiate the various zones and the intrinsic anatomy of the prostate. We can't say which is the peripheral zone, central gland, anterior fibromuscular stroma. On other hand, using the T2 weighted sequence, we can see beautifully this is the peripheral zone, central gland, anterior fibromuscular stroma. So fundamental sequence for prostatic MR is T2 weighted sequence, and then after we can go for diffusion weighted sequence and rest of the sequence. The role of the T1 is very limited, except when you are dealing with hemorrhage or you want to check out the post biopsy hemorrhage. So now how they look on MR when there is the CA prostate. Just like sonography, in sonography this is the peripheral zone. Whenever there is the CA prostatic nodule, you see the hypoechoic lesion. Here similarly there is the dark lesion on T2 weighted sequence on MR in peripheral zone. So this, it appears dark on T2 in the peripheral zone when there is the CA prostate. In this case, there are two nodules, discrete nodule, one on the right side, one on the left side. Now, one important thing is, if the darkness is mild, moderate, or intensely dark, there is the proportionate cancerous nature of the lesion. I will show you the example here. It's in a mild to moderate dark lesion. In other case, there is the intensely dark lesion, right? So such kind of the more darker the lesion, it's a high grade cancer. If it is the low or the intermediate, it may be the low to moderate intensity of the cancer. Now coming to the multiparametric MR, here we are taking help of one structural imaging, that is the T2 weighted, and three other parameters, which are the diffusion weighted, spectroscopy, and the dynamic contrast enhancement. So we take help of all the parameter, then we sum it up, and we can suspect that this patient may be having the high chances of CA prostate, this patient is not having the cancerous tissue. On that basis, we can ask surgeon whether to go for biopsy or not. That is the main purpose of multiparametric MR. And so what is the role of the diffusion weighted? We are very well aware the role of the diffusion in rest of the body structures, especially the brain and liver and many other organs. Here also it is playing the very crucial role. Whenever there is the lesion, cancerous CA prostate, we see the diffusion restriction on the high B value images, and it appears dark on the ADC images. MR spectroscopy, in brain, you see the choline, creatinine, and Na. Here in prostate, there are some difference. There is the choline, creatine, and the citrate. Now, the citrate is secreted by the normal prostatic fluid, right? So, when you in the normal gland, you put the voxel, and you will find such kind of the tall citrate peak. Whenever there is the CA prostate, there will be the suppression of the citrate, and you can see the increase or the raised choline peak. So this is the normal MR spectra of the prostate. In cases of CA prostate, there will be the complete separation of the citrate peak, and you can see the tall choline peak, right? So here in the case of CA prostate, there is the reversal of the graph. Another important parameter, there is the dynamic contrast enhancement, and here we give the gadolinium at very high rate using pressure injector, and we check it out for the washing and the washout of the contrast, right? If it is at the rapid pace, then there is the highly possibility of having the CA prostate, right? This is the typical example here. Pre-contrast, dynamic contrast enhancement, you can see the early washing of the contrast and wash out of the contrast. We can typify them by giving the various curves, and we can check it out into the type 1, type 2, or the type 3 curves, right? Here is a very rapid washout. When you see such kind of the type 3, and it's a highly possibility of having the CA prostate, right? So there are the curve 1, curve 2, and the curve 3 in cases of the dynamic contrast enhancement. I'll show the example now, using all the parameters. 58-year male who presented with the raised PSA value. Here what you see on T2 weighted is a intermediate to moderate dark lesion involving the left posterior aspect peripheral of prostate. The same lesion is showing the high B value and the ADC dark. Post contrast dynamic, you can see the early washing of the contrast. So it's a very highly and likely CA prostatic nodule. The same patient, when we did spectro, there is the suppression of the citrate and reversal of the graph, and it turned out to be the adenocarcinoma. Another patient, 79-year male with the raised PSA value, you see the diffusion restriction of the lesion in the right part of the prostatic gland, and it appears dark on the T2 weighted. Again, there is the reversal of the graph, and post contrast also there is the washing and the early washout, and it turned out to be the adenocarcinoma. Other patient on the left posterolateral aspect, there is the protruding lesion which is now breaching the prostatic capsule, showing the diffusion restriction, and this lesion was extending into the 5 o'clock position in the neurovascular bundle. So now any lesion which is extending beyond the prostatic gland, it falls into the T3 category of the tumor. Now T3 is again divided into the T3A and T3B. In T3A, when you see the irregular capsular focal protrusion, that is the T3A, when you see the extension into the neurovascular bundle or rectoprostatic angle obliteration, they all falls into T3A. When the lesion is extending into the seminal vesicle, then it will be the T3B lesion. I'll show the example. Here there is the irregular capsular focal protrusion here on the right side, T3A. Here there is the neurovascular bundle extension. I also showed you the one case before also. And this is the T3A. These all are the example in the 5 o'clock or the 7 o'clock position extension into the neurovascular bundle infiltration, stating that it's a T3A variety of the tumor. Same with the rectoprostatic angle obliteration, and it's a T3A. But when you see the lesion, this is the right sided normal seminal vesicle. On left side, these are the, it's very easy to identify seminal vesicle on MR. You see the bubbly appearance on the T2 weighted sequences. And here, what you see is the extension of the dark tumor into the seminal vesicle, and this is the T3B variety of the tumor. So here, these are all various example when you see the extension of the tumorous tissue in the seminal vesicle, and it's a seminal vesicle invasion, and now the tumor will be upstaging into the T3B. So now coming to radiology part and how to report CA prostate. As on today, we all are reporting on the basis of the PIRATES, and the PIRATES is a prostatic imaging reporting and data system. This was established by European Society of Uroradiology to standardize the report method, and to overcome that limitation, it was again revised into 2015 by American College of Radiology, European Society of Radiology, and Admitech, and it comes now the PIRATES version 2. Recently, in 2019, there was again some revision, and it was the PIRATES version 2.1, right? So the role of the PIRATES, when you just sum it up the score of different parameters, and if it is stating that this is more likely when it is the PIRATES 4 and the 5, then surgeon will go for the biopsy. If it is PIRATES version 1 or 2, we can simply wait and watch and don't do anything, right? So that will be on the basis of PIRATES, neurosurgeon, they will decide what to do further in given case, whether to go for biopsy or not. So there are major changes in the PIRATES version 2. Now we already said bye-bye to MR spectroscopy. We are not using it any further. So there is now no need to check it out for the choline and the citrate related graphs, because we are just simply using rest of the parameters, but not MR spectroscopy as on today. Similarly, in the dynamic contrast enhancement, now it is more simplified. Previously, as I said, there was type 1, type 2, and the type 3 varieties of the curve. If type 3, it's more suspicious. Now there is no such kind of the complexity there. Here, now it is more simple, whether it is positive or negative. And of course, there is the concept of the dominant sequence. Here, in dominant sequence, when the lesion is lying in the peripheral zone, diffusion weighted sequence is a primary sequence. If the lesion is lying within the central gland, T2 weighted is a primary sequence. And of course, we can take help of the other parameters as and when need. Okay, we'll go into the detail. But when the lesion is lying in the peripheral zone, then the diffusion weighted sequence is a primary driver, right? It's a dominant sequence. So when you on diffusion weighted, when you don't see anything, it's a PIRATES 1. When there is the diffuse increase in the signal, but no focal feature, then it will be PIRATES 2. When it's indeterminate, it's a PIRATES 3. When you see the focal area with the diffusion restriction, and it is less than 1.5 centimeter, then it's PIRATES 4. The same lesion, if it is more than 1.5 centimeter, then it is PIRATES 5. 4 and 5, they need biopsy. 1 and 2, don't do anything. PIRATES 3, we can take help of T2 weighted dynamic contrast enhancement, and on that basis, we can again upstaging the tumor, or we can downgrade the tumor, right? So we will take help of the dynamic contrast enhancement in all these PIRATES 3 kind of the lesion. Now, if the lesion is lying in the central gland, now here the T2 weighted is a primary driver, and there is the main dominant sequence. So on the basis of T2, when it's a kind of the heterogeneous normal adenomas, it's a PIRATES 1. When you see the area of the low signal but well-defined contour in the transition zone, that is the PIRATES 2. When there is indeterminate kind of the lesion, then it's a PIRATES 3. We'll come back this to later. When the lesion is having charcoal or the lenticular shape appearance with the very smudgy margin, then it is more likely to have the cancerous nodule, and that is the PIRATES 4 if it is less than 1.5 centimeter. The same kind of the lesion, when it is charcoal shine having maybe the lenticular shape or the water drip lesion more than 1.5 centimeter, it's a Pirates 5, and these both are the malignant kind of the nodule, and we go for the biopsy. Here Pirates 1 and 2, no need for the biopsy. When the Pirates 3, now here we take the secondary help from the diffusion weighted sequence, and if diffusion is suspecting malignancy, then we can upstage the tumor into the Pirates 4 or 5. When it is saying there is no chance of the malignancy, we will downgrade the lesion into the Pirates 2, right? That's how it works. So the primary driver for the peripheral zone is the diffusion weighted sequence. If needed, we will take help of post contrast, and we will do the dynamic study and characterize the Pirates. When the lesion is sitting into the transition zone, T2 weighted sequence is the primary driver. If needed, we will take help of diffusion weighted sequence. So to memorize this, make it more simple, it's a PDTT, so peripheral zone, diffusion weighted, transition zone, it's a T2 weighted sequence as a primary driver. So I will show the some example later on, but in 2019, recently there is some revision in the Pirates version. Now it is known as the Pirates version 2.1. Here, major changes they are in the technical parameters that now limitation. Number of the sequences are limited now than the before. T2 weighted, there has to be at least one axial image of the T2 is a compulsory now. Diffusion weighted, now more clarification about the B values and less variability. Dynamic contrast, technically the temporal resolution is having the less than 15 second is advised, and 3D T1 weighted gradient is a preferred method, right? So it's more of a technical parameter related changes into the Pirates version 2.1. Things are going for the less and less sequences, and now there is also a lot of research in the biparametric MR where we are just using the diffusion weighted and the T2 weighted. On that basis alone, we can complete the examination, and we may eliminate contrast study in down the line in very near future. So all the lesions when we are looking at the prostatic gland and showing some abnormality on the diffusion or the T2, they are not cancer. We need to be aware about other pathologies which may mimic like cancer, like prostatitis, or there may be the enlarged confusing central gland nodule or exophytic hyperplastic central gland nodule. There may be the post biopsy hemorrhage, fibrous band. Actually, when they are thick, we may get confused whether it's a malignancy or the benign. So we need to check about all the other possibilities also. I will show the example. 26-year man who presented with the prostatitis, and on T2 there is the V-shaped ill-defined T2 hypointensity in the peripheral zone, and this is the typical appearance of when you see the large V-shaped area, young age patient, and having the clinical features of the prostatitis, it's easy to diagnose on the MR. When you see such kind of the multiple nodes within the prostate, these are the benign nodules. And you see look at the peripheral dark band which is sharply demarcated. These are all the benign lesions, right? So don't confuse them with the CA prostate. These are though it's an enlarged central gland nodules, but they all are benign. Sometimes you may find such kind of the nodule which is lying at the junction of the transition zone and the peripheral zone, and this is but always look for the thin dark band which is indicative of the benign lesion. Many a time you may find such kind of the nodule which is pushed into the peripheral zone like this here, but still if you look at the capsule which is completely intact, and this is the hyperplastic nodule, but it's a benign and not the malignant. This is the T1 weighted sequence, and as I said, the role of the T1 MR is only to check for the post biopsy hemorrhage if you need to check it out. So here what you see here, this is the T1 weighted and this is the post biopsy hemorrhage. Don't confuse this lesion on T2 or the diffusion for malignancy. Such kind of the thin fine bands, they are very much benign and nothing further is needed, no need for biopsy. But when you see such kind of the dark thick irregular band, and such lesion may be typified for the Pirates version 3 and we may need to give the contrast and do the further characterization. If needed, we may go for biopsy. Now, coming to the post-operative status, when the patient has been operated for CA prostate with the radical prostatectomy, and now further there is a rise in the PSA after few months or the few years, then there has to be some sort of the recurrence. Otherwise, there is no business for PSA to reappear again. So the common sites for the recurrent CA prostate is a perianostomotic. That is the most common. It may be the retrovesical or sometime into the retained seminal vesicle. So what is the modality of the choice? Sonography, it's already operative status is there. Distortion of the anatomy, you don't see, it's very difficult to discriminate the many structures lying in the post-operative status. It's not a good tool. There is, I don't advise to go for the sonography for recurrent CA prostate. What about MR? MR is a good tool, but again, post-operatively, it is not that easy that what we can do pre-operatively. There is no role of pirates reporting in the post-operative status, right? So that is only to decide before the operation. After the operation, it's a different ball game. Here, the role of MR is also limited, and we may take help of the diffusion weighted sequences. And if it shows restriction and the early enhancement, this is the diffusion weighted showing the recurrent tumor. But the best modality as on today in 2022, that is the prostate specific membrane antigen PET-CT. I'll show the example. 50-year-old male operated for the CA prostate. Now there is the rising PSA, and there is the abnormal structure in the pelvis on CT, PET-CT, PSMA. It's showing very avid kind of the recurrent lesion at the anastomotic site, and there are also bony metastases seen in the pelvis, also in the spine as well. Now PSMA is having the different tracer than what we are using in the PET-CT, regular PET-CT, which is the FDG. Here there is the DOTA generator, and we are also having an in-house DOTA generator and doing in the afternoon session for a CA prostate recurrent evaluation, but it's giving extremely good result. I will show you the other example here. The patient was operated. Now again there is the rising PSA, and on gallium PSMA, what we found is a small node. This is the recurrent metastatic lymphadenopathy from CA prostate, which is not appreciated at all on the CT alone, right? So if you do the CT or the MR, we may miss such kind of, the node which are active metabolically, and it's a metastatic lymph node, though it may be less than 1 centimeter or 1.5 centimeter, and also there are associated bony metastases. This is the last case, and very interesting case. A 62-year male who had a radical prostatectomy 1.5 years back, and now there is the increasing PSA value. So neurosurgeon, they referred for the PET-CT. We did FDG PET-CT, and there was subcarinal lymphadenopathy, which was metabolic. FDG avid node, quite large size. Only thing, locoregionally there was no lymphadenopathy, no metastasis in that given region on PET-CT. Then there is no business directly, it will come to the subcarinal region. So we are also skeptical. We spoke with the neurosurgeon, and he said, I also am not convinced. Then we did the PSMA, and on PSMA there was no avidity was seen in the subcarinal lymph node. So now we were sure this was the granulomatous lymphadenopathy, not the prostate related metastatic node. So again, back to the square. Then why there is increase in the PSA value? Then we found on this same study, there was the metastatic lymphadenopathy in left iliac region, and which was proved by biopsy also. And PSMA is the only sensitive modality to check for the recurrent CA prostate. And now, finally, what is the future direction? Though we have already started doing the MR and sonography fusion, and then the biopsy. One study we are doing with the Muljibai DDIT and Nadiad Kidney Institute, and the results are very encouraging, and I'm sure it will be a very common practice. Though it is not available as on today here in India, but I'm very sure within 2 or 3 years, in-bore MR-guided biopsy will be the best tool to do CA prostate biopsy, not the sonography guidance alone, right? So many new things and the exciting things they are coming in the coming future also. So to conclude, MPMRI is a state-of-the-art technology for the non-invasive detection, localization, and characterization of prostatic cancer. IRIS version 2 is mainly all about the concept of dominant sequence. If lesion is in the peripheral zone, then diffusion weighted is the dominant or the primary sequence. If lesion is lying within the central gland, then T2 weighted is the primary driver. So diffusion and the T2, they are the main sequences for staging of the cancer. Be aware about the prostatic mimics like the prostatitis or the fibrotic band or the post-biopsy hemorrhage. MRI and prostate specific membrane antigen, especially the PSMA PET-CT, they are the ultimate tools for CA prostate recurrence. Thank you so very much.
Thank you so much, sir, for that excellent talk, and thank you for joining us. Sir, if you could just be around for a couple more minutes and just answer the questions in the chat box if at all they do come up.
Sure, definitely.
Let's move on to our. So you can stop. Can you stop sharing your screen, please? Yeah. Let's move on to our next talk for the day. We have with us Dr. Harsh Mahajan, sir. Sir is a consultant and founder of Mahajan Imaging. He's been awarded the Padma Shri honor in 2002. Sir is the former president of IRI. He's the director of Department of Nuclear Medicine and bone densitometry at Sir Gangaram Hospital. Has served as the honorary radiologist to the President of India. He's the honorary consultant to the International Atomic Energy Agency. He's on the board of advisors of Rishihod University. Sir's topic is AI in oncology. It's an honor to have you with us, sir. You may please share your screen.
Thank you very much. It's indeed an honor to be speaking here today. And following my good friend Hemant, who gave us a master class really in prostate imaging. And I'll take you to some other areas which are unfolding on a daily basis as we speak, and these are going to transform the way we practice radiology. Today, I'll talk on artificial intelligence in oncology, and really, I say the way forward. Now, artificial intelligence as a term was coined way back in the 1950s. It's not a new concept. It has gained recent popularity, and basically, it is because of the fact that computers have become so fast. Each of us carries a supercomputer in our pockets, our cell phone, and basically AI is using high-end computing to find hidden patterns in data, and there is a significant overlap with the field of computational neuroscience. What are the types of artificial intelligence? We have artificial narrow intelligence, where you teach the computer one task and it becomes excellent at it. And this is a very famous picture when Deep Blue, the IBM chess computer, beat Garry Kasparov, the world chess champion, many years ago. Then we have artificial general intelligence. This is where human beings are. This is the emerging field, the next frontier. And this is when you teach the computer one task, and on its own, it's able to learn other tasks. And this is actually how human beings also learn. And then there is this concept of artificial superintelligence, when, robots will rule the world. This describes the point in time when AI becomes stronger than humans and the world is divided about its possibility. Then there are two broad categories of AI applications. One is what humans can do, but AI can do better or faster. And this we see on a daily basis. Humans can monitor CCTVs, but maybe only 10, 12, 15, whereas using AI, you can monitor thousands and hundreds of thousands of them. And then also another example is Google Translate. Humans can translate language, and many amongst us who are evolved may be able to translate 5, 6, 10 languages, but Google can do it much better, much quicker. And then there is the category which humans cannot do, something that AI can do, but humans cannot do. And this is an example of something we use on a daily basis, our Google Maps. There is no way that humans can match AI in this. Now, artificial intelligence is based on learning or training, which is the fundamental basis of all AI today. It's a traditional technique, and most healthcare AI is focused on this. It is labor intensive. We need to have excellent ground truth with high accuracy. Better the ground truth, better the AI algorithm that is developed. And examples are chest X-ray algorithms, where we use thousands and hundreds of thousands of labeled images. The labeling, the better it is, the better is the AI that you will develop. And if we see this example, if we look at 3, now 3 can be written in various ways by different people. And so more heterogeneous the data, more heterogeneous or multiple ways in it is written in, it is easier for us to develop a very, very vibrant AI algorithm. Similarly, when we develop an AI algorithm, if we develop it on data obtained from one hospital, then it may not be as robust as when we take it from multiple hospitals, multiple kind of patients, multiple machines. And so one thing to remember is that more heterogeneous the data, better your AI algorithm will work in day-to-day clinical practice. Now, how is an AI algorithm developed? First, we have to find data, which is the most important step. Find as much heterogeneous data as possible, like I said, that addresses the problem that you're trying to solve. Then using this data, we have to train the model. The data is generally split into a half training and half validation data sets. The algorithm finds patterns itself on training data, and AI algorithm is developed. Then we have to validate the data. The trained model is validated on the balanced data, the half that we had left separate, and summary statistics are calculated. And this is where, we get all the newspaper headlines where they say, AOC, area under the curve, is 0.99%, 0.98%, and people claim all kinds of accuracy. But remember, you have validated the data on the same data on which an AI algorithm was trained, and hence it is likely that it'll be highly accurate. But actually, the proof of the pudding lies when this AI algorithm is used in other hospitals, other areas, and that is called testing the model. The trained data set is tested on data from a completely new site or hospital, and that's when you realize that this claim of a 95, 98% accuracy actually is not so good, because probably the data wasn't trained on a heterogeneous data set. And so this is the reason why we see a lot of AI algorithms being developed, but very few being in use. And this is something that has to be set right. So finding data, training the model, validating the model, testing the model, and we call this pre-test deployment. And then you can actually deploy it in the clinical field. Now, coming to the radiology scenario itself, the radiology value chain, AI has potential to impact at every level, and we will see that patient scheduling and preparation, scanning and image acquisition, processing and analysis, and then finally the holy grail, the diagnosis, which is what radiologists do. Now, if we talk about patient scheduling and preparation, this is a paper 2018, Machine Learning for Predicting Patient Wait Times and Appointment Delays. This is one of the grouse of the patients that come to radiology settings, especially for MRI, where, because we may end up taking more time on booked patients, patients have to wait. And that creates problems. Now, here is an algorithm that has been developed which very accurately can tell you which patient will have to wait what time, and you can actually do some permutation combination changes to be able to accommodate this. And this is from Mass General Hospital in Boston. Now, the other thing, we book patients throughout the day, and some of them do not show up. This is an AI algorithm which has been developed predicting scheduled hospital attendance with artificial intelligence. And surprising though it may sound, it can quite accurately tell you which out of those 30 patients that you've booked is not going to show up. So it's helping even in this area of radiology. Now, then we talk about scanning and image acquisition. And this is one of our papers which we presented in ISMRM and the ECR 2019, virtual MR imaging, predicting T1 and diffusion-weighted brain images from T2-weighted MR images. And these are examples. And it was very surprising for us when we came across what this AI algorithm was able to do, and probably it'll have a role to play in oncology, in infections, in day-to-day clinical radiology. This is a 74-year-old with sudden onset left-sided numbness. And here what we see, this is a chronic infarct, an area of ischemic demyelination, which this is true diffusion, that's T2, true diffusion, virtual diffusion. And here, this doesn't show up as bright. And we were surprised to see that on virtual diffusion, which is only seeing this bright lesion on T2, it doesn't show up as bright. And what was the cause? There is something mild hyperintensity here, hardly visualized. On true diffusion, this showed up as bright, so there is an acute infarct there. We were surprised to find that even on virtual diffusion, it showed up. And so this is an indicator that maybe in the future we may need to do just one or two sequences, and AI sequences, AI algorithms may be able to reconstruct the other sequences based on these input data. These are some other cases. Again, this is a case, multiple chronic ischemic lesions. There is, of course, this lesion here in the region of the thalamus, just above the thalamus. And true diffusion, that's virtual diffusion. A small infarct in the head of caudate nucleus also picked up on diffusion-weighted images. And you have to believe me when I say that only the T2 were shown to the AI algorithm. So this has a lot of connotations for the future. Then further, in the field of oncology, this again we presented at the, I think this was ECR or RSNA, and a synthetic PET generator for lung nodule detection by showing the AI algorithm only CT images. And we call this synthetic PET, generate PET images from CT of the lung. And there were, I won't have time to go into the methodology, but these are the images. This is the input CT image. That is a true PET where you see these multiple areas of uptake on the PET. And this is a synthetic PET. This has been created only by showing the AI algorithm the input CT image. And this was an algorithm developed by us again in 2018-19. Another example, that's the input CT image. This is true PET, and that's a synthetic PET. And yet another case here showing. So is there a possibility in the future, after we've done a deep dive, after maybe other people have worked on this possibility, that we may be able to use AI with CT scans to show you PET CT images? That's another case, just to show that in this case, PET CT also showed uptake in the mediastinal region, which wasn't shown on the true PET. So all is not gold, and a real deep dive will have to be used before we can bring this into day-to-day clinical practice. Then improving image quality using AI, do a low resolution image, and using AI be able to create a high resolution image. On a 1.5, be able to create 3 Tesla-like images. On a 3 Tesla, be able to create 7 Tesla-like images. And this is something which we worked in collaboration with Subtle Medical out of USA, and this is already a product that's available and functioning in many parts of the world. So, of course, as a radiologist, when cleaning up of images happens, we are always concerned that did it clean out some subtle abnormalities as well. But here, this is already FDA approved, and you can see. So a 1 minute image being, giving you the resolution of maybe a 3 minute image. And this was a few years ago, 2019, using very low radiation dose, noisy images. GE was able to reconstruct pristine quality, diagnostic quality images at much lower radiation dose. And this was cleared by FDA 3 years ago. Moving on to processing and analysis. And here again, this is with our partners, Predible in Bengaluru, where AI can do automated liver, vessel, and tumor segmentation and give you the volumes. All of this done automatically. Here, the tumor segmented out, the vascular anatomy, all of this done by the AI. And so this can help the radiologist to do the work much, much quicker and maybe with more accuracy in the months and years to come. This is fully automated brain tumor segmentation, which is done using AI algorithms. This is from Wang et al. And here again, deep learning for variational multimodality tumor segmentation on PET CT. This is from Sloan Kettering. And here again, you can see pink is the manual and blue is automated using AI. And, you can see that they are very, very close to each other. Then to the Holy Grail, diagnosis, something which concerns all of us as radiologists, because we tend to feel that will our work get taken away? Will computers replace us? We've gone over this time and time again. We spoke at the RSNA on the same very topic. 2018 it was, when Dr. Vasant Venugopal from our group spoke about it in the Airy Crown Theatre. And actually, this will work as a radiologist's helper. There is no way that radiologists are going to get replaced, but it is going to make radiologists better, more consistent, more accurate, and help us in turning around much quicker the cases. Maybe if today we report 30, 40 MRIs, we may be able to do 70, 80, or 100, and those who report 100 may be able to do 200, 500, God knows, in the years to come. This is our paper along with Cure.ai, our collaborators out of Mumbai. The first paper to be published in the Lancet on AI in healthcare. This is automated detection of critical findings on an NCCT head. And this really showed that brain hemorrhage, fractures, all of these can be shown very well. And I've already shown you that it is now also working in brain tumors. Hopefully, in the months and years to come, we will even not only be able to segment brain tumors, but also characterize brain tumors into malignant and non-malignant, and even into the various varieties based on AI algorithms. Then triaging leading to case prioritization, where the case with critical findings actually rises to the top of the list so that a radiologist reads that scan first rather than, in its own place. So something with a critical finding coming up to the top of the heap and being read very quickly, there are alarms that can be put in which can, tell the technologist or the radiologist that someone with a critical finding has been screened. Then automatic generation of text reports by artificial intelligence. Can AI generate clinically appropriate X-ray reports? Judging accuracy and clinical validity of deep learning generated reports as compared to reports generated by radiologists. This is a retrospective study from our group, and this was presented and also at the RSNA, and also picked up by Aunt Minnie in 2019, where they said AI doesn't hedge when reporting on chest X-rays as much as what radiologists do, could be, should be, maybe possibilities which we tend to write. AI uses those terms much lesser. This is again another paper presented by us at ECR 2019 along with our collaborators, Credible, where we looked at nodule characterizations automatically detected by artificial intelligence as benign or malignant, and then compared with the three radiologists. Radiologist accuracy and AI accuracy was nearly similar. In fact, AI accuracy was slightly better than radiologists at predicting whether a nodule on a CT scan was benign or malignant. Prostate cancer, and this is work which has been lent to me by Quibim, which is out of Valencia in Spain. And we know prostate, we've had a talk just now on prostate cancer. Now, this is an AI algorithm, a solution that improves the accuracy of prostate cancer diagnosis in a fast and more generalized way to deliver safer care. We do know prostate cancer is a scourge. There are many unnecessary surgeries or invasive procedures that are done. Then there is, in many parts of the world, a shortage of specialist radiologists to report prostate MRI using the PIRADS classification. And this is a MRI-based screening and early detection tool. And this is called QP Prostate, an automated AI tool for fast, accurate MRI reporting. It picks up and segments different parts of the prostate, the peripheral, the central, and it automatically detects the lesion, gives automatic prostate size and volume, and multiparametric MRI and biparametric MRI protocols. Both are accepted, and it gives a structured report like this on its own. Of course, it'll have to be validated by a radiologist, but where the lesion is, what the volume, size, what the possibility, the PIRADS classification, all of those done automatically. This is AI-based automated segmentation. This is analysis, and it highlights the area where there is a large T2 abnormality within the left peripheral zone, extending from the apex to the base. And of course, there's a focal bulge you see of the prostatic capsule. All of these things picking up on its own. That's another case with a biopsy positive result out here, which again it picks up, and it actually marks out everything. A Pirates 5 lesion, which it picks up and correlates with biopsy, even helps in making the biopsy. Having said all of this, possibly mammography will be the first oncology application of AI. These are certain papers, and this actually has come into day-to-day clinical use as a second read, and not just digital mammo, but also MR mammo. And this is from Penn Medicine, which predict 10-year breast cancer recurrence with MRI scans. AI, we feel, will also lead to integrated diagnostics. And what is integrated diagnostics? Combining pathology, radiology, and genomics. There is a mutual interdependence, but there are limited touch points. We still work in silos, whereas what we need is deeply integrated workflows. We need to communicate. We need to move beyond the traditional radiological pathological correlation. And so we believe that in the future is the role and the field of integrated diagnostics. And I feel that a radiologist who is used to using all of the technology that's available, we are used to computers, we are used to playing with data, I feel the radiologist will be best suited to become this higher, more exalted entity of an integrated diagnostician, for want of a better word. There will be this department of integrated diagnostics in the future, in which, and some of it in oncology has already started. We already have integrated tumor boards, and this is from Sectra, where on the same screen you have the mammo, you have the biopsy, all of this together, the MR mammo, all of this can be shown together. The radiologist, pathologist, side by side, viewed together, instantly resolve any discordances, provide a reconciled report in all concordant cases. This improves quality, reduce risk, and has instant potential in breast cancer. So what you'll have is a single patient-centric window, even for the clinicians to see. And frankly, all this digital integration has already started. Development of online cancer patient assistant pathway technology platform to provide treatment guidance even for cancer patients in developing countries. So not only will it help the diagnosticians, the radiologists, the pathologists, the genomic specialists, but will also help the oncologists in treatment. The future really is radiogenomics, where genomics data, detailed imaging data, PET, CT, MRI, X-ray, ultrasound, and clinical follow-up data will all be put together into machine learning systems and will come out with the answers. Does the future of screening and preventive health checks lie in integrated diagnostics? An example is genetic risk, the exome sequencing using next-gen sequencers, acquired risk with detailed history taking, smoking, tobacco, exposure, viral infections, all of that, current status being given by whole body MRI plus other imaging that may be necessary after whole body MRI is done, and giving an answer to the questions generally asked by patients. Do I have cancer right now? Which we will be able to answer with the whole body MRI and imaging tools. And what is the breast screening protocol for me using the genetic risk profile with genome sequencing? All of this put together, the data will be fed. And so the hospital of the future will certainly have an integrated diagnostics department, which will liaise with the clinical departments. And here you will have the diagnosticians, the radiology, pathology, genetics, biochemistry, and a clinical information specialist to boot. And personally, I feel the radiologists of the future need not worry about AI coming in. They need not worry about this conglomeration that is going to happen, because they would be best suited to evolve into this new role of an integrated diagnostician. So this will have integrated diagnostics institute, will have computational sciences, innovation, diagnostic optimization, population health, which is, again, even in India, we've started talking about it, disease-based departments, oncology, neuro, cardio, whatever, and clinical diagnostics, imaging, pathology, and genomics, all together into an integrated diagnostics institute. We've taken our own step towards building this, and this is our new center where we have 3 MRI scanners in the basement, along with a spectral CT, molecular imaging with a PET CT, solid state PET CT, gamma camera, on top all the X-ray, ultrasounds, mammo, above that AI, genomics, routine pathology, lab, and then on the top teaching, training, about a 30,000 square foot facility, all things under one roof. That is what it actually looks like right now. And this was the Vice President of India who 2 weeks ago to this day inaugurated this facility. And some of what came out, and we are also building the world's first end-to-end validation, deployment, fine-tuning platform for medical AI, and we hope that this will help taking AI from the bench to the clinic. And what does the future hold for young radiologists and physicians and radiologists? AI will certainly work as radiologist's assistant, improving productivity and quality. It will replace radiologists for certain areas of reporting, normal, abnormal chest X-rays, normal, abnormal head CT, normal, abnormal brain MRI. It will also help clinician read scans, and this is where it may lead to turf erosion. The radiologists of the clinicians are very excited about these AI tools, maybe more than radiologists. They want to use them very quickly, and here it will lead to turf erosion. But like I said, the field is open for radiologists. We need not despair. It will help in reading scans in underdeveloped parts of the world with limited number of radiologists. It will impact teleradiology providers and armchair radiologists who never meet the patient or physician, as there is no human face to the radiology report. And this is very important. I think most of us of my generation keep saying to the younger lot, don't sit in your offices, don't sit in your homes and report. Meet the patient, see the patient, talk to the physician, become a part of the day-to-day clinical treatment team in a hospital. Then AI will not replace you. AI will only help you. But if a radiologist is only a written report, just similar to what an AI generated report is, then it may be very easy for AI to replace radiologists. So be clinical radiologists, be part of a larger team. There is still questions regarding liability of AI generated reports as to who would be liable. Of course, one thing is certain, that the report would have to be written out or would have to be signed out by a radiologist as things stand today. But things may change if the clinical colleagues say that they don't need a radiologist's intervention. So we have to be careful in the future. But one thing is certain, it'll definitely improve turnaround times and reduce healthcare costs. So, in conclusion, I'd like to say, especially to my younger colleagues, radiologists who are listening to me, and this I quote Jack Welch, the legendary chairman of GE, who said, change before you have to, before you are forced to, and also control your own destiny or someone else will. These are some of our collaborators, including Stanford, Mass General, Harvard, our own IITs, Max Planck Institute, JNU, then the GE, Philips, NVIDIA, and the startups, Kibim, CureAI, Lunet. Kibim is from Spain, CureAI is from Mumbai, Lunet from South Korea, and Lunet has done very, very well, and we did help them. Our group, Carpal.ai, for their FDA approvals, credible, parallel dots. So the other fact of life of the future as of today is that we need to collaborate. We should not work in silos. Let's collaborate, collaborate, and collaborate. And that's when we will remain relevant in the months, years, and decades to come. Thank you so much for giving me this opportunity. It's been an honor to speak at this forum. Thank you.
Thank you, sir, for the excellent talk and making it so simple, this artificial intelligence in oncoimaging. Thanks once again. And sir, if you could stay here for 5 to 10 more minutes and answer the questions in Q&A section, it would be grateful. Thank you, sir.
Thank you very much.
So moving forward to our next lecture, before that, I just want to inform you that our masterclass breast imaging will be on 7th and 8th May, which is an online venture, and 21st MR teaching course in August 2020. Its registration link is in the chat box and you can register for that. So our next speaker is Dr. Akshay Kumar Saxena. Sir is a professor, Department of Radiology, PGI Chandigarh, and he is in Central Scientific Committee, Indian Society of Pediatric Radiology, and he has more than 143 publications in index journals and 7 book chapters to his credit. Sir has been awarded with Sir J.C. Bose Memorial Oration of IRI and Dr. Arcot Gajraj Oration in ISPR 2009. Sir's today's topic is malignant hepatic tumors in children. We welcome you, sir, and over to you.
Thank you so much. And let me share my screen. Let me just do it. Okay. I hope my screen is visible and I'm audible.
Yes, sir. Yes.
Okay. So after the very advanced discussion from Dr. Harsh Mahajan, let's come back to the malignant hepatic tumors in children. It's not doing okay. I've got no financial disclosures to make, and I've got no conflict of interest to report. What I'm going to discuss in this particular webinar is when confronted with a suspected malignant tumor in a child, what exactly is the role of the radiologist? What are the imaging modalities available to you to kind of live up to your role? And we certainly will discuss imaging morphology of common malignant lesions of the liver in children. So, what would be the role of the radiologist? You got to identify in a fresh case or confirm in a case where the lesion has been reported earlier, the presence of the mass. So either you identify or confirm a previously reported lesion. You characterize the lesion, whether it is solid, cystic, mixed kind of a lesion. Do the staging and or the extent, whatever you want to call it, for the benefit of the treating team. You provide a diagnosis and differential diagnosis if needed. You may frequently be called upon to do an image-guided FNAC or a core biopsy. If during the treatment the patient develops some complications, you will be called upon to help the clinicians in diagnosing those complications, sometimes even managing them. and after the patient has received chemotherapy or has undergone surgery, you would be expected to monitor the response to the treatment. So this exactly is where you stand. These are the roles which have been assigned to you. And for carrying out these roles, the imaging modalities which are available to you, I'll discuss them one by one. So let's start with the plain cells. Well, long story short, these are not useful at all in the current era of imaging. They may show displacement of bowel by the malignant hepatic mass. In the case of hepatoblastoma, you may be able to see calcifications overlying the liver area. But by far and large, you're not going to kind of diagnose a malignant hepatic lesion on a plain X-ray. So exactly what is the role? Well, you may encounter an X-ray done for some other reason and the patient has an incidental or a known malignant lesion, and then you will be called upon to identify these findings and include them in the report. The next imaging modality is the ultrasound, and this is the initial investigation of choice. This is very easily available in our country. It's cheap. There's no ionizing radiation involved, which is a major advantage when imaging the children. This is because ionizing radiation gives rise to carcinogenic damage to the child, and the child may develop cancer at a later date. Why the children are more sensitive? It is because of the two reasons. One, they have got rapidly dividing tissues, so they are more sensitive to the damage by the ionizing radiation. Two, they've got a very long lifespan to manifest the effects of that damage. If you give the same amount of ionizing radiation to a 60-year-old versus a kind of a 2-year-old child, the 60-year-old may have a lifespan of say 1 or 2 decades, but the child has got a lifespan of 7 to 8 decades to manifest those damages. So the child has growing tissues which are sensitive to ionizing radiation, and then they have longer time to manifest this damage. Hence, the children are more susceptible, and you should keep the radiation dose to the minimum. This is also called the LRA principle, which is known as low as reasonably achievable regarding the ionizing radiation dose to the children. So ultrasound has this advantage that it does not have any ionizing radiation involved while scanning. The patient does not need to be sedated. So that is another advantage compared to the CT and MR, where the child needs to be sedated. The role is to detect, characterize, find out vascular invasion, and provide guidance for the FNAC and biopsy. And you can also use ultrasound for the follow-up for the size of the lesion. It is best for differentiating a cystic lesion from the solid lesion. But with all these advantages, it does come with the limitations of having the observer error. It may be difficult to perform in a crying child. Remember, you're not sedating the child, so child may be crying and moving around on the table, and you got to have some degree of expertise and a lot of patience to image such a baby. And then your visualization in the retroperitoneum may be limited. So these are the disadvantages which you will face while using ultrasound as the diagnostic modality. So what is its current role? Well, current role is that it is the initial imaging modality of choice, and it will also by far and large be the imaging modality for providing guidance for FNAC or doing a core biopsy. Next imaging modality at your disposal is a CT scan, and it is usually done after ultrasound for further evaluation. It has got explicit soft tissue contrast, and unlike ultrasound, there would not be an observer error. The current generation of CT scanners will allow for multiplanar reconstructions of the data. So the advantage of MR that it can provide this thing. The advantage of MR of providing multiplanar reconstructions is no longer valid as compared to the multi-detector CTs. It is the disadvantage compared to ultrasound. It is not that freely available. It gives high radiation dose. It is motion sensitive and requires sedation, and it certainly is far more expensive as compared to the ultrasound scan. Remember, to minimize the radiation dose to the child, we prefer single phase study these days. Current role would be that this is a mainstay of diagnostic evaluation, and is usually done after the initial ultrasound. Next is MRI scan, and it has got exquisite soft tissue contrast, no observable error, and importantly, unlike CT, it does not have any ionizing radiation involved. But again, it is not freely available. It is motion sensitive, requires sedation, and that sedation period is far more longer than the CT scan, and certainly is more expensive. If you ask the current status, well, it continues to be a problem-solving tool despite all its advantages. But at times you may have to do a MR when educated family demands that the child be scanned through MRI and not CT scan. There are other miscellaneous modalities like PET CT, PET MRI, nuclear medicine scans. These are used as problem-solving tools and the research tools, and not really kind of used routinely for the evaluation of the malignant focal hepatic lesions. Their availability is limited, and we will not be discussing them any further in this lecture. So, effectively, what we are going to discuss is ultrasound and the CT scan in the context of the malignant focal hepatic lesions in children. If you look at the spectrum of the focal lesions, hepatic lesions in children, they can be malignant, they can be benign. The list is right over here on the screen, and we are going to discuss today the malignant focal hepatic lesions. So we'll start with the hepatoblastoma, which is the most common primary hepatic tumor in children. It can be epithelial type or mixed epithelial and mesenchymal type. Generally, it will affect children less than age of 5 years, and the peak incidence is at 18 to 24 months. The disease is more common in the male, 1.5 to 2 times more common as compared to the female child. And clinically, they usually, by far and large, they present as an abdominal mass. If you go for the lab investigations, you'll find that the serum alpha fetoprotein is elevated in nearly 90% of cases. The ones who do not show elevation of the serum alpha fetoprotein are the ones which are far more differentiated. Imaging wise, if you look at the ultrasound, you'll find single or multiple masses of variable echogenicity. There can be calcification seen within the lesion. There can be vascular invasion into the hepatic veins or the portal vein. There can be hypoechoic sepsis seen within the lesion. And on CT scan, you'll see sharply circumscribed mass that is slightly hypotenating related to the adjacent liver parenchyma on non-contrast as well as contrast enhanced CT. Although I'm telling you the features both on unenhanced and contrast enhanced, remember that the current guidelines are to restrict to the single phase evaluation as far as possible. That would minimize the radiation to the child and bring down the carcinogenic effect. Calcifications on CTs can be seen in nearly half of the cases, and the septae within the lesion may enhance. So here is the topogram of a CT, which can be a surrogate for an X-ray, and if you encounter one, you are looking for the calcifications and you are looking for any mass effect on the adjacent bowel. On the CT scan, it would appear as a hypodense mass of variegated appearance, and you will be able to see calcification in a large number of cases. As a patient, although I'm showing you both unenhanced and contrast enhanced scan, please remember that currently we do only single phase imaging. These are old images. On unenhanced image, you can see calcification. Now the calcification can easily be diagnosed from direct contrast images. So this is not really required. And on contrast enhanced over here, you can see a large mass with heterogeneous attenuation, necrosis, solid component, calcification, contour bulge. All the findings can be nicely seen on CT scan at the expense of the radiation dose to the child. As a patient, a large mass in the liver, and you can see multiple septae which are enhancing in a case of hepatoblastoma. After you've diagnosed the lesion and you suspect it to be hepatoblastoma, well, the next thing you need to do is staging, and in the context of the hepatoblastoma, give me a moment, please. Apologies for the break. So the staging these days is done as per the pretext classification system. It is used both for hepatoblastoma and hepatocellular carcinoma. The pretext essentially stands for pre-treatment extent of the tumor. It will have the kind of segmental description and multiple annotations. This was first described by Fetal in 1992 to standardize imaging evaluation and risk stratification. And then subsequently it was revised in 2005 and 2017. Currently what we are using is a 2017 version. Pretext group and annotations are described in this classification depending on the extent of the tumor and that guides for the treatment. And then after the patient has received chemotherapy, you may be called upon to do the repeat imaging and provide the post-text staging, which stands for post-treatment extent of the tumor. I'm not going into the details of the pretext staging because it's a longer topic in itself, but the classification staging is freely available on the internet. You just put pretext staging and you'll find it on the internet for the purpose of your reporting. The next tumor which we are going to discuss is the hepatocellular carcinoma. This is the second most common primary hepatic malignancy in children. And usually the children are older than 5 years of age, unlike the hepatoblastoma, which are less than 5 years of age. And again, the disease is more common in the male children. It has a high prevalence in region where hepatitis B virus is endemic, and it can be associated with glycogen storage disease, stenosis, hereditary tyrosinemia, and a host of other congenital diseases. If you do an ultrasound, you may find a focal lesion or a multinodular appearance or a diffuse form. The echogenicity is variable, and it is generally the larger lesions which are heteroechoic. Diffuse lesions may cause disruption of the complete distortion of the architecture, and capsule may appear as a hypoechoic halo around the lesion. You may or may not find vascular invasion into the hepatic veins as in the portal vein. Do a CT scan on NCCT. Again, I'm saying don't do multiphasic imaging. This is just for the purpose of telling you the findings in case you find one such scan coming to you for reporting. NCCT, the lesion will be of low attenuation. In the arterial phase, it will be hypervascular, and in the portal venous phase, you may or may not see the washout. Vascular invasion, if present, would be nicely seen as a thrombus, tumor thrombus inside the hepatic vein or the portal vein. It may reach right up to the IVC. Tumor capsule may enhance on delayed imaging. So what do we have got here? This was a grown-up child around 8 years of age. On ultrasound, we have seen multiple focal lesions, and then a CT scan was done, and you can see this is a contrast in CT. You can see the contrast in the venous phase into the portal vein, and you also see these multiple focal hepatic lesions. This patient had viral markers positive for hepatitis B virus. FNAC was done, and hepatocellular carcinoma was confirmed. Another patient, very heterogeneous looking mass in the liver, and a corresponding lesion shown on the CT scan, FNAC done, and proven to be a case of hepatocellular carcinoma. Fibrolamellar hepatocellular carcinoma is a variant in young adults or adolescent population. They do not have any underlying hepatic disease and are supposedly having better prognosis. They do not have any sex predilection compared to the routine HCC, which is more common in the male population, and serum AFP is not elevated. It shows up as a solitary, well-defined mass on ultrasound, which may be heterogeneous in echo texture, being predominantly iso to hyperechoic. There may or may not be center scar, and you may or may not see calcifications. Similar features will be seen on CT scan, where you can see solitary, well-defined mass. On NCCT, it would be hypodense. There may or may not be center scar. On calcification, again, may be seen in a variable number of patients. Arterial phase, it will be hypervascular. Portal venous phase will have variable appearance, while there may be a center scar which usually does not enhance. There are exceptions to this rule where the scar may scan, the center scar may enhance on the delayed images and still turns out to be hepatocellular carcinoma on histopathology. Here you see a lesion in the liver predominantly involving the left lobe, has got multiple foci of calcification and a center scar, and is mildly hyperattenuating in the portal venous phase. This was the case of fibrolamellar HCC in a grown-up child. Next, we are going to talk about is undifferentiated embryonal sarcoma, which has been in the past given multiple other names, like the malignant mesenchymal, mesenchymal sarcoma, embryonal sarcoma, primary sarcoma. I prefer to call it, we prefer to call it the undifferentiated embryonal sarcoma. It is an aggressive tumor of mesenchymal origin, mostly diagnosed at 6 to 10 years of age. And there again is a slight male preponderance, but no racial predilection. It will present as an abdominal mass and pain. On ultrasound, you will see a typically appears solid and iso to hyperechoic relative to the normal liver parenchyma with small anechoic spaces. This lesion appears more solid on ultrasound than it is seen on CT scan, and I'll show you the images. A minority of tumors appear predominantly anechoic on ultrasound. And on CT scan, predominantly you see a water attenuation lesion. Foci of soft tissue may be seen at the periphery, and septa of variable thickness may also be seen. There may be a dense enhancing peripheral rim, which corresponds to the pseudocapsule at the macroscopy, and there may be central foci of high attenuation if there's bleeding inside the tumor. Fluid delivery level and classifications may occasionally be seen in cases of undifferentiated amyloid sarcoma. Enhancement on the CT scan will predominantly be peripheral in nature and can be seen on delayed images. So this was a patient who had a large mass in the liver, and you can see it appears relatively solid on ultrasound, but far more fluid attenuation looking lesion on the CT scan. This patient on FNS turned out to be a case of undifferentiated abdominal sarcoma. I'm including biliary rhabdomyosarcoma because they come like liver and biliary lesions go hand in hand. It is the most common tumor of the biliary tube, almost exclusively seen in children. Less than more than 75% patients are less than 5 years of age, and again there is a male preponderance. Clinical presentation can be by jaundice, abdominal distension, fever, an enlarged liver, which will be palpated, presenting as a right-sided mass, nausea, vomiting. These all features can be there in a patient of biliary rhabdomyosarcoma. On imaging, the biliary dilatation is common. Ultrasound will show solitary heterogeneous hypoechoic mass or multiple hypoechoic nodules separated by septae. CT scan, you can see a corresponding tumor, and you can also do an MR for the patient. This is a patient where on ultrasound we saw this branching kind of a soft tissue within the liver. The portal vein was not very clearly seen. The small child would not allow use of color Doppler, and we thought it to be a biliary lesion, but we were not sure whether it can just be the portal vein thrombosis. And on a CT scan, you can clearly see the lesion going along the biliary channels and compressing upon the portal vein, which was patent, and then it was going down the CVD right up to the pancreatic head. And the T1 and T2 weighted MR images for the same, showing the entire extent of the lesion from the intrahepatic biliary channels right up to the pancreatic head. And you can make it out much better on the corneal images. This is a T2 weighted corneal MR image for the patient, where you can see the dilated biliary tree and all this soft tissue inside. And this is a reconstructed CT scan image, which mimics what we see on the MRI. And this was a 4-slice CT scan, which we used to work upon maybe 15 years back. And you can see that we can have multiplanar reconstruction, good quality multiplanar reconstruction, even on a 4-slice scanner. Current day scanners of 256 slice or higher give you very good multiplanar reconstruction. So the advantage of MR, which was earlier considered that it gives multiplanar reconstructions, no longer holds true, because you can have the very good quality multiplanar reconstruction on a current CT scanner. Coming to the metastasis, remember metastasis is far more common in the liver compared to the primary tumor. So if somebody asks you what is the commonest malignancy, in the exam your answer should be the commonest malignancy is metastasis. It's not the primary liver lesion. And the common primaries could be neuroblastoma, Wills tumor, GI tumors, lymphoma, and leukemia. And imaging will show you multiple focal hepatic lesions, rather non-specific in nature. Sometimes you may not be able to differentiate them from tubercular lesions or histiocytosis, and then you'll again have to put in a needle to confirm the lesion. But many times you would see a large abdominal mass, and then in that setting, if you see a focal hepatic lesion, you know that you're dealing with a metastatic disease. And same patient, another patient, and you can see multiple focal lesions, rather ill-defined here. And this again was a case of liver metastasis. This was a case of lymphoma actually. And you, in this case, you can also see the retroperitoneal lymph nodes. So to summarize, let's do a bit of revision. If you see a child less than 5 years of age with no history of liver disease, raised IFP and solid mass, well, we are dealing with a case of hepatoblastoma. Older child, more than 5 years of age, history of liver disease, raised AFP, solid mass, hepatocellular carcinoma. In an adolescent patient, normal AFP, non-enhancing central scar, likely to be fibrolamellar HCC, and this will have better prognosis compared to the regular HCC. A young child, solid looking on ultrasound, but cystic looking on CT and MR, undifferentiated abdominal sarcoma. Age less than 5 years, intraductal tumor in the biliary channels, biliary rhabdomyosarcoma. With that background of the imaging, let's look at what you actually will encounter in your clinical practice. We have discussed only the malignant hepatic lesions, but in practice, you will encounter the entire spectrum of focal hepatic lesions. They can be benign, malignant, infective, traumatic, can be anything. Radiological findings alone are not going to be pathognomonic. You have to look at the combination of age, clinical features, serum alpha protein levels. They all will help you arriving at the correct diagnosis. In the previous lecture, Dr. Harsh Mahajan has discussed the concept of using the multiple sets of information. And while the AI evolves and actually becomes a reality, in the meanwhile, you will have to do that manually and look at all the clinical features, lab data, and the radiological data before you come to a particular diagnosis. Risk of ionizing radiation and sedation should be kept in mind while doing the imaging evaluation of the child. Remember, malignant lesions are more common than benign, but the metastatic disease is more common than even the primary malignant disease. Apart from making the initial diagnosis, you will be required for image-guided interventions, monitoring for the complications of the treatment, as well as for the follow-up. These all fall in the domain of the radiologist these days. Keep updating your knowledge because the technology is changing, and you may get things like artificial intelligence stepping into the diagnostic arena. So this is an image which we have seen earlier. And if you look at it, this will give you the clinical picture you are likely to face. A child with multiple focal hepatic lesions. Can this be hepatocellular carcinoma? Well, yes. Can it be multifocal liver abscesses? Well, we cannot really exclude. So what do? We look at the history. Well, the patient had HPV, the lab data, the patient had HPV positive status. The AFP was raised. Should we do the FNA or not? We left the decision to the clinician. They asked for the FNAC, and the FNAC showed the lesions to be hepatocellular carcinoma. So this is the entire gamut. In the practice, you'll have to keep the entire spectrum of the clinical data, lab data, and radiology data together to arrive at a particular diagnosis. And if you're still in doubt, you're going to go and put in a needle into the lesion to make the diagnosis. Thank you so much.
Thank you, sir. Thanks for the excellent talk and making it so simple and introducing us to the pre-test concept and how to differentiate these close differential lesions with each other. So thanks once again. And sir, if you could stay here for 5 to 10 more minutes and answer the questions in the chat box, it would be grateful. So moving forward to our next talk by Dr. Melvin Dianis. And sir is a consultant radiologist at Medical Imaging Department, Master Hospital, University of Malta. He is a secretary at ESOI, and he has experience more than for 12 years working with pharmaceutical companies and academic institutions, and more than 50 imaging publications and 6 book chapters to his credit. He is a co-organizer of the ESOI RESIST workshop, and he has special interest in oncoimaging. So today's topic is updates in RESIST. Over to you, sir. Just wait for a few seconds. There is some technical difficulty.
Please bear with us. We are just sorting out the issues. Sorry for the technical issues. We'll move on to the next lecture and we'll start with this lecture later on. It's my pleasure to introduce our speaker, Dr. Deepak Patkar, sir. Sir really doesn't need an introduction. Sir is a Director Medical Services, Head Department of Imaging at Nanavati Max Super Speciality Hospital. He's the immediate past president of IRI. Sir has more than 32 years of experience in the field of radiology. He's leading medical administrative functions and has been instrumental in clinical team expansion. He's been the past chairman of ICRI. Sir is a member of National Steering Committee for Indigenous MRI headed by IIT Mumbai. Sir has received the Best Radiology Teacher Award for 2019 at the Radiology Imaging Conclave. He's delivered several lectures and orations at national and international conferences. It's an honor to have you with us, sir. So his topic is classification of brain tumors and advanced imaging. You may please go on with the lecture, Dr. Amit.
So I'll be talking on advances in multiparametric brain tumor imaging, India. When we talk about MRI and brain tumor imaging, we know that use of MRI as diagnostic tool has progressed from pure anatomical to functional over the last 10 to 15 years. It allows neurosurgeons to plan surgeries in a very, very sophisticated manner using neuronavigation. It is also effective in assessing treatment response in terms of true progression of the disease versus pseudo progression, true response to the disease versus pseudo response, which actually immensely helps the radiation and medical oncologist to know it. So as I said, we have moved completely from pure structural imaging to a lot of functional imaging, and that is what I'm going to concentrate on today. So as far as tumor imaging in CNS using MRI is concerned, the conventional sequences are spin echo, gradient echo or SWAN, fast spin echo, inversion recovery, especially used for post-contrast attenuated images, and FLAIR. As far as advanced sequences are concerned, we're talking about spectroscopy, diffusion and diffusion tensor imaging, dynamic contrast imaging, arterial spin labeling, which is a corollary to dynamic contrast imaging without contrast, where RBCs are used to tag the contrast in the brain and in the tumor. Bold imaging or functional imaging as it is called, and fusion imaging, which is combination of all this plus PET. So as I said, there is paradigm shift in brain tumor imaging from pure anatomical to morphological into metabolic, functional, and biological evaluation that happens through MRI. What it does is it gives greater insight to the neuro-related people, whether it is surgeon, physician, oncologist, or radiation oncologist, into grading of the tumor, better characterization of the tumor, better functional localization of the tumor, secondary effects on white matter tracts and ventricle. It allows better surgical planning for neurosurgeon. It also assesses response to chemo and radiation therapy very, very accurately, and it differentiates recurrence from post-treatment changes very, very effectively. So as I said, tumor protocol has moved from pure structural imaging to a lot of functional imaging, and that's what we are going to try and understand today. So over next half an hour or 25 minutes or so, we'll understand these 6 subcategories of newer sequences and how they are useful in tumor imaging. We'll first start off with role of MR spectroscopy in tumor imaging. Over almost 20 years, spectroscopy and its role in tumor imaging has been well documented, refined very well, and there are some objective evidences available today. So when we talk about role of spectroscopy in tumor imaging, we look at higher ratios of choline upon creatine, choline upon Na, choline plus creatine upon Na, and creatine upon Na, and lower ratios of lipid upon lactate and creatine upon lactate. So if you have these ratios properly, you can differentiate high-grade tumor from low-grade tumor very well. Let's look at practical applications of MR spectroscopy and how we distinguish abnormalities with same imaging appearances on morphological imaging. So spectroscopy is useful in differentiating tumor from radiation necrosis, cystic tumor from abscess, metastasis from primary brain tumor, and if the patient is immunocompromised, you can differentiate toxoplasma from lymphoma. So how do you differentiate similar looking metastasis from glioma? Look for presence of MI and presence of creatine. If this is present in the tumor bed, you are dealing with glioma because metastasis would not have MI or creatine. Choline would be high in both the situations. In metastasis, you will get a tall lipid peak, which would be absent in primary brain tumor like glioma. Oligodendroglioma can be differentiated from other high-grade gliomas by looking for glycine peak, which comes next to MI, and a relatively low choline. So if you have relatively low choline and presence of glycine, it indicates oligodendroglioma. Radiation necrosis can be differentiated from recurrence of a tumor by presence of relatively low choline and high lipid lactate peak, which gets inverted, the lactate gets inverted on long T sequence. This is a classic example. A friend's brother who had astrocytoma, which was operated about 8 years back. He used to come for follow-up every year and had a fresh history of a cycle of convergence which lasted over 3 to 4 days. His MRI shows a lot of heterogeneity and cystic, necrotic, and solid changes in the tumor bed. If you look at this multi-voxel spectroscopy, there are certain voxels where choline is high. So you know at the periphery of the tumor bed, you are dealing with recurrence. In the tumor bed itself, there are cystic, necrotic changes. The next sequence that is useful in differentiating benign tumors from malignant tumors and primary brain tumors from other is combination of diffusion and diffusion tensor imaging. And we'll see in next 4 or 5 slides how DTI and diffusion plays a very, very important role in CNS tumors. Diffusion, as you all know, is index of free motion of water. High viscosity and membranes impede motions. So lesions with pus will show restricted diffusion. Lesions with high cellularity like high-grade gliomas would show restricted diffusion. Restricted diffusion would be present in abscesses in the center, and that will be present at periphery in the high-grade gliomas with cystic necrotic changes. As early as 2006, meta-analysis was conducted by AJNR of several articles which talked about how using diffusion you can differentiate high-grade gliomas from low-grade gliomas. High-grade gliomas, for example, like this corpus callosum glioma, will show a lot of restricted of diffusion, whereas low-grade gliomas like this oligodendroglioma with cystic change would show facilitation of diffusion. Intermediate grade gliomas would show relatively less restriction of diffusion. Cerebral abscess, as I said before, would show restricted diffusion in the center. The periphery would not show restricted diffusion, whereas if it is a cystic glioma, restricted diffusion will be seen at periphery and facilitation of diffusion will be seen in center. This is another nocardia abscess in a relatively immunocompromised patient showing restricted diffusion in the center, periphery showing facilitation of diffusion. The pus had gone in the occipital horn of lateral ventricle, showing restricted diffusion again. DTI is an extension of diffusion imaging. It is a non-invasive way of understanding brain structural connectivity, which gives insight into macroscopic axonal organization within the tumor, adjoining the tumor, and in the normal brain parenchyma. It is based on the directional rate of diffusion of water molecules, where directional rate is maximum along the white matter tracts, parallel to the white matter tracts, and it is minimum perpendicular to the tracts. So along the white matter tracts, the diffusion FA ratio would be 1, perpendicular to it, it would be 0. And fractional isotropy, which is the index of anisotropic diffusion, is based on this complex calculation, which we actually need not remember. What we need to remember is if the diffusion is spherical, FA value will be 0. If it is tubular, FA value will be 1. And in the tumor area and peritumoral area, it will lie anywhere between 0 and 1. And that's what we should be looking at. Other thing that we should be looking at is the color coding of diffusion. So any tracts which are moving in transverse axis would be coded red. Tracts which are superior inferior would be coded blue, and tracts which are anteroposterior would be coded green. So what are the actual clinical applications of DTI? It allows tract-specific localization of white matter lesions. It allows localization of tumors in relation to white matter tracts. It differentiates infiltration from deflection. It localizes the main white matter tracts for neurosurgical planning, so surgeon knows where to approach the tumor from and what not to be touched. Also, it detects occult white matter invasion by high-grade gliomas. And these are pictorial examples of the same, borrowed from applied radiology. So DTI pattern is based on how high-grade or low-grade the tumor is. For example, in low-grade gliomas and metastasis, tracts will be only displaced. In anaplastic astrocytomas and GBMs, they will be infiltrated. In very, very high-grade gliomas, they will be unidentifiable because they are disrupted. And in metastasis, they are displaced or edematous and minimally deviated, but normal. And here are actual examples from our department. We know we're dealing with a frontal lobe oligodendroglioma. If you look at the tracts, they are just displaced. FA values have reduced, but there's no destruction of the tract. Compare this with this another benign low-grade glioma, I would not say benign, a low-grade glioma pons, where the tracts are displaced posteriorly and on the left side. So surgeon knows he should approach this tumor from right CP angle. Here is a glioblastoma multiforme of left temporal lobe, where the tracts are completely destroyed and invaded by the tumor. Here is a relatively benign looking lesion, dinette of left posterior frontal parafascian cortex. Again, the tracts are displaced, color hues have changed, FA values have reduced, but there is no destruction of the tract. Compare that with this right frontal lobe glioma, where tracts within and surrounding the tumors are almost completely disrupted. So that is the role of diffusion and diffusion tensor imaging in tumor imaging today. Let's look at one of the most important sequence, which is dynamic contrast perfusion, which allows us to differentiate benign tumors from malignant tumors, and we'll understand how we can do that. All of us now know that MR perfusion is the best biological marker of malignancy grading and prognosis. It measures the degree of tumor angiogenesis and capillary permeability. Higher RCBV of more than 1.75 is considered to be cut off for differentiating high-grade tumor from low-grade. What we do in MR perfusion is we rapidly inject intravenous contrast and get a time series of EPI-based T2 images. How is it different from simple contrast? So simple contrast is based on disruption of blood-brain barrier, whereas perfusion is based on concept of neoangiogenesis, which is more in high-grade tumors and less in low-grade tumors. Also, perfusion imaging looks at leaky tortuous vessels which form within and around the tumor. So perfusion imaging is ideal to diagnose, biopsy, and follow up the tumor, which you need to completely follow up till the end of the tumor, whether it gets well or does not get well. So understanding the concept of perfusion versus enhancement is very, very important, because we know that simple enhancement indicates disruption of blood-brain barrier, whereas perfusion indicates and depicts tumor grade much more precisely. So you get sequential 32 sets of images obtained in a matter of minute repeatedly. The contrast in the tumor picks up the contrast very fast and it washes out also very, very fast. So what are the current practical applications of perfusion in tumor imaging? It is used to differentiate tumor from non-tumorous conditions which simulate tumors. It is used to differentiate glioma from lymphoma from metastasis. Also, in cases of glioma, it is used to grade gliomas. It allows better biopsy guidance to neurosurgeon. In post-operative situation, it differentiates recurrence from radiation necrosis. It also assesses response to chemotherapy very well, and it differentiates true progression from pseudo progression and true response from pseudo response. These are some optimal cutoffs given by American Journal of Neuroradiology, which talks about RCBV being a much better marker compared to spectroscopy in terms of sensitivity as well as total error rate. And here are actual examples. Here's a tumor in the right frontal lobe, which appears relatively innocuous, whereas its contrast kinetics showed that there was RCBV of almost 4.2. And this turned out to be anaplastic astrocytoma grade 4 on histopathology. Here is another innocuous looking lesion in the left thalamus, but RCBV was 3.7. So you know you're dealing with a high grade tumor, and histology of this tumor was GBM. Here is a child with large butterfly type bithalamic glioma. If you look at perfusion, it is very, very low. It is 0.7. So you know you're dealing with a low grade tumor. Here are two different examples of ring enhancing lesions. One in the right half of midbrain showing low perfusion, two in the left frontal lobe showing very, very high perfusion to the tune of 7.2. This turned out to be tuberculoma, responded well to AKT. This turned out to be metastasis from CA lung. Here are again two different patients showing one lesion in the insular cortex, other one showing lesion in the left frontal lobe. We know we are dealing with a low-grade glioma here and tumor factor necrosis on post-contrast MRI. The perfusion shows this to have 0.6 of RCBV, and this one again showing 0.8 as RCBV. Here is another patient started off with a low-grade glioma with low perfusion of 1.2. Patient did not undergo any treatment, came back 22 months later with large increase in the tumor, lot of cystic necrosis and heterogeneous enhancement, and RCBV of 3.2. Low-grade glioma getting converted into high-grade. There is another concept in perfusion, that is the concept of mean curve analysis, where you look at how quickly the contrast is taken up and how much is the baseline recovery. We'll understand this concept in next 3 or 4 slides. Any high-grade glioma would pick up the contrast very fast. Washout is also quick, but the baseline recovery is up to 60%. This happens because of leaky tortuous neovascularity. In low-grade glioma, the recovery is to the tune of 80% plus. In lymphoma, we know we're dealing with lymphoma because it's T2 hypo and showing intense homogeneous enhancement. The baseline recovery is to the tune of 120%, which is again typical of lymphoma. So this allows us to differentiate glioma from metastasis from lymphoma, basically because baseline recovery is about 60% in high-grade gliomas, metastasis, it would be about 80%, and lymphoma, it would be about 120%. And reason for this is leaky neovascularization in glioma, lack of break-in blood-brain barrier and capillary fenestration in metastasis, and angiocentric growth pattern and widening of perivascular spaces in lymphoma. Radiation necrosis can be differentiated from tumor recurrence, again using perfusion. Here are 2 borrowed examples. What looks like recurrence here in the left parietal occipital region has RCBV of 0.6 or lesser, so we know we're dealing with radiation necrosis. Here are relatively 2 innocuous lesions compared to this, but both of them are showing intense enhancement of more than 2.6. So it indicates spread of tumor along white matter tracts and ventricular spaces. Here is our own example of the glioma that you saw in the right temporal lobe. What you see here is recurrence because we can see quick contrast pickup and quick washout with baseline recovery of about 80%. And in the periphery of the tumor bed, along the area of radiation field, you see area which does not pick up contrast very fast, not too steep, and washes out also very slowly. So we know we are dealing with radiation necrosis here and tumor recurrence in the tumor bed. Let's quickly understand pseudoprogression versus tumor recurrence. Pseudoprogression will show RCBV, which is lower in necrotic tissue, whereas in tumor recurrence, the RCBV will be like a high-grade glioma. With pickup, quick washout, and washout to the tune of 60% or lesser. In this particular case, it was 55%. Same thing can be diagnosed by using diffusion. In pseudoprogression, ADC values would be higher. In tumor recurrence, ADC values would be lower. Pseudo response happens with Avastin, which is an anti-angiogenic drug. Initially, between 1 to 4 weeks of therapy, the tumor response is very, very quick. But you should not believe that and repeat the scan after 4 weeks. So here is the baseline study. This is after 4 weeks, 4 cycles of Avastin. It looks like the tumor has completely recovered to normal. What we need to do is repeat the MRI after 3 months to make sure that you're not dealing with pseudo response and you're dealing with real response. So this was about role of DAC and DC perfusion. We now will look at arterial spin labeling, which is basically non-contrast perfusion imaging, where you tag the inflowing arterial blood by magnetic inversion, get a tag image, then obtain an image without tag by acquiring a control image. Then you minus out tagged image from control image to get RCBF and not RCBV. So RCBF also is similar to RCBV. The normal ASL maps also look like the dynamic contrast maps, and the outcomes are also quite similar. And here is our own example of metastasis in the right posterior parietal and temporal cortex and white matter, showing ASL color maps and DAC color maps to be quite similar. This is the borrowed example of what looks like recurrence of a tumor following temozolomide. But if you see, the perfusion, ASL perfusion, is very, very low to the tune of 0.6. So you know you're dealing with pseudoprogression. We'll now look at bold imaging or functional imaging and its role in tumor imaging. Role of functional MRI is for patients undergoing surgery, we need to localize the tumor in relation to eloquent cortex and also need to determine the cerebral dominance. This is an article from neurosurgery which talks about importance of distance between tumor brain function and lesion margin. So if the lesion margin is 2 centimeters away from eloquent cortex, there will not be any post-resection deficit. If the tumor margin is between 1 to 2 centimeters of tumor margin, then 33% patients will have deficit. If it is less than 1 centimeter, 50% patients will show deficit. And here is our example of left frontal lobe benign looking tumor. It turned out to be grade 2 astrocytoma. The foot motor function is about 3.5 centimeters away from the tumor, the primary center. The hand motor function, which was supposedly near, but is actually quite away from the tumor, and Broca's area is again far, far away from the tumor. So outcome of this patient, if surgically treated, would be quite good. Let's now understand fusion imaging briefly before we close this talk. PET MRI has added a new dimension to MRI completely. So in addition to doing structural MRI, functional MRI in terms of perfusion, dynamic post-contrast, and spectroscopy, you have metabolic PET, which adds new dimensions to tumor imaging in the brain. It gives excellent human anatomical information, superior soft tissue characterization, better temporal resolution, and of course, no radiation hazards. Here is a borrowed example of a 44-year-old male, known case of left temporal lobe, low-grade glioma, treated 6 years back with surgery and radiotherapy, presented with recurrence of symptoms in terms of convulsions. What we see here is away from tumor bed, you have a new left frontal lobe periventricular tumor, which is hyperperfused, which shows increased uptake of glucose on FDG PET, large peak of choline, lot of lipid lactate, and destruction of tracts on DTI. So you know you're dealing with recurrence of a malignant tumor. A little bit about sampling bias. When you're describing tumor, it's important for us to tell the surgeon where to biopsy from if he's not going to resect the tumor completely. Because if he does not resect it rightly and in the right area, based on perfusion imaging and spectroscopy, he can pick up a low-grade portion of the tumor and miss out on the high-grade portion of the tumor. A lot of new activities are happening in terms of molecular imaging, in brain tumor imaging, which we should be aware of. Because tumor prognosis, now we know, does not depend only on histology, which we used to think, but it also depends on molecular microstructure of the tumor. There are certain important mutations which we should be aware of as neuroradiologists. For example, IDH1 mutation, 1p19q co-deletion, and MGMT methylation. So I spent 3 slides on this. If patient is IDH1 positive, mutated, that patient has better prognosis compared to IDH1 negative, non-mutated, which is called as a wild type of IDH1, which has worse prognosis. Again, if 1p19q chromosome is co-deleted, then those patients have better prognosis compared to the ones who have intact 1p19q chromosome, which has worse prognosis. Again, if MGMT methylated decreased activity is present, that patient has better prognosis compared to the patient with normal activity. And this was put forth as a key concept in the New England Journal of Medicine as early as 2016, which over 20-25 years took into account several patients of low-grade glioma, intermediate gliomas, and glioblastoma multiforme. All of us, of course, know that low-grade gliomas have much more longevity compared to high-grade gliomas, which have very, very low longevity. Here is a blue line which talks about low-grade gliomas to start with, but had wild type of IDH1 mutation. These patients started off as low-grade gliomas, but behaved completely differently. And hence, we know that IDH mutation is very, very important. There are some metabolites in IDH pathways, which as per ongoing research, will be assessed by mass spectroscopy. WHO 2016 tumor classification update talked about significant change in the classification of number of tumor families, which we cannot really go into details of. But what we as neuroradiologists should know, that there is layered classification of all the brain tumors now. It is based on histological classification, WHO grade, and molecular information. Based on that, several new entities have come up. Common ones among them are epithelioid glioblastomas and diffuse leptomeningeal glioneural tumors. So to conclude, with integration of conventional and advanced imaging techniques, we can now provide increasingly detailed information about the underlying pathologies in brain SOLs. These details will aid in improving our understanding of brain tumors and help in development of new treatment strategies in future by reducing the morbidity and mortalities in these unfortunate patients. What we as radiologists must understand, that radiology has to be both image-centric and patient-centric, and we are an important part in the patient management. Interspecialty communication and coordination is a prime need, and we should be able to talk the language of neurosurgeon, neurologist, radiation oncologist, oncologist, as well as histopathologist. And that's what we should train our future generation for. Thank you very much.
Thank you, sir, for the wonderful talk and introducing us to the newer advanced techniques in neuroimaging. And for the delegates, you can type your questions in the chat box. We'll answer them there. So moving forward to our next session by Dr. Melvin D. Anastasi. He is a consultant radiologist at Medical Imaging Department, University of Malta, and sir will be speaking on updates to RadBuzz. We welcome you, sir, and over to you.
Good morning. Thank you for the introduction, and thank you to the organizers for inviting me to this Oncoimaging Masterclass. So today we're going to talk about assessing response with RadBuzz 1.1. This is a case-based presentation. It is primarily aimed as a refresher for those with some previous knowledge of using RadBuzz 1.1. These are my disclosures. So RadBuzz are criteria for the assessment of tumor response in the treatment of solid tumors, and they are based on change in tumor size. They are important for the assessment of therapeutic effects in phase 2 and 3 oncological clinical trials. As you can see from the RadBuzz 1.1 publication, this was an international multidisciplinary collaborative effort between radiologists, oncologists, radiotherapists, the pharmaceutical industry, and regulatory authorities. So what constitutes measurable disease in RadBuzz 1.1? So these are tumor lesions with the longest diameter of at least 10 millimeter, pathological lymph nodes with a short axis diameter of 15 millimeter or more, and osteolytic lesions are only considered measurable when they have a soft tissue component which fulfills the criteria for measurability. That is, it has a longest diameter of 10 millimeter or greater. The choice of target lesions is dependent not only on size, but they should also be representative of all the affected organs. They should lend themselves to reproducible measurements in the follow-up examination. And you can take up to 5 target lesions, a maximum of 2 per organ, measured at baseline and follow-up scans. For example, they could be 2 liver lesions, 2 lung lesions, and 1 metastatic lymph node. These are the response categories for the evaluation of target lesions. So we have 4 categories: complete response, partial response, progressive disease, and stable disease. For complete response to be satisfied, there must be disappearance of all target lesions, and any pathological lymph nodes must have a reduction in short axis diameter to less than 10 millimeter. For partial response to be fulfilled, you need to have at least a 30% decrease in the sum of diameters of the target lesions, taking as reference the baseline sum of diameters. For progressive disease, we need to have at least a 20% increase in sum of diameters of the target lesions, taking as reference the smallest sum of study, also known as the nadir time point. There is also a requirement that this sum must have increased by at least 5 millimeter in order to avoid overcalling progression. The presence of new lesions at any time point after baseline implies progressive disease. Stable disease occurs when there is neither sufficient shrinkage compared to baseline to qualify for a partial response, nor a sufficient increase, taking as reference the nadir time point to qualify for progressive disease. Let's talk about non-target lesions. So these are all other lesions, including lesions which fulfill the measurability criteria but are not selected as target lesions, small lesions with the longest diameter of less than 10 millimeter, pathological lymph nodes with a short axis diameter of at least 10 millimeter to 14 millimeter, and the truly non-measurable lesions such as ascites, pleural, pericardial effusion, or lymphangitic involvement of the skin or lung. These are the response categories for non-target lesions. So you can have a complete response, a progressive disease, or a non-CR, non-PD. So for a complete response of the non-target lesions, you need the disappearance of all non-target lesions and normalization of tumor markers. You have progressive disease for non-target lesions when there is unequivocal progression of existing non-target lesions or the presence of new lesions. Unequivocal progression of non-target lesions is defined as substantial worsening in non-target disease, which even in the presence of stable disease or partial response in target disease would require a change in therapy. And you have non-CR, non-PD when there is persistence of one or more non-target lesions and or maintenance of tumor marker level above normal limits. So you will look at the response of your target lesions, at the response of non-target lesions. You will assess whether there are new lesions or not, and from that information, you can generate the overall response. So if you have progressive disease of any category, either target or non-target, that will automatically result in progressive disease as an overall response. And if you have any response for target lesions, any response for non-target lesions, and the presence of new metastatic lesions, that will be an overall progressive disease. This is how a typical RECIST report can look like. So these are tables which we use for also teaching courses, and they show you the different time points here. You can see each column represents a different time point, and the rows show you information about the target lesions, like here. So you have two target lesions in this case, and their location, which liver segments, the longest diameter for each time point is entered. You calculate the target sum of diameters for each time point, and then you assess the percentage sum of diameter change from baseline and from the nadir time point. The nadir time point is this one because it has the lowest sum of diameters. So we see here you have an initial decrease, partial response, it's more than 30%, a further decrease, so you have continued partial response. Then you start having an increase, it's 8% from nadir, it's not enough for progressive disease, so you're still in partial response. And then you have a significant increase, which results in progressive disease of the target lesions. The other rows show the non-target lesions, and here you have multiple liver metastases. These do not need to be measured, they are assessed visually, and you look at your non-target response. Here you have non-CR, non-PD until this time point, which coincides with this time point where you have unequivocal progression. You will look at whether there are new lesions or not at each time point. Is very important, and in this case there are no new lesions. So the overall response is a progressive disease based on progressive disease of the target lesions and progressive disease of the non-target lesions. Okay, so that was a refresher. Now let's start looking at some cases. So we'll look at the first case. This is a quick and easy one. So we have a 78-year-old female patient, and she had a diagnosis of colorectal cancer with a primary tumor of the ascending colon and liver metastasis. We have a baseline CT here, so I will play a video. Have a look at the liver. So you can see a large metastatic lesion here and the smaller one in the left liver lobe. Let's play it again briefly. Okay, so we saw two metastatic lesions, and we'll take the larger one first. So the question arises, when you have such a large lesion, where do you measure this target lesion? So we have several images here with different slices showing different sizes of the target lesion. And which one would you take to measure? And the correct answer would be D. You would take the one where you can measure the longest in plane diameter. Sometimes if you're not sure, of course, you need to take 2 or 3 measurements and see which one is the longest diameter. And how would you measure it? Here, there are 3 possibilities shown. So A, B, and C. The correct measurement would be B. And the reason is that it is not the longest. This would be the longest. However, this includes a measurement. The measurement includes the inferior vena cava, which shouldn't be the case. So always be careful not to include adjacent vessels. So this is the correct answer. And how many target lesions can be measured for each organ? We mentioned this already. So you can measure a maximum of 2 target lesions for each organ according to RadBuzz 1.1. Okay, so now we have measured target lesion 1. And we have a measurement of the second target lesion, a smaller lesion in segment 2 of the liver. And the question arises again, how do you measure target lesion 2 at time point 2? So this is the measurement at time point 1. And the question is, how do you measure it at time point 2? So do you measure it like this in the same orientation as time point 1? Or do you measure it like this or like this? So the correct answer is B. So you measure where the target lesion is largest, even when the slice and orientation are different compared to baseline. So this is a frequent question that we get. Do you take the measurement in the following time point in the same orientation as the first measurement? The answer is not necessarily. You measure where the target lesion is largest. It may be in the same orientation, but it may be a different orientation. Okay. So another question can arise. If you have different phases, which phase do you use to measure? You always use for these cases, unless it is an HCC or a neuroendocrine tumor, you measure in the portal venous phase. And the answer would be this one here. So it's important to be consistent, and you will measure in the portal venous phase across all the different time points. Okay, so let's look at the second case. And this is a 74-year-old male patient investigated for anemia. Was diagnosed with a stenosing tumor of the ascending colon with hepatic and nodal metastasis. We have a baseline CT. The patient underwent treatment with bevacizumab and xerini, and we have a follow-up scan. So let's look at the video of the baseline scan. So you can see several liver metastases in both liver lobes. There are some metastatic lymph nodes. And here you have the primary tumor of the ascending colon. Some ascites in the pelvis. Now let's look again. Okay. So in this patient, we have several metastatic lesions in the liver. And the question is, which target lesion would you choose in the liver? So you have plenty to choose from. Let's look a bit at the considerations that you take when choosing a target lesion. So would you choose this lesion here in the left liver lobe? Or would you choose this one here? Would you choose the primary tumor as a target lesion? So this small lesion here, it is first of all small, and it is also too close to the diaphragm. So if you have any respiratory artifacts, that will be the first place which you will not be able to measure properly. Would you choose this lesion here? It is a larger lesion, so size-wise, it is more representative of the metastatic load of the liver. However, it is very close to other lesions, and it may be difficult to remeasure on follow-up. So if you can, you avoid taking such lesions as target lesions. What about the primary tumor? So the measurement of the primary tumor, in this case, since it's a hollow organ, it is not very reproducible. And the primary tumor does not always need to be included as a target lesion. You can include it as a non-target lesion. So let's look at the target lesions that we actually chose. So we have this lesion in segment 8, which is 40 millimeter. It is big enough. It is not too close to the diaphragm. It is separated from other metastases by normal liver parenchyma. We chose this lesion, so a lesion in the left liver lobe, also large enough, can be measured reproducibly. And this metastatic lymph node, portocaval lymph node, which fulfills the measurability criteria. So it has a short axis diameter of 70 millimeter. It would need to be at least 15. So this is again a brief refresher of the table showing the response categories. So just to refresh your memories once again, partial response, 30% or more decrease in sum of diameters compared to baseline, progressive disease, 20% or more increase in sum of diameters of target lesions compared to the smallest sum on study, and stable disease when neither of these two are satisfied. So let's look at the measurements at baseline and follow-up one. So we see that the longest diameters of the first two target lesions have decreased, whereas that of target lesion 3, which is the lymph node, shows an increase of only 1 millimeter. So the target sum at baseline is 89, at the first time point is 69, and that is a 22% decrease in the sum of diameters of the target lesions. And which target response category do we get? And the answer is stable disease, because we have not reached the 30% threshold for partial response. So the non-target response for this case was non-CR, non-PD. So what is the overall response? You have stable disease of the target lesions, non-CR, non-PD for the non-target lesions, and the overall response will be stable disease. Okay, let's look at another case. So this is a 64-year-old male patient. He had a rectal resection with coloanal anastomosis following a rectal tumor with a singular hepatic metastasis. He had an atypical resection of segment 6 of the liver and a complicated postoperative course. We have a baseline CT prior to chemotherapy, and then we have 3 follow-up scans. So let us look at the baseline scans. So I play a video first in soft tissue window. So you can see a mediastinal nodal metastasis and some liver lesions here. And the lung window, you can see several metastatic nodules in both lungs. Okay, so let's look now at target lesions in the lung. Which target lesion in the lung would you choose? Would you choose this one here in the right lung base, or would you choose this one? So the answer is you try to avoid lesions which are next to an area of atelectasis, because that may influence your measurement. And you also avoid basal lesions which are too close to the diaphragm. So the target lesions that we chose are this mediastinal metastatic lymph node, which has a short axis diameter of 22 millimeter. This nodule in the right middle lobe, which has a longest diameter of 12 millimeter. And another nodule in the right lower lung lobe, which has a longest diameter of 12 millimeter. And as for the liver, we chose two target lesions, one in segment 4A, which is 12 millimeter in size, and another in the right liver lobe, which measures 12 millimeter too. Windowing, of course, is very helpful, and it helps to delineate faint lesions, making your measurement more accurate. Which window do you use to measure the longest diameter of lung lesions? So the correct answer is we only use lung window. Sometimes you may look at soft tissue window before to help you assess its proximity to blood vessels, for example, but you take the measurement in lung window. And it's important that you do this, of course, in a consistent way, so you always measure in lung window across all the different time points. So let us now look at the measurements across the different time points for our target lesions. So if we look at target lesion 1, this mediastinal lymph node, we see that it has decreased in size, and then it shows a mild increase in short axis diameter in the third follow-up scan. The lung nodule has decreased across all time points until follow-up 3. So an important reminder is for lymph nodes, you should always continue measuring the short axis of target lymph nodes, even if the short axis diameter becomes less than 15 millimeter. Then we have target lesion 3, this lung nodule here. So it has decreased in size and then shows a mild increase. And this liver lesion, target lesion 4, has decreased in size initially and is then no longer visible. So if there is a lesion which has disappeared, you assign a value of 0 millimeter. But if the lesion is present and too faint to be seen, in your opinion, then you assign a value of 5 millimeter. And finally, we have target lesion 5, which we see there is a decrease in size and then an increase in follow-up 3. So let's look at all the measurements now in this table. So we have target lesions 1 to 5 and the measurements at baseline and at the 3 time points after baseline. So at baseline, we have a target sum of 83 millimeter. This decreases of 7 millimeter at time point 1, so that's a decrease of 31%. That means we have a partial response because we have fulfilled the threshold of 30%. Then we have a further decrease from 7 to 47 millimeter. And this would be a decrease of 43% compared to baseline. So we are still in partial response, continued partial response. And then finally, we have an increase to 59 millimeter. So this would be the nadir time point, the smallest target sum. And when we look at the increase from the nadir time point, so it's 47 to 59, that is an increase of 24.5%. And that gives us a progressive disease for the target lesions. So remember, the reference for partial response is the baseline sum of diameters, and for progressive disease, the reference is the nadir time point. Okay, so let's move to the next case. So we have 73-year-old male patient, clear cell renal cell carcinoma. He had had a left nephrectomy. He had lymph node metastasis, underwent therapy with sunitinib, and we have 3 time points, baseline and 2 follow-ups. So let's look at the measurements. So we have metastatic lymph nodes here in the mediastinum, measured across the time points, when we have an interautocaval lymph node here. And if we look at the measurement of the target lesions, we see that their diameter has decreased in size. If we look at the non-target lesions, so we have these periportal lymph nodes, baseline, first follow-up and second follow-up. So from baseline to first follow-up, we don't see much change here. But at the second follow-up, we see a significant increase. And this would be an unequivocal progression of non-target lesions. And there are also some new lesions in the third time point, which is this left paratracheal metastatic lymph node. So if we look at the target lesions, we have the mediastinal lymph nodes and the should read interautocaval. We see the sum of diameters here. So we have initial decrease and a small further decrease. And the percent change from baseline is minus 9.5% and minus 15.7% at the second time point. So this gives us a stable disease of the target lesions. The non-target lesions show initially a non-CR, non-PD, and then a progressive disease due to unequivocal progression. And there are also new lesions. So the overall response would be progressive disease. Okay, so those were the cases which I wanted to show you. I hope that you enjoyed this presentation. If you would like to have further information on RadBuzz, you can access the website of the RadBuzz working group of the URTC. There's a lot of useful information there and the related publications. And we also organize our society, the European Society of Oncologic Imaging, together with the ORTC, organizes a workshop on assessing response to treatment. It's a hands-on workshop with workstations using cases from clinical trials. And after a break because of the pandemic, we will restart these courses, with the next course being in October in Bordeaux. During this workshop, you have the possibility to sit for an exam and obtain a certification to report with RECIST 1.1 in clinical trials. So if you'd like more information, please look at the website of the European Society of Oncologic Imaging. I thank you for your attention, and thank you again for the invitation to this Oncoimaging Masterclass.
Thank you, sir. And thanks a lot for taking out time and sharing your knowledge with us. It was really insightful. And we are looking forward to the conference you just mentioned at the end of your talk. Now with this, we move on to our next speaker. And to introduce our next speaker, I would request our scientific committee chairperson, Dr. Sikandar Sheikh sir, to kindly come online and sir, kindly introduce Professor Clement Siren. Sir is already with us live.
Yeah. Thank you, Dr. Mithusha. And it's my privilege being part of this ESHI society. And I welcome Professor Clement Siren, sir. And sir is the Vice Chair, Department of Radiology, LMU University Hospital, Munich, Germany. Sir, as mentioned, is the current president of European Society of Hybrid and Molecular Imaging. Then sir is focused on multimodality imaging, biomarkers of therapy response in oncology, automated image analysis of digital molecular imaging data, and also artificial intelligence-based analytics for multidisciplinary diagnostic data in integrated diagnostics. So I welcome you, sir, for this forum of our Oncoimaging Masterclass. And with this, on behalf of entire committee, I thank you for consenting and giving this talk with this forum. Over to you, sir.
Dear Dr. Sikandar, thank you so much. Ladies and gentlemen, a very good morning here from Germany. I'm sharing my screen now. I hope you can see it.
It's visible, sir. Yeah.
Great. Those are my disclosures. So today's topic is PSMA PET-CT for guiding therapy in prostate cancer, a very important topic with a lot of current literature. So what's the clinical challenge? You know, prostate cancer is the most frequent cancer in men in the Western countries, and second to lung cancer in mortality. The therapy in localized or advanced prostate carcinoma is either radical prostatectomy, external beam radiotherapy, or brachytherapy. The challenge and really clinical need is that we see a recurrence in up to 53% of cases after radical treatment within 10 years. We know, however, that not all of it is a true recurrence, but that it is frequently a failure of staging with limited sensitivity of conventional staging techniques, including CT and bone scan, that do not enable us to really detect the sites of metastasis at the time point of diagnosis. So we really need a diagnostic disruptor here that helps us out. So conventional staging is usually performed by a multiparametric MRI with the questions, is there a tumor? Is there extracapsular extension? How about the seminal vesicles? Can we do a nerve sparing resection to, for example, reduce erectile dysfunction? So this is the conventional situation for local staging. The whole body staging was performed for a long time by a CT of the chest and the abdomen paired with technetium bone scintigraphy by SPECT-CT. However, we know that metastasis-directed therapy approach based on hybrid imaging with PSMA PET improves patient outcomes. And this is basically the basis on which we are moving forward. Now, what is PSMA? It's a glutamate carboxypeptidase 2. It's a 750 amino acid transmembrane glycoprotein with an intracellular and extracellular domain. I'll show that to you in just a second. The expression is 30 to 40% higher than in other tissues in the prostate. And the expression of PSMA within prostate carcinoma is a little variable between 100 and 1,000 times higher than in regular prostate tissue, depending on the level of differentiation normally. So you can see here on the right-hand side, again, the PSMA protein with the intra and extracellular domain. And there's a variety of PET tracers with different mechanisms available, such as synthetic amino acid analogs, as flucyclovin, for example, that is recommended within the NCCN guidelines. But with regard to the PSMA targeting tracers, there's also a broad variety of molecules available. The good news is that although there's some data showing that the one or the other compound may have a little higher detection rates, generally it doesn't really matter which one you use. The diagnostic accuracy overall seems to be very similar. However, what makes a difference is that now 18 fluor labeled PSMA ligands have become available. So in the beginning, it was 18 fluor, it was a gallium-68 labeled compounds with shorter half-lives and also a little lower resolution. And with the 18 fluor labeled compounds, there are just larger production volumes available, long distance delivery. So when you think about satellite systems where you have a cyclotron at a center and you can basically deliver the tracer over longer distances, that is possible with 18 fluor, and you make the technology broader available. So that's one of the things. And of course, the image quality is somewhat better. But again, here, most likely no significant change in diagnostic accuracy. The indications for functional imaging in prostate cancer are really broad, and you kind of see the patient journey here of a prostate cancer patient over time. So you have the diagnosis, patient undergoes primary treatment, patient receives or has a biochemical recurrence, there's an initiation of ADT, the patient is still staged as non-metastatic castration-resistant prostate carcinoma, becomes second and third line therapies. Then metastatic castration-resistant prostate carcinoma, additional therapies such as radioligand therapies we'll talk about in just a minute, and at the end, death. So in each of those stages, we'll see that PSMA PET-CT has a significant role for therapy guidance, and that's really the key information. Generally, as I just showed you, this is true in oncologic imaging as a total. The indications for imaging are primary staging, therapy monitoring, and recurrent disease. And at each time point, imaging plays a major role in the evidence-based clinical decision-making, ensuring that the patient really gets the therapy that he or she needs. So let's look at primary staging. What's the databases here? In cases where you have prostate carcinoma high-risk disease, that means isoGleason higher than 3, PSA higher than 20, clinical stage T2C to 3A, they come along with a high risk of lymph node metastasis. And several studies demonstrated the superiority of PSMA PET-CT compared to conventional imaging, so CT or MRI, for the detection of lymph node metastasis at primary diagnosis. So this is really the point where we talk about sub-centimeter or sub-0.5 centimeter lymph node metastasis that just elapse the assessment of CT or MRI. And as you know, the level of certainty when you diagnose a PSMA positive lymph node is really also including lymph nodes that can be as small as 0.2 centimeters. So the data shows, however, that for 18 fluor PSMA PET-CT, the sensitivity is about 86% specificity, almost 100% for lymph nodes larger than 3 millimeters. And it was a study with histological correlation, so very nice. And one of the other important positive aspects of PSMA PET-CT is that CT are called bone lesions, meaning non-sclerosed, not yet sclerosed bone metastasis can be detected with a high level of certainty. But in the end, it is important that our technology, our imaging has effects on prognosis and outcome. If we put the data together and we know that the detection of radiologically occult lymph node metastasis significantly influences patient management, this kind of projects on our aim, that by our means of diagnosis, we are really changing the outcome of the patient. So another study you have to know when you talk about PSMA PET-CT is the PRO-PSMA study. It investigated patients with biopsy-proven high-risk prostate cancer, 302 patients in 10 centers, ISUB group higher than 3. And it was a prospective multi-center study protocol, so a qualitatively high study, and investigated patients prior to curative intent surgery or radiotherapy. And those patients with prostate cancer before curative intent therapy were randomized to PSMA PET-CT for staging or conventional staging, meaning CT and bone scintigraphy, with the hypothesis that PSMA PET-CT has a higher accuracy than standard of care imaging. And the second hypothesis was that PSMA PET-CT should be used as the first-line diagnostic test with significant management impact and also consecutive economic benefits, because the patient gets the right therapy from the beginning. Endpoints were histopathology, imaging, and clinical follow-up at 6 months. And I don't want to take up your time too much. Just look at the red dots and the blue dots. And this is basically diagnostic accuracy. And you can see that generally when staging with PSMA PET-CT, your diagnostic accuracy is significantly higher, and no matter whether you look at any metastatic disease, pelvic nodal, distant metastasis. So this is really true overall. And this is a prospective, multi-center, high quality data set. So this really proves our case that also for primary staging, PSMA PET-CT should be used in patients with high risk prostate cancer. And as you can see, it was also published very high ranking in the Lancet by Michael Hoffman. What's also very important, this is a retrospective study by Wolfgang Fendler. He looked at 200 patients with allegedly non-metastatic castration-resistant prostate cancer. Patients had a PSA of higher than 2, including high risk for metastatic disease. They looked at the detection rate for pelvic disease and M1. And look at this. In this patient cohort of non-metastatic castration-resistant prostate cancer, almost any patient had a lesion that was PSMA positive, and M1 was present in 55% of the patients previously diagnosed with non-metastatic castration-resistant prostate cancer. So you can see how really PSMA PET-CT changes the stage by the higher level of accuracy it provides compared to conventional staging. This is the game changer. And the conclusion was that PSMA PET-CT has excellent sensitivity and specificity compared with currently recommended workup. PSMA PET-CT should become the standard also in baseline. Now, that was whole body staging. It is, of course, also very interesting when you look at local staging. So, when we looked at this previously or currently done with multiparametric MRI, the question is really, what does PSMA PET contribute on top to multiparametric MRI? And would it be worthwhile, for example, to do PSMA PET MRI as a type of one-stop shop approach? So this was also investigated in a prospective multi-center trial, again, a very qualitatively high study. The primary study included 291 men with suspected prostate carcinoma. Patient underwent multiparametric MRI and pelvic-only PSMA PET. Additionally, systematic and targeted biopsy of the prostate was performed. The aim was to determine whether a combination of PSMA PET and MRI is superior to MRI in diagnostic performance for the detection of prostate carcinoma in a higher ISUB group. Now, those are the results. PSMA PET-CT plus MRI improved the negative predictive value compared to multiparametric MRI, including an improved sensitivity and, however, at the price of a somewhat reduced specificity. But still, a higher negative predictive value. And those are basically two cases. You can see in the top row, the case where you can see this clearly PSMA enhancing lesion, where you say, well, this is of course a lesion, a prostate carcinoma without a significant corresponding lesion in MRI, and vice versa in B. On this case, you would say no, we don't have a lesion, and there's a clear lesion here. Yeah, so you can basically see that there's a variety with regard to the specificity. There's a trade-off, but nevertheless, it adds again diagnostic confidence. So their conclusion was that the combination of MRI with PSMA reduces the number of false negatives, which is really extremely important when looking for the prostate carcinoma, compared with multiparametric MRI alone. However, another important point is that this may also allow a reduction of prostate biopsies. Yeah? So when we look at the local staging of prostate carcinoma, it is important to remember that the perspective of adding a local PSMA PET to your MRI may significantly and positively influence the therapeutic management of your patient. Okay, second indication, therapy monitoring. We'll jump that in the interest of time and move along to the really main indication from the beginning of PSMA PET-CT, and that was, of course, recurrent disease in the setting of biochemically recurrent cancer. So what are the therapy options in patients with biochemically recurrent prostate cancer? Biochemical recurrence is defined after radical prostatectomy, a rise in serum PSA levels of higher than 0.2 nanogram per milliliter in 2 consecutive measurements. After radiotherapy, it is defined as a rise in serum PSA of higher than 0.2 over stable nadir. And the predisposition is that conventional imaging is negative, so CT or MRI. So what's the important point in patients with biochemically recurrent prostate cancer? It is about the accurate disease localization. That's crucial for the patient's treatment options. Because if imaging is negative, it means that empirical salvage radiotherapy is performed or pelvic nodal dissection. So it's a not precise approach that's not really fitting to our times in precision medicine. And there is, of course, a limited usefulness when the disease is outside the treated region. So looking at a salvage radiotherapy to the pelvis or pelvic nodal dissection, if the lymph node metastasis is retroperitoneal on the height of the kidneys, of course, this is not within the field. And that's the point where high sensitivity imaging is, of course, pivotal to detect the localization of the disease. As we saw already in other indications, PSMA PET-CT has high detection rates when conventional imaging is negative. And there's a substantial change in treatment plan in prospective studies and shown in a meta-analysis with over 1,000 patients in over 50%. In this regard, it is also very interesting to look at the change in intention to treat. So this was a retrospective study looking at 119 patients that were investigated with PSMA PET-CT. Patients underwent primary prostatectomy and had early PSA failure, meaning that they had a rise of PSA after radical treatment of prostate cancer very early on. Yeah? However, PSA was still very low. Yeah, 0.3 is still a very low PSA value, but nevertheless, they were qualified as PSA failure, and patients did not undergo salvage radiotherapy so far. The detection rate for metastasis by PSMA PET-CT and the impact on intention to treat according to the NCCN guidelines were investigated. The recurrence detection rate in this cohort was about 34%, which fits to the PSA level, where we say in patients with a PSA level of 0.5, in the situation of biochemical recurrence, we are able to detect the lesion in about 50%. So this is about the corresponding level of accuracy. The change in intended treatment was 30%. Yeah, so this is quite high, very honestly, when you consider this patient cohort. 1/3 of the patients had a change in intended treatment based on the results of the PSMA PET-CT. And look at this, the intended radio planning was modified in almost 90%. So this is really the big game changer. And how did this come along? And I just wanted to show you one classical case. This 65-year-old patient from that study, after radical prostatectomy, lymph node dissection due to prostate carcinoma, patient underwent adjuvant radiotherapy and had a biochemical recurrence after 5 years. PSA was 0.3, again very low. At the time point of imaging, PSA was 0.45. And this is basically the classic. Yeah, you perform the PET and you can see that clearly this small lymph node metastasis in the pelvis that you would not have been able to detect on CT. Yeah, no chance. I mean, of course, I'm willing to admit that this is non-enhanced, this is not contrast enhanced, but still, I would say you would not have been able to make that call. And with the PSMA PET on top, it is so clear that you have a high diagnostic confidence to make this call. However, with regard to the pelvic salvage radiotherapy, this lymph node would have been included. This is basically not the challenge, but it gives you a higher level of confidence. However, in this patient cohort with 270 patients investigated in a retrospective setting, they looked at biochemical recurrence after radical prostatectomy without prior radiotherapy. What usually happens for salvage radiotherapy is that the target volume delineation is drawn in the absence of visible recurrent disease. So basically, you do the salvage radiotherapy and you include the regions that are most likely to be the localization of metastatic disease. And this study drew the target volumes on the CT as they always did. And they were masked to the PET component, as you see here. If you included the PET, you can see that a number of lesions were included. However, there was a number of PSMA positive lesions that were not covered by the initial planning volume and that were considered to have potential major impact on treatment planning. Overall, 50% of the 270 patients had PSMA positive lesions. 19% had at least one lesion not covered by the clinical target volume, most commonly bone metastasis and perirectal lymph nodes. And look at this. Those were the localizations that were not included in the clinical target volume of the initially planned salvage radiotherapy. Pararectal lymph node, an inguinal lymph node. For example, here, bone metastasis is not included, or also pulmonary lesions. Yeah, so you can see how this very high level of change with regard to the radiotherapy planning field is caused by the very high accuracy of PSMA PET-CT, and PSMA PET-CT also very much contributes to a very precise and accurate planning of your radiotherapy. So also, this is a message you need to pass on to our friends from radio oncology. They are usually quite aware, but it's one of the main messages. Very interesting is also a general look on the change in management. What happens when we talk about PSMA PET-CT is changing management in prostate cancer. And there's a very nice meta-analysis that included 15 studies, over 1,000 patients, that looked at how, in general, PSMA PET-CT changes the management of prostate cancer patients. So this diagram shows you the initial planning, a large portion of radiotherapy, some surgery, some systemic therapy, or even no therapy. And when you look at the modified diagram, when you take the information from PSMA PET-CT into account, you can see that radiotherapy, surgery, and focal therapies increased. However, ADT, so the systemic therapy, the green proportion, is reduced significantly. Why is that? Because localized therapy was more possible after PSMA PET-CT because the site of metastasis was localized that can be addressed with local therapies. This is also very important because ADT effectiveness is controversial, and there's a number of negative effects also, cardiovascular effects, fractures, and also the development of castration-resistant prostate cancer. So this is really a very important, data that comes along with this. And when you know that surgical resection or radiotherapy for oligometastatic recurrence is associated with a better outcome than systemic therapy, we can also extrapolate that PSMA PET-CT serves our end goal, that it is potentially associated with better outcome. Yeah, that PSMA PET-CT really contributes, makes a difference for the patients, and that the diagnostic application of PSMA PET-CT really improves outcome at the end of the game. With regard to the guidelines, it is important to know that with regard to biochemical recurrence, PSMA PET is recommended by the European Association of Urology, also by the American Urology Association, the RADAR 3 Consensus Group, the American Society of Clinical Oncology, and also the consensus guidelines on imaging in advanced prostate carcinoma. We are moving along to a very important and increasingly active field. It is the field of theragnostics. It means imaging and therapy with the identical PSMA ligand. So you have one ligand and different radionuclides for diagnosis and therapy. Now, this is the PSMA binding motif that gets bound to gallium-68 or fluor-18, more or less. This is chemically discussable, but in general, it is like that for imaging. We can take the same binding motif and link it to a beta emitter, such as yttrium-90 or lutetium-177 for a radioligand therapy approach. So that's the overall concept of theranostics. And when we look at the data, we know that PSMA imaging is just crucial before PSMA-directed radioligand therapy for patient selection and to determine the presence and intensity of target expression. You can see this patient with a disseminated metastatic disease in prostate cancer, and you can also see the number of bone metastases and probably also extra skeletal disease. And you can also see the heterogeneity. It is important to know that with the grade of dedifferentiation and heterogeneity, castration-resistant prostate carcinoma can lose the PSMA expression and actually increase the FDG avidity. And you can see in the same patient how different that level and that heterogeneity of the metastasis can be. This is incredibly important because the PSMA lesion uptake, when qualifying for PSMA-directed radioligand therapy, should be greater than the physiological liver uptake, and no PSMA-negative and FDG-positive disease should be present, which is obviously here not the case. A prospective phase 2 trial investigated metastatic castration-resistant prostate carcinoma patients under lutetium PSMA therapy, and a higher mean SUV in pre-treatment was predictive of longer overall survival. Yeah, so the higher the PSMA expression of the metastatic lesions was, longer was the overall survival of the patient. And the higher the pre-treatment FDG positive tumor volume was, that was predictive for poorer overall survival, because this basically addresses tumor heterogeneity, the dedifferentiation of tumor sites, and the higher the dedifferentiated tumor load was, the worse is overall survival. I think this is very intuitive also for a general, from a general medical perspective. Yeah, but we can image that by PSMA and FDG PET. With regard to the radioligand therapy with PSMA, the important trial you have to know is the so-called VISION trial. It's prospective, randomized, international phase 3 trial that investigated PSMA radioligand therapy in 831 patients with castration-resistant prostate cancer previously treated with androgen receptor pathway inhibitor and taxane regimens. And you can actually see that the combination of radioligand, PSMA-directed radioligand therapy plus standard of care significantly prolonged progression-free survival and overall survival. So the blue curves are the PSMA plus standard of care therapy, and the red curves are standard of care alone. So obviously, the radioligand therapy has a significant effect. And look at this. This was also published in a very high-ranking journal, the New England Journal of Medicine, in 2021. So this is a very important trial that paves the way of PSMA-directed radioligand therapy into clinical routine. So we are already at the end of today's lecture. Take-home points are that there is a very high number of recurrence rates after radical therapy in prostate carcinoma, and that is in part attributed to failure of staging. So it's not a true recurrence, but it is actually metastases that are present that elapse our low sensitivity conventional staging techniques that include MRI. Indications for high-risk prostate carcinoma are primary staging, because we know that PSMA PET-CT has a higher diagnostic accuracy than standard of care CT, MRI, and bone scan, and it really has a high level of change in management associated. Secondly, the indication of therapy monitoring, we jumped that, but it's important to know that there are some challenges, for example, that the onset of ADT, so the implementation of androgen deprivation therapy, can increase the PSMA expression of metastasis in the beginning. This is a separate topic, but it's still an indication. And third is the biochemical recurrence after radical prostatectomy or radiotherapy in prostate cancer. It's the key application. There's a high level of change in management, and it's already in the guidelines. So we can consider it level of care. Last point, PSMA radioligand therapy. We discussed the VISION trial that showed a significantly prolonged progression-free survival and overall survival compared to standard of care alone. So there's a great perspective for this concept, this theragnostic concept with PSMA as a target. And with this, I'm already at the end of my lecture. Thank you very much for the kind invitation to participate in the Oncoimaging Masterclass on this wonderful Sunday. And I'm ready for questions if you would like.
Thanks a lot, sir, for joining us today and for your time. Excellent talk and the concepts which you made so clear for all of us. Right now, there are no questions in the chat box, sir. I would request Sikandar sir to kindly come online and thank Professor Kiran.
Yeah, thank you. Yeah, thank you, Mitusha. And thank you, sir. Clement sir, as usual, it was excellent and very informative. And these are the things which probably we have to inculcate in coming days. So thanks a lot for sparing your valuable time, expertise, and on behalf of Oncoimaging Masterclass, we thanking you all, sir.
Thank you so much. It was a pleasure being with you, and I'm looking very much forward to the next occasion. Dr. Sikandar and everyone, thank you very much. Have a great day.
Thank you, sir.
Bye. Enjoy.
Thank you, sir.
Bye, sir. With this, now we move on to the next talk for the day. But before that, I would request Dr. Sikandar sir to kindly announce the winners for the papers and posters. And all of you who had submitted the posters and papers, we thank you for all your efforts. All of them were really nice. And we have also taken the recordings of your papers and posters, and those will be shared on the YouTube channel of Indian Radiologist soon. So these are the results. Sikandar sir, I would just request you to kindly announce the winners.
Yeah, so the first prize for this paper presentation goes to Dr. Sneha Chaudhary from Ambala, from Department of Radiodiagnosis, Maharishi Markandeshwar Institute of Medical Sciences and Research, for the topic role of MR in evaluation of malignant lesions of oral cavity and tongue. So thank you, Dr. Dr. Sa, and second prize goes to Dr. Meghna Shaini for the topic role of imaging in pediatric embryonal tumors from Usmania Medical College, Hyderabad. And the third prize goes to Dr. Almas Swati D'Souza for the paper prostate imaging, that is PIRATS, tool for risk assessment in prostatic lesions, retrospective study from. She is a second year resident from again MIMSR Ambala. So congratulations all of you for their excellent, and I also congratulate all those who have participated in this competition, because we have excellent stuff here, but unfortunately we have to choose the top 3. So these were based on the
Yeah, I think there is some technical issue. So congratulations to all the winners. And these are the winners for the poster presentations. The first prize is to Dr. Anirudh Kishore Vati for pictorial essay of CNS intraventricular neoplasms and mimics. The second prize to Dr. Tanya Sharma for ultrasound and MRI fusion guided muscle biopsies in diagnosis of myopathies. And the third prize to Dr. Anup from Department of Radiodiagnosis, Government Medical College, Kozhikode, Kerala, for puzzling breast lumps in teenagers, rhabdomyosarcomas with breast metastasis. So congratulations to all the winners. We had a tie for the third prize in the paper presentation, and the winner for the third prize is Dr. Dipanshu Suhag. And all the winners will receive attractive Amazon gift vouchers soon from Indian Radiologist team. So thank you once again. And with this, I would request our next speaker for the day, Dr. Sonal Krishnan, who is Associate Director, Body and GI Imaging, Medanta Hospital, to please come online. And the topic which ma'am is going to take is response assessment of hepatic tumors. Her special interest area is hepatobiliary MRI. We welcome you, ma'am, and over to you.
Can you hear me?
Yeah, yes, ma'am.
Okay. Hi, good afternoon, everybody. And I think I heard the Sunday's talks. They were all very, very good. And I learned a lot, even though I don't do so much outside of the GI imaging and rest of the body imaging, but there is a lot to learn, especially the international talks and the talk by Dr. Deepak Patkar and the other speakers today. So I'll quickly rush through because I feel that it's a lot to take in. It's a lot to take in. Just hold on. It's a lot to take in on a Sunday with so much information. So yeah. So when we speak of HCC, there is a lot of it which we don't know as radiologists. So when we are speaking in GI radiology, we are very closely related to clinical teams, and following on with Dr. Harsh Mahajan's, Dr. Deepak Patkar and other senior radiologists who said that we are in close tandem with the clinicians. So first we should understand that why do we offer different loco-regional therapies to the patients. So as you will see, I will not go into the details because there is a lot of it, but you will see that there are a lot of options available and it depends on a lot of factors, not just the tumor. So this talk is just to give you a taster of when you get imaging to review. If you are not in a specialist center, there are a lot of factors to consider, and you should have these factors in mind before you are reporting. And also it is very important that unlike RECIST criteria, here each and every lesion in loco-regional treatment needs to be addressed because it is going to affect the management of the patient, whether he or she is a liver transplant candidate, how we are going to counsel the patient. So please remember all this in mind. So there are lots of options. Obviously the best would be curative. In curative, we have surgical resection and various ablation techniques. By ablation, basically what we are doing is we are giving some form of heat to the tumor such that the thermal energy destroys the tumor cells. Of all the locoregional therapies, it's the energy-based radiation which is curative. Whereas transcatheter therapies are either bridging therapies or they downstage or they are palliative. The same goes for the radiation therapies and the systemic therapies. So coming to what is curative? Curative, when you completely eliminate the tumor you have detected. Downstaging is that you allow for something which was not in the transplant criteria to come within the transplant criteria. Bridging therapy is, for example, a patient doesn't have cannot afford a living donor, is waiting for a deceased donor. So to make sure that they continue to stay within the transplant criteria, we offer them a time gap treatment such that the tumor does not increase in size and they do not go out of the transplant criteria. Debulking refers to big tumors, which allows for the patient survival to increase. However, it does not offer curative treatment. Please remember, debulking and palliative are different. In palliative, we know the patient is not going to survive. So palliative is aimed not to remove the tumor, whereas to alleviate symptoms and improve quality of life rather than reducing or eliminating tumor burden. So the therapies we are going to talk about, curative, downstaging, bridging, and debulking, are mostly locoregional therapies. Palliative therapies are usually with the oncologist who takes care of the patient's comfort, for example, pain relief, vomiting relief, to make them more active. So all these things are addressed. So if you look at this image, this is how heat is delivered through the device. And this is fairly self-explanatory. And because of the heat being delivered to the tumor, the death of the tumor cells occurs. And the technique is such that the heat is delivered within a particular range of the tumor diameter. And I will go through more. And now in the locoregional therapies, this can be both cryoablation, where you're using you are quickly freezing the tumor and then using ablative techniques. Thermal ablation, we are using high heat. Microwave, very self-explanatory, you are using microwaves to deliver heat. Or radio frequency ablation, we're using radio frequency pulse to deliver heat to the tumor. The most commonly used is radio frequency ablation. If a vessel or a bile duct is close to the tumor, or if it is large in size, then in those cases, microwave ablation is used. Now, when we talk of intra-arterial therapies, they are different to the heat-based therapies in the sense that you are first going to block oxygen supply to the tumor. So that is why it is called trans-arterial chemoembolization. And then you deliver chemotherapy to the agent. So it is cytotoxic, that it kills the cells. So this will induce an inflammatory response. The difference to trans-arterial radioembolization is that you do not stop the arterial supply to the tumor. So you do not embolize the artery, you don't use angioembolic material, but you deliver radioembolic material which has small beta emitters and which in fact need the oxygen to cause cell death. In radioembolization, as we know in any radiation injury, the cell death is by apoptosis. That is, the DNA damage occurs and it dies on its own. The reason I'm telling all this physics is that it will help us in image further on and to look at the complications of the tumor. So this I have explained to you. As you can see, in there is another treatment known as blunt transarterial embolization. Now, that is used in rare situations where you just want to decrease the size, or for example, it's a subcapsular tumor. And it's a form of either a debulking therapy or to prevent hemorrhage or to give symptomatic relief to the tumor. The taste can be lipoidal taste or DEB. DEB means drug-eluting beads. So drug-eluting beads are very small beads which have the chemotherapeutic agent, and they are better able to target the tumor rather than the normal liver parenchyma. So basically, before we assess treatment response, we should also know that the HCC is one of the rarest tumors where in a setting of cirrhosis or hepatitis B patient, you do not need a biopsy diagnosis. Likewise, to assess response, we do not biopsy. So what happens is that you have a hypervascular washing out tumor with or without delayed capsule enhancement, threshold growth, various criteria are there. So the most important thing I've put here is that you should know the pre-treatment enhancement pattern. For example, you might have portion of the tumor which is hypervascular, not the rest of the tumor. And then it is important for you to compare the pre-treatment enhancement pattern with the post-treatment enhancement pattern. So all this I have told you. As I have said, now there are various complications we should consider. So when we are imaging, we should also look at the complications. In TARE, it is very important to look at radiation-induced complications. The most common being radiation-induced cholecystitis, liver abscess or myeloma, or bile duct injury. In ablation, the most common, if they have not been careful in selecting, can be bleeding due to the capsular breach or an active arterial extravasation. So as I said, now there are various criteria to assess the tumor, and it is mind-boggling. The key thing in liver, as I said, it's very important to assess. Unlike when we are talking of oncology settings where we have index lesion and then we have non-target lesions, here if it's for a curative intent, for example, in the same liver, you can have two lesions which are being ablated, and one lesion which is going to have microwave ablation, one lesion which is going to have radio frequency ablation, and a third lesion which is going to be planned with TACE with a curative intent. So it is important to label each lesion and to look at the response of each lesion separately, unless it is for palliative or debulking intent. So there are various criteria. We have mRECIST, which is basically modified RECIST, European Association of Study of Liver, LIRADS. There are more, PERSIST, which includes PET-CT, and as well as the Society of Cancer Imaging. I will talk about that, RECIL criteria. So as I had said, that we need to assess response not in the patient level. We need to assess each lesion separately. So loco-regional therapy, we need to assess each lesion separately because they're going to be treated differently. So as I said, you have various criteria. We have RECIL, and then we have various imaging modalities which are available. The most important thing is to know which imaging modality to use, what timing fits for which modality, especially for those who are listening and are not in a high volume or a specialist centers. It's important to mention your findings and be descriptive, and please don't be afraid to ask for a specialty opinion. Because, for example, if you say that it is recurrent disease, or if you say that, for example, there was no tumor in vein, and you say that tumor in vein has occurred, it is going to be, really life changing for the patient. So please understand the implications of your imaging report in response to the various loco-regional therapies. So because of brevity of time, I can make a PDF of this talk and you can share it. There are very, very good articles. So basically what modified RECIST is doing, it is not looking at the size criteria, because what happens, for example, in case where we are giving chemotherapeutic agent, there is an inflammatory response. So there can be edema and swelling. So there can be a pseudo increase in size of the lesion. Likewise, for transarterial radioembolization, what happens is that we give radioembolic material where again there is inflammatory response, and initially you can have pseudo enhancement or pseudo progression. In microwave ablation, the target zone is more than the size of the lesion. So the ablated lesion looks bigger. So in all these cases, the size criteria has no relevance. That's why we have modified RECIST or RECIL, where it is talking about the volumetric tumor necrosis. So not just the size or the enhancement, but also how much of the tumor has necrosed. Now, when we talk of necrosis, when we use day-to-day reporting, we just use necrosis subjectively. Please use a quantitative assessment of necrosis. Necrosis means when there is no enhancement, or enhancement which is less than what can be explained by granulation tissue. I will talk about this a little bit later. So when there is no enhancement, then it talks of tumor necrosis. So then again, these are this thing. Now what happens is that derivative of RECIST has been using terms called partial response, stable disease, progressive disease. The key thing here is, for example, I have spent 4 lakh rupees in getting 4 lesions, having radiofrequency ablation, microwave ablation, 2 lesions each. Then these do not have any relevance. The importance is that, do I need to be treated again? Do I need to be recalled and I'm not sure what's going on? Or I am 100% treated and I can go back to routine follow-up. So all these things, please understand when you are reporting, do not use these terms without having in your mind what the clinician needs the information for. So for that, I'll just come. LIRADS has come up with more discrete criteria. You can use MRECIST, ESL, whatever is the institutional protocol, and the key is to sit with your hepatologist, with your radiation oncologist, with your hepatic surgeons, with your interventional radiologists, because these are the ones who are going to treat the patient at the end of the day. Lot of places, the interventional radiologists only report the post-treatment imaging, but at our institute, we report because the caseload is very high. But the key here is that our imaging is reviewed by each and every again and again. So please remember that that all this is very important. So this is again showing. So these are various tables showing how much information we have. Now these 2 tables I'll quickly go to tell you that how complex is treatment decision, that it's not just the size of the lesion, it is also the location of the lesion, whether there is vascular invasion, whether the bile ducts are close to it, whether vasculature is close to it, whether there is hepatic venous invasion, whether there is portal venous invasion, and if it is portal venous invasion, what level of the portal vein. For example, is it just a segmental tributary? Is it a right anterior portal vein? So all this is very important. And now systemic therapies is also being increasingly used along with TACE and downstaging treatment. For example, at our institute, they do TARE and SBRT, and with or without systemic therapy, to with the intent to completely cure the tumor thrombus, where the patient was not considered a candidate for transplant, becomes a candidate for transplant. So where it is very important for radiologists to be able to interpret whether there is residual tumor in vein or not. So as I said, it varies per institution. Now, usually what happens in most of the therapies, you image at 1 month and then you follow for 3 months, twice, then 6 months. And if there is no recurrence, you go back to routine follow-up. The caveat being, for example, sometimes you want to image immediate post-treatment if you want to look at the ablation zone, or you are suspicious there you might have injured a vessel or biliary system. In radiation-based therapies, you do not image before 8 to 12 weeks. The reason being, in the initial phases, there's going to be quasi enhancement, which is because of the response of the connective tissue and the blood vessels to the radiation damage within the tumor, which produces enhancement, so which can affect our reporting, and we might consider it as residual tumor. So as I said, I have now detailed imaging findings, complications. This is for radiofrequency ablation, this is for TARE, and this is for TACE. Now here, please remember, a lot of institutes, when they are going to consider patient for transplant, they also look at PET-CT, and some places they do MRI. So not just contrast enhancement, please also look at your non-contrast images. your PET images and diffusion weighted images. For example, if you have a tumor which is not PET avid, and post treatment, even though you are not seeing any enhancement, but in the periphery of the tumor, 3 months following treatment, you see unexplainable PET avidity or unexplainable diffusion restriction, then it is very important to closely monitor the patient. In my own experience, I have seen recurrence, and the patients have come back. The patients who have not come back, have not believed us, have went on to develop florid disease. So that's why I have mentioned this. This is again similar. So this is one case in point. You will see that this is chemoembolization. And what happens after chemoembolization, you will see here, is that there is death of the tumor. There is no enhancement, but there is a thin zone of enhancement. This is not tumor. This is the reactive parenchymal tissue, which should not be more than 5 mm. It sometimes persists up to 6 months or decreases in size. Any nodular enhancement, nodular diffusion restriction is suspicious. Anything more than 6 mm is suspicious and should be followed up. So we call this granulation tissue. It is reactionary. So this is another post-ablation appearance. Now the reason I have put this image is following ablation and sometimes chemoembolization, you have what is coagulative necrosis. If you remember your pathology, coagulative necrosis is a type of ischemic necrosis. And there what happens, the cells die in situ with the architecture maintained. And what happens in this case in terms of coagulative necrosis is the lesions become T1 bright. So here the subtraction imaging becomes very important because this will be T1 bright, and if you do not have subtraction imaging, it will show pseudo enhancement without subtraction imaging. So this is subtraction imaging. You can see clearly that it is complete necrosis. Again, similar case where there is part of it is T1 bright, part of it is not T1 bright, and you can see posterior part is showing enhancement which is more than 5 mm. So this patient has residual or recurrent disease. The other thing is that, as you can see, that sometimes in this case, for example, the reason I have put here is you are seeing this peripheral enhancement. This is a different case, and you are seeing this hypo enhancement. So please do not ignore this. You must have looked at previous imaging. If this area on follow-up shows diffusion restriction, or if this area is showing washout, it is very important to look for residual or recurrent disease, because recurrence or residual disease develops at the margin of the lesion. Now, when we talk of residual and recurrent disease, there is a reason we are saying different things. Residual disease means that it is present soon after the treatment. That is the first baseline scan after treatment. We say that viable tumor is left. Whereas residual disease, we say is, recurrent diseases, we say when tumor is there, once a patient has been declared completely cured and we develop disease close to the treated site, usually along the margins. So residual disease when it is there soon after treatment, and recurrent disease when it develops after curative report. So here you can see that this particular case, it decreased in size, that enhancement was nothing. So this is completely treated, whereas here this is not completely treated, it is residual tumor. So this is to show you what lipoidol taste will look out. It shows globular lipoidol high density uptake. Now, patients who have lipoidol taste, please remember CT has no role in follow-up because you cannot see intralesional enhancement. Such cases ideally should only be followed with MR. As you can see in this case that there is no intralesional enhancement, there is thin granulation tissue. This is a post-taste patient. You can see that there is, this is the enhancing tumor and there is near complete necrosis. These are similar cases. And in fact, there are two cases, one anteriorly and one posteriorly, which have been treated and which are showing variable appearance. Now, this is an interesting case. We get a lot of infiltrative HCCs with tumor thrombus. So you can see, as I said, it is very important for us to know the enhancement pattern pre-treatment for us to be able to tell post-treatment. So this particular case is hypoenhancing with infiltrative tumor, and it remains hypoenhancing. So even though there is decrease, but this still constitutes residual tumor because it is not complete necrosis. This particular case, it is important that again there is infiltrative tumor. This was showing washout with diffusion restriction. And in this case, you can see that there is no diffusion restriction. There was another smaller lesion posteriorly. This particular case, role of diffusion restriction, you can see that it is barely visible. It is showing on high B value, bright. Here you will see that it is showing T2 shine through. So this represents that even though it is showing on high B value images, it is T2 bright. Sorry, it is bright. There is T2 shine through, and it is not low on ADC, suggesting that it is treatment response. Now this I have shown not to show anything but diffusion weighted imaging and PET. Now we are used to looking at fused PET images. Please understand that PET is counting of whatever is rapidly metabolizing. So in some cases, we have both diffusion and PET, and they may not match each other. So in some cases, we may have areas which are hypermetabolic and areas which show diffusion restriction in the same patient if the patient has had multimodality imaging. Then it is important to follow and make sure that all of it has had resolved. In a lot of patients, we don't have this information. But if we have, then it is important to mention that in the report. For example, if the follow-up is only on MRI, then we should say, okay, this is what it looks on MRI. However, the PET-CT showed hypermetabolism in that area, which has not been evaluated on the current imaging. So this is a case showing recurrent disease. You can see nodular areas of enhancement with subtle T2 bright lesion. Now you can ask, how will perfusion related enhancement be different? Now the perfusion related enhancement, it will be geographical, ill-defined. Rarely there is signal alteration on the non-contrast images or the T2 weighted images. It will not show diffusion restriction. And plus it will wane with time as the inflammation response settles. So similar case, you can see nodular areas of enhancement. Now this is followed over time as you see that the thin rim enhancement in this tumor has decreased. Now the key thing here is you are seeing this ill-defined enhancement. But as you see over time, it has decreased, but it is still persistent. So this particular case would technically be an LRTR equivocal. I will talk about this a bit later. This is to show you what happens in a transarterial radioembolization. This is a patient or infiltrative tumor. This is a hepatobiliary phase imaging. So you are seeing that there is damage not just to the infiltrative tumor, which was here, but there is also effect on the rest of the parenchyma. In fact, we are doing what is now known as radioembolic hepatectomies. And what they do is they produce resection by occluding or producing radioembolic damage to a particular portion of the liver, similar to surgical hepatectomy. But because radiation hepatectomy will be a slow damage compared to surgical hepatectomy, where you will cut in one go, it allows for hypertrophy to happen and is sometimes preferred, especially in patients who are high risk for surgery or who are high Child-Pugh score. So this is something you should know about. Now, this is something which we did at our institute to look at color-coded maps and to look at perfusion in the liver and the enhancement pattern. So here, this is the treated area, but you have ill-defined infiltrative tumor here. And this is a combination of the dynamic enhancement in all the phases, where you can see that the dynamic enhancement in the rest of the liver is quite similar, whereas here it is disproportionate and is more hypervascular. So this is suspicious for there being residual or recurrent disease. This is a similar case where there is clearly a hypervascular area. It was not washing out. but showed hypermetabolism. This was a case which was treated with tear. This is a trophy following tear, and the reason was the patient was having rising RFAs, rising AFPs, and this patient went on to develop portal vein tumor thrombus. But this is just research purposes, because it's very time consuming, and also in a routine workflow we cannot do this. But this is just to give you a flavor that a dynamic contrast enhanced imaging patterns also help. The other cases were the other images were diagnostic challenges. This is not a diagnostic challenge. We can clearly see a hypervascular lesion. So again, you can see that this is the tumor thrombus. Part of the lesion has been treated, but there is ill-defined hypervascular area, and there is tumor thrombus in the branch of the portal vein. So it is very important that you not just look at the liver, and this could be that the particular tumor has been treated, but patient has then developed, because of the biology of the tumor, infiltrative disease with tumor thrombus. So this is not perfusion related. You need to look at the imaging closely. And for infiltrative tumor, if you are seeing tumor thrombus and the rest of the parenchyma is slightly hypervascular, please ask for MRI, because infiltrative tumor is often missed on CT. And the key here is diffusion weighted imaging and hepatobiliary contrast phase dynamic MRI to look at infiltrative tumor. It is also called serotomimetic HCC. So as I said, these are again recounting. Now, after RFA, you can develop small nodular areas, which are AP shunts, but they will resolve. And again, tumor growth will be at the periphery at irregular thickening or as new tumor nodule. This I have said before. Now, the first post-ablation imaging should be 1 month, and then 3-month intervals to identify recurrence. These are just some of the references. Now, in lipoidal case, it is preferable to perform MRI, because on CT, high density lipoidal is already there. We will not be able to detect intralipoidal recurrence. So there is heterogeneous enhancement in edema within a month of tear. You should only image tear cases after 12 weeks. So this is different in terms of protocol, that all tear patients, the first post-treatment imaging should be 12 to 15 weeks. So you have radiation effects on tumor necrosis. You have delayed treatment response and patchy internal enhancement, as I said. So we should image only after 3 months. So similar SBRT, this similar to the radioembolization. Now, IRE is a technique which is available in very few institutes, but IRE allows for palliative or downstaging ablation of larger tumors, and also tumors which are very close to bile ducts or other structures, which was not possible, and especially patients where we may not be able to offer TACE or tear because of, say, high bilirubin or any portosystemic shunts or shunting to the lung. So this is a topic in itself. How do we evaluate, as I had shown initially, how to evaluate suitability for which treatment to give. So IRE can be offered in some subset of patients. So if your institute is going to offer IRE, please read some articles or go through the IRE. The enhancement pattern is different. We don't have IRE at Medanta, so we don't have practical experience. I'm just touching here for completion purposes. So systemic therapy, validated data is very less. Very few consensus guidelines talk about systemic therapy. The key thing in systemic therapy is that the hypervascularity goes away. So if, for example, the patient is on sorafenib or altenevenib, and patient had hypervascular washing out tumor, and the repeat imaging shows hypoenhancing tumor, enhancement in itself is not a criteria for tumor response. Like we saw in ablation, necrosis is a criteria for tumor response. So this is something which needs to be addressed, and a lot of groups are looking at it. At our institute, we speak in terms of decrease in size of the viable tumor. We calculate viable tumor by looking at enhancement pattern in all the phases, because even though they don't have arterial enhancement pattern, they continue to show hypo enhancement. So if there is hypo enhancement, we presume it's viable tumor, and we compare the pre-treatment to post-treatment in terms of the viable tumor volume which is there, similar to RECIST criteria, but including the enhancing component of the tumor, and also continue to look for new lesions which may show atypical enhancement patterns as well as extrahepatic disease. So interpretation, now transient hyperemia, as I said, which is also called granulation tissue, represents a transient physiologic response. It is not residual tumor. If you have nodular arterial enhancement, washout, or nodular enhancing soft tissue, it is highly suspicious, or in fact almost diagnostic of residual or recurrent tumor. Subtraction imaging are a must if you're doing MRI for all post-treatment response. Okay. So I think I'm short of time. There are a lot of articles, and now quickly, these are various guidelines you can go through. Now I want to touch on PET-CT. Again, there is no recommended consensus guideline or solid data to talk about PET-CT, but a lot of institutes in India are doing triphasic PET-CT. And at our institute, we use triphasic PET-CT where there are large tumors, where the AFP is disproportionately high to the bulk of the tumor burden. And we use it to also evaluate portal vein tumor thrombus, because it is usually hypermetabolic. So we use a combination of MRI and triphasic PET-CT to evaluate portal vein tumor thrombus response, especially if the patient would be a suitable candidate for liver transplant. So for this criteria, the whole of the portal vein tumor thrombus should be necrotic, and not a single area should show SUV more than the background noise. The frequency of follow-up I have talked about. These are some of the references. So is there a rule of biopsy in the perilesional area? At our institute, very few times biopsy has been done, but definitely what has happened is they have done in few settings where they are not sure whether, for example, a new lesion which is developed or close to the treated lesion and is showing enhancement characteristic which was not similar as the baseline tumor. If it's not typical HCC, we need to biopsy. The other thing is the role of contrast enhanced ultrasound to either help in localizing the recurrent tumor. For example, they don't want to use CT for guidance, or it is too small to be used for CT for guidance, or to help in the surgeons if they're going to look at non-anatomical resection. So these are some of the criteria where biopsy or contrast enhanced ultrasound is used. Now coming to LIRADS. Now the reason I have come here is that this is very unique. It talks of a lesion. Each lesion has separate LIRADS. If you have 3 lesions, you need to give LIRADS post-treatment to all. So the key here is you need to tell your clinician LRTR non-viable means that it's cured, nothing to do. You do your routine follow-up as per institutional protocol. Equivocal means I'm not sure what's going on. I cannot tell either way. It's like flipping a coin. Viable means there is tumor left. Please look at what you are going to do next. Okay. So, and non-evaluable means, like we write in our report, suboptimal images, repeat imaging, or we can ask for alternative, or we can ask for contrast enhanced ultrasound, or we can recall the patient, whatever we want to do. So no lesional enhancement or treatment specific expectant enhancement pattern. LRTR equivocal, there is some enhancement, for example, intralesional thick septal enhancement more than 5 mm, even 3 months after treatment. LRTR viable, we have nodular mass-like thick irregular tissue, arterial phase hyper enhancement, you have a typical washout or enhancement similar to pre-treatment. As I said, you can have hypo-enhancing HCC. So if it is hypo-enhancing HCC, we cannot say that just because it's hypo-enhancing in pre-treatment, post-treatment, it should be hypervascular. post-treatment will also be hypoenhancing. So you measure the viable tumor size. These are just some of the ways you can do it. I think the best is to the 2, 3, or 4 people who report in your department to sit together and use it. So this is again, this is big. And then again, the imaging workup, this is institutional. This is just indicative. It is not definitive. It is not a legal document. As I said, what you must report. You must report pre-treatment, category, size, and type of treatment, and post-treatment, why you have considered what you have considered. You can make a table and things like that. I will be quick. So these are some of the things saying that mRECIST is good. Now I was talking of 2-dimensional. Now they are saying the same thing. You can do a 3D quantitative approach. Here they are a hand-drawn semi-automated segmentation. The similar things, necrosis, percentage enhancement, has been evaluated quantitatively. So these are some of the studies which have come up for LIRADS, which is coming up. As I said, in arterial phase, you are seeing nodular enhancement. You can clearly see this is dead tumor. These are again some of the imaging LIRADS. Here again, post-treatment, you can see there is residual tumor. This is again another case where you're seeing rim enhancement, which was irregular, interrupted, equivocal, but subsequently there was no recurrence. So treatment-specific expected enhancement pattern is very important. Equivocal is a unique category. So, I think it allows for as I say, shock, or, I'm not sure what's going on, to be used in a more structured way. Otherwise, radiologists are always put at the corner, whereas we know medicine is not exact science. So I think it's a good step forward. Again, pre-contrast, T1 bright, we should use subtraction imaging. Similar case, you are seeing necrosis, some cases. And here, this case I have put, please look at the pre-treatment contrast enhancement. This is not a hypervascular lesion. So it is very important to look at these cases. There is a diffusion restriction posteriorly, so we don't know what's going on. This is a case which has come back with the progressive diffusion restriction. So again, this is a case of residual disease. So these are the things which we should know. And pseudo progression, as I had said before, it is an increase in size because we image too early following tear. So these are the findings. You can see there is intense enhancement around the tumor, which decreases in size. And here also you are seeing there is a thick rim of enhancement. Similar findings. Again, because of brevity of time. So, this arterial phase hyperenhancement, AFI, is a term which now LIRADS is using increasingly. It's the institutional or whoever are the colleagues to sit and look at it. So these are the article. This is a very nice article. I would recommend you to go. And this is from this Korean Journal of Radiology. And you can see that this has used, this has given tear to the patient. And now what happens in tear, as soon as you do yttrium, you give yttrium particles to the patient, you do an immediate post-treatment PET to look at the uptake of the radioembolic material in the tumor. Now you can see that this part of the tumor has not taken up the radioembolic material. And this is the part which has come back and progressed. So when you look at tear images, please also look at pre-treatment yttrium images. So at our institute, when I report, I look at the pre-treatment, I look at the shunt images, and I also look at the yttrium PET CT fused images, which is done immediately following treatment to show which are the regions which have taken up the radioembolic material. So similar cases showing recurrent disease. So this is a case which is completely treated. Again, imaging findings, how it retracts in volume, what happens following treatment. So I'm now concluding. And the reason I didn't put summary is because it's not as straightforward as the other talks talk about. I'm 46 years old, and I'm really telling you hand on heart that every second day a case comes, where we end up discussing with our clinicians, where the patients don't understand, why such a long time is taking place, especially patients, for example, their costs 10 to 15 to 25 lakh rupees. So if we are going to offer a tear to a patient with an attempt to downstage, and we are giving them the hope, okay, your tumor, we will downstage, it will become within the transplant criteria. It is very important that anything which is suspicious is addressed holistically, and there is a, like a opinion in your report which represents everybody, so that everybody is talking the same language. So not just the local tumor, please also look at distant sites, also repeatedly look at biliary complications, look at infective complications, look at cholecystitis, and look at new sites of disease. Also look at AFP and PIVCA values. So there have been times where AFP has been rising, and I have gone and looked back at my imaging and have detected subtle nodular diffusion restriction or some nodular enhancement, which I would have missed had I not looked at the AFP and PIVCA values. So thank you for your time, and I'm sorry I rushed through it. It's just to show you that there is a lot of input involved in this, and it's like this is almost like swimming. Till you jump into it, you will not know. And post treatment imaging in the liver is more difficult than routine GI imaging, and say detecting HCC hypervascular washing out. Thank you.
Thank you, ma'am, for such a detailed lecture. There aren't any questions in the chat box yet, but if I can ask you to hang around for a couple of minutes in case someone has a few. Good evening, everyone. My name is Abhishek Patkar. I will be moderating the next session. A quick thank you to Bayer, our sponsor for this event. Taking our next lecture today is Dr. Anaga Joshi. She is the professor and head of Department of Radiology at Sion Hospital in Mumbai. She is an MCI recognized PG teacher and accredited speaker by the MMC. She is GMC registered in the UK, and she has done fellowships in Chicago and Philadelphia. She is also on the editorial board for the Indian Journal of Radiology and Imaging. Her topic for today is PNS tumors and mimics. Now, if I could ask you to share your screen, please. Yeah, thanks. Can I request you to unmute yourself, ma'am?
Okay. Thank you, Abhishek. Next 30 minutes, I hope to take you through imaging of sinonasal tumors and its mimics. Today happens to be the celebration of 75th year of Lokmanya Tilak Municipal Medical College, popularly known as Sion Hospital, where I head the Department of Radiology. Okay. Imaging of paranasal sinuses, basically CT scan, is one of the most frequently performed examination, and the common pathologies that one look at or image for is sinusitis and polyps. Comparative to the sinusitis and polyposis in paranasal sinus or compared to head neck tumors, paranasal sinus or sinonasal tumors are not common. They're relatively uncommon. Many of these tumors have non-specific presenting symptoms and imaging features. However, some can help to narrow the differential diagnosis. Now, an important thing is that paranasal sinus has got a diverse histology. It has got ectoderm, mesoderm, that is all the cells, dermal cells, glandular cells, vessels, cartilage, bone. So large variety of neoplasm can occur in this region. So let's see some cases, some tumor-like cases, mimics, their characteristics, and some less common lesions. Now, histological classification being like everywhere else is benign and malignant. So epithelial tumors like papillomas, soft tissue tumors like hemangiomas, angiofibromas, bone and cartilaginous tumors like fibrous dysplasias and ostiomas, hematolymphoid tumors, neuroectodermal tumors, germ cell tumors. Their malignant counterparts are squamous cell CAs, adeno-CA, undifferentiated CA, the soft tissue and bone malignant tumors being the muscle, the rhabdomyosarcoma, the bone, the osteosarcoma, lymphoma, plasmacytoma, etc. So again, there are certain mimics which can come as tumors. Now, just a slide on WHO classification of tumors of nasal cavity and paranasal sinus and skull base, the 4th edition in 2017. Several new entities and provisional entities were added to the chapter of nasal cavity, PNS and skull base, which includes HPV-related multiphenotypic sinonasal carcinoma, the SMARCB1 deficient sinonasal carcinoma, the renal cell-like adeno-CA, seromucinous hamartomas, the nut carcinoma, biophenotypic sinonasal sarcoma. So this has been the newer edition, which is the 4th edition in 2017. Now, let's go on to how my talk is going to be. It is going to relate to what kind of symptoms the patient comes with. So it is a very practical approach to what you get in forms of patient. Most of the patient comes with nasal block, epistaxis, pain, and swelling. Let's start with nasal block. An 18-year-old male, nasal block, breathing difficulty, and on examination, this is what the ENT surgeon can see. There was a lesion in the anterior nares. Beyond that, the ENT surgeon could not see. Mind you, 18-year-old male. I'll just take two laser pointer. Okay. So these are all plain images, axial and coronal. You have a soft tissue density lesion occupying the entire nasal cavity, peeping via the posterior choana into, that is what it is seen, and into the nasopharynx. And if you go in the axial, you'll appreciate that this area is very important. This is the sphenopalatine foramen, pterygopalatine fossa, and laterally is the pterygomaxillary fissure. So a large tumor or a lesion, soft tissue density occupying the nasal cavity, displacing the nasal septum to the opposite side, that is to the right. And as you go behind, you will see the posterior choana. It is causing kind of abutting the hard palate. We'll see bone window what happens. And this is the area of the pterygopalatine fossa. The bone window will show that the pterygoid plate is partially eroded. Let's see what happens on the coronal and sagittal image. We'll appreciate that there is widening of the superior and inferior orbital fissure. You can actually see the widening of the pterygopalatine fossa very well. On post-contrast study, you'll see avidly or intense enhancement of the lesion, which was seen in the nasal cavity. And so the epicenter of this lesion is in the sphenopalatine foramen and pterygopalatine fossa. Now, as a radiologist, your job is to identify where it has extended. Like in here, it is nasopharynx. It is gone into the, reaching up to the anterior nares where it was seen. Here, unfortunately, this patient has an intracranial extension in the parasalar or medial temporal region, extra-axial, mind you. So the moment the lesion reaches this area, that is intracranial, things get little complicated. They call it as a red flag, because this patient may require, before treatment, radiation. Coronal image not only shows you the lesion, it shows you how it is extended, its extension into the sphenoid sinus and intracranially. And this is the infratemporal extension. And on sagittal image, it shows you that the lesion from the anterior nair to the posterior choana and into the nasopharynx, not extending into the oropharynx in this, and it is involving the entire ethmoid air cells and the sphenoid sinus. By now, you already know what this lesion is. It's a juvenile nasopharyngeal angiofibroma. And delayed image is just done if you want to go inferiorly. Here, you don't expect any internal jugular vein thrombosis. Now, the usual supply to this is internal maxillary artery. Now, what next? What is the role of the radiologist? Now, in comes the role of an interventional radiologist. Is the embolization, and the embolizing material is PVA particles, and it is 250 to 300 microns. And when is the embolization done? Basically, whenever they plan the surgery has to be done 48 to 72 hours. So not before 48 hours and not after 72 hours of embolization. And in our institute, we do per week 1 embolization for JNA. It's a very high JNA institute. So this is one case where we are seeing that there is a pre-embolization. You can see the blush. This is selective catheterization of internal maxillary artery, and the catheter has gone beyond that, and you can see that there is a blush. And after PVA particle, you will see that it is completely embolized. Mind you, before embolization, one has to see where that hopefully that there are no feeders from internal carotid artery, especially in tumors which have an intracranial extension. Now, one should also know how a post-operative CT in a post-operated for JNA looks. Like in this, they have removed the nasal septum. They have made a large kind of a window in the region of sinonasal cavity. You cannot identify the normal anatomy of the maxillary sinus, nasal septum, or the turbinate. So whenever you see this kind of appearance, go and ask what, even if the patient is older, go and ask the history whether the patient was operated for JNA, because the kind of resection done for JNA is quite extensive. Now, all of you already know that it's an exclusively lesion occurring or tumor occurring in males, usually in adolescents, but I have seen cases as young as 8 years and as late as 28 years. It's one of the benign tumor. Its location, as I've already told you, spinopalatine foramen, pterygopalatine fossa, and its extension is very important. That is what, as a diagnostic radiologist, is where exactly it is extending. Basically, once it enters the infratemporal fossa, its extension into the other areas, and also extension, if there is extension in the orbit and intracranial cavity. Now, there are certain signs that one should be aware when there is JNA. One is bowing of the posterior wall of the maxillary sinus, called as Holman-Miller sign. Then extension of the lesion into the pterygoid wedge. So if you see, this is the pterygoid bone, and the lesion extends into the pterygoid wedge. Like here, the lesion is extending into the pterygoid wedge. This is the medial pterygoid plate, this is the lateral pterygoid plate, and the lesion is extending into the wedge of the pterygoid. That is a Ram-Haran sign. And what is the Hondosa sign? Hondosa sign is the widening of the gap between the ramus of the mandible. This is the ramus of the mandible and maxillary body. So this gap is widened as compared to this. So in this patient, there is the Ram-Haran sign, and in this patient, apart from Ram-Haran sign, there is also Hondosa sign. Another similar case, but not that extensively involving spreading, same 15-year-old, so adolescent male with epistaxis. You have a soft tissue density lesion in the spinopalatine foramen, pterygopalatine fossa, in the nasopharynx posterior coina, as you can see in the coronal. And here on the bone window, you can see the lesion extending into the wedge of the pterygoid plate. This is a nicely corticated normal pterygoid wedge, and see there is cortical defect. So again, the Ram-Haran sign. Post-contrast study, you will see that there is moderate enhancement and the lesion is partially extending to wedge of the pterygoid plate. So this is a smaller tumor as compared to the first one. And what this sagittal image shows, that a lesion is involving the extending and causing widening of the pterygomaxillary fissure. So this is another case of JNA. Now, another case, another pathology. Patient presented now with epistaxis. Axial image, plain coronal, anterior most part where you are not seeing the turbinate. So there is an oval soft tissue density lesion in the left side of the nasal cavity, abutting the nasal septum as well as the lateral cartilaginous portion of the nasal wall. What next? Stop here or do CCT? Yes, you're going to do CCT. Our example, this thing is tumors and mimics. We are going to do contrast enhanced CT scans. So what do you find here? You have an heterogeneously enhancing oval lesion, which was what I showed you on plane. It is heterogeneously and partially avidly enhancing lesion. I don't know whether you can see, but this is 112 and this was 32. So avidly enhancing but heterogeneously enhancing, and the sagittal image shows that a lesion is not abutting the inferior turbinate. It is just abutting the nasal septum medially and anteriorly the undersurface of the lateral wall of the nasal cartilaginous portion of the nose. So diagnosis, the adenomatous nasal polyp versus angioma. It turned out to be hemangioma. What are the types of hemangiomas? Capillary and cavernous. Capillary are lobulated, are composed of capillary-sized vessels lined by flattened epithelium. Basically, these hemangiomas can occur in all ages. They peak in children and adolescent males. They are commoner in females in their reproductive age, and beyond the 5th decade, male and female are equally affected. Cavernous hemangiomas are usually large, inhomogeneous mass with heterogeneous enhancement of either centripetal or multifocal nodular pattern. You can do an MRI with it with biphasic contrast injection. Another case, intermittent episodes of epistaxis in 3 months. And on examination, of course, ENT surgeon could see a anterior nasal cavity lesion on the left side again. So here the lesion is not exactly in the anterior nares, but mildly posteriorly, again attached to the nasal septum. This lesion has lower density than the first one, 12.8, and post contrast, it is really avidly enhancing to 160, more intensely enhancing than the previous lesion. So as you can see, there is heterogeneous avid enhancement seen in the lesion located in the left nasal cavity, abutting here the inferior turbinate and also the nasal cavity. And it is not abutting the floor of the nasal cavity. The sagittal images shows that the lesion is arising from the inferior turbinate, from the middle turbinate and abutting the inferior turbinate. So actually you are not able to see the middle and inferior turbinate anatomy very well on the anterior aspect of the turbinate or nasal cavity. And on sagittal images, you will see the lesion arising from the middle turbinate undersurface, and this is the inferior turbinate. So point here I am trying to tell you is always look at the sagittal image. You tend to look only at the coronal and at the most axial, but definitely look at the sagittal image, which will give you an idea where the lesion is arising from. Just the delayed images. So this turned out to be a LCH, not Langerhans cell histiocytosis, but lobular capillary hemangioma. So what do you look at? Now, if you look for presence of bone destruction, if the lesion is rapidly growing, so usually these lesions do not cause bony destruction, but if they are rapidly growing, definitely they cause bony destruction. And if the lesion is from at the roof of the nasal cavity, like this lesion what at the middle turbinate, so the mid and inferior part of the nasal cavity, but a similar lesion at the roof of the nasal cavity, then look for any intracranial extension. Another patient, a 43-year-old male, presented with swelling over the cheek. So from nasal blockage to epistaxis, we have come to another symptomatology where swelling, and is a non-diabetic. I purposely said non-diabetic because we saw a lot of mucor. Non-diabetic, non-COVID, a 43-year-old patient with cheek swelling. Now, these are MRI images. What do you have in MRI? The T2 weighted images shows a kind of, I'm using a specific term called gyriform or cerebriform pattern of lesion, which is T2 hyperintense, but not as hyperintense as sinusitis would be, but it with areas of linear areas of hypointensity on T2. On T1, it is definitely isointense to the muscle. Now, apart from that, you have to tell about the location. So this lesion is located in the nasal cavity on the left side, extending into the maxillary sinus, beyond the maxillary sinus in the posterior retromaxillary area, and on the coronal image, you can say a large infratemporal extension, and you can see a large intraorbital extension. It is not restricted on DWI and not low on ADC. The actual image, the stack images of the shown, same patient shows the intranasal lesion in the left side, middle turbinate anatomy not seen, intraorbital extension, so on and so forth. Maxillary sinus here is normal. You can't appreciate the maxillary sinus, and a large premaxillary infraorbital component, which is what the patient presented with. Post contrast images shows the proptosis, intraorbital, extra as well as intracoronal extension. And just to show you that the lesion abuts the inferior turbinate, middle turbinate normal, abnormal side is not seen. The bone window, the CT scan, basically I want to show you the bone window. There is erosion of the medial wall of the maxillary sinus, anterior wall, posterior wall, and this is a heterogeneously enhancing lesion with a large premaxillary component. Sagittal image shows you the intraorbital. Now here, this is more extraconal compartment because you can see the inferior rectus elevated. This is the optic nerve, and here you cannot identify the inferior rectus muscle, and you can see erosions of the lateral wall as well. So this turned out to be inverted papilloma called as IPAP. They are most frequently encountered benign epithelial neoplasm, and IPAP is the most common subtype. Why is it called inverted papilloma? Because it's got an endophytic growth pattern. Usually presents between 5th through 7th decade. IPAP is more common in men than women. I already told you it has got, the MRI showed the cribriform pattern or columnar pattern, characteristic for IPAP. CT delineates bony remodeling, focal erosion, and may show bone strut or focal hyperostosis at the point of attachment of the lesion. Now, if the destruction of the bone is too much, you can say it is IPAP with suspicion of malignant transformation. Now, it is important to report the site of attachments as complete resection is required to prevent resection. Foci of necrosis, of disruption of the architecture, or as I showed you, severe destruction of bone, you should raise suspicion of coexistent tumor. So the final diagnosis in this case was IPAP with malignant transformation with coexistent squamous cell carcinoma. Now this patient, a 72-year-old next patient, mass in the buccal cavity, right nasal cavity, and had a histological proven Schneiderian papilloma. What is Schneiderian papilloma? Also called as sinonasal papilloma, considered as benign sinonasal tumor arising from Schneiderian epithelium. Now, IPAP is most common subtype of this Schneiderian epithelium. The other epithelial malignancy or papilloma. This The other one being exophytic papilloma, and the third one being oncocytic. Now, this is a 72-year-old patient. You will see this plain CT scan shows a large component in the nasal cavity from the anterior nair to the posterior nair with erosion of the hard palate, an extension of the lesion, or on the plain CT, we don't know whether this is an extension of a lesion or sinusitis. Because you can see the density of this is different from the medial and anteromedial component of the maxillary sinus. This is sinusitis, and this probably is the invasion of the mass. Also anteriorly, it is causing erosion of the maxillary alveolus. Bone window shows extensive destruction of the maxillary alveolus, also of the hard palate, so on and so forth. This is post-contrast image showing you heterogeneous moderate post-contrast enhancement of the lesion and its extension. The corneal images also shows that there is an intraoral component of the lesion, and you can measure the intraoral component from anterior to the posterior aspect, and there is severe erosion of the hard palate. So maxillary sinus, nasal cavity, intraoral component. The previous CT showed the lesion, but remember, there was no nasal component. And of course, the previous CT was from outside and they have not done open mouth view. Now, if you see the difference, this is the previous CT. This is the current CT. You will see that the open mouth view showed the intraoral component very well. The closed mouth cannot really appreciate the intraoral component. Also, if you compare, there is growth of the lesion. So there is involvement of the anterior nares and complete obstruction of the anterior nair as well as the nasal cavity. So if you have always, in cases of tumors, try to understand and ask the patient if there is a previous CT. In this patient, there is definite increase in the size of the lesion and increased extension. Coming to another pathology where there is an soft tissue density lesion with erosions of the walls of the maxillary sinus. You can't really see medial wall, inferior wall, the hard palate. It looked like the previous case. This is nothing but malignancy. Now, squamous cell carcinoma, what are the CT features? Is prominent bone destruction. And MRI, what are the MRI findings? It is the intermediate T1 signal intensity, hypointense on T2 as compared to fluid. Because remember, the fluid, which is non-fungal, of course, non-fungal infection, just sinusitis, is very bright on T2. So these lesions are less than that of the fluid. Most squamous cell carcinoma have a non-specific imaging appearance. So let's go on to see some cases. Again, if you remember the first case I showed you, the nasopharyngeal angiofibroma, it had a nasal component, but look at this. This is not widened. That is a sphenopalatine foramen and pterygopalatine fossa is not widened. The lesion looks the same, but the key factor is here. The lesion is extending into the maxillary sinus, and in the JNA, there was not much lesion that we saw. Of course, you can get, but not very common. So this is anterior periantral extension of the lesion. Of course, there is intra-orbital extension also. Post-contrast shows heterogeneous moderate enhancing lesion involving not only of the nasal cavity like here, maxillary sinus, ethmoid air cell, and intra-orbital extension and causing retention sinusitis. You can see the intra-orbital extension. Extensive bony erosions. I will just quickly show you. I've finished my 25 minutes. I had kept an alarm. So you can see that extension of the lesion in the nasal cavity as well as the maxillary sinus, the ethmoid sinus. This is the medial rectus, so extracorneal extension, so on and so forth. So a higher age group, extensive involvement of the structure adjacent to the nasal cavity and paranasal sinus with bony destruction, like you're going to see here, lamina papricea, the roof of the maxillary sinus, medial wall, the ethmoid trabeculae, and as you go posteriorly, the lesion is also causing partial extension and erosion of the lateral recess of the sphenoid sinus. So keep in mind the age of the patient and erosions of the bone. This was a sinonasal carcinoma. So antral or maxillary sinus carcinoma are uncommon head, face, neck tumor, average age being 45, more common in males than females, almost 5:1. Despite large lesion, but it is confined to the maxillary sinus. Hence, the symptoms are quite late. Another patient, female here, proptosis, left eye with diminution of vision, associated pain and left nasal discharge. Again, the findings are similar. Expansile lesion in the nasal cavity with intraorbital extension, moderate heterogeneous enhancing lesion, severe bony destruction, but the age is higher. Also, the fovea ethmoidalis is eroded. So is the anterior part at where your Kiros classification. Remember, the cribriform plate is eroded. Presence of a soft tissue in the nasal cavity. As of now, there is not any intracranial extension. Again, a sinonasal carcinoma. We went ahead and did the MRI. T1, it is iso-intense. On T2, it is hyper-intense, but not as much as the maxillary sinusitis. So this is retention sinusitis, and this is extension of the lesion into the maxillary sinus. This is extraconal extension of the lesion. T2, it is hyper-intense. On diffusion, it is restricted with low ADC value. Post-contrast, it shows heterogeneous enhancement. So both are CT and MR cross-sectional imaging showing you the extension. And here, it is also extending to the supraorbital air cell, but there is no intracranial extension. A sinonasal carcinoma was given, and the histopathology came as adenoid cystic carcinomas. They are very rare tumor. Salivary glands are more involved than sinonasal region. And the problem is you cannot really differentiate adenoid cystic carcinoma from a squamous cell carcinoma. Another patient with epistaxis, headache, nasal obstruction. You have a lesion which is now has an intracranial extension along the base of the anterior cranial fossa with erosion of the cribriform plate, fovea ethmoidalis. This turned out to be a esthesioneuroblastoma. So yes, there is a confusion when it comes to ethmoidal cell tumor and esthesioblastoma. I'm not going to read all this because I'm falling short of time. Now this is an 11-month-old, so our age is changing. 11-month-old male, mother noticed a swelling. So again, a soft tissue density lesion in the nasal cavity, extending into the orbit. Lamina papricia is eroded, and it is abutting the medial rectus muscle. On post-contrast study, it shows heterogeneous. Now the age is different. So when you have a child, now this was less than 2 years, and you have a large lesion, which is causing erosion, like here in lamina papricia, normal and abnormal. Think of rhabdomyosarcoma. Common in males, Caucasian children below the age of 15. Types you all know, and a differential diagnosis of lymphoma. Treatment is usually radiotherapy. Now, this is an interesting case. I will quickly go through it. A 65-year-old, histopathologically rhinoscleroma, a debulking surgery was done. We did a CT scan on 13 December 2021. You see, again, a soft tissue density lesion with ethmoid invasion, maxillary sinus. This is plain. Let's see what happens on post-contrast. And this on bone window shows rarefaction. It is not complete erosion, but rarefaction of the medial wall of the maxillary sinus, posterolateral wall of the maxillary sinus, and also the inferior wall. So there is rarefaction of the lesion. And the current CT also shows that the second CT, that was for us the current CT, shows that this is an enhancing lesion which has got a large preseptal component, and it is abutting the eyeball and has got an anterior nasal cavity component and preantral component. And to our surprise, look at the lesion in the neck. multiple lymph nodes on the left side, right side, a large lobulated mass, causing all the mass effects on the internal carotid artery, the common carotid artery, and this lesion has an intraoral component. So extensive lymphadenopathy. So we told them that kindly revisit and repeat a biopsy, because on imaging, it looks like a lymphoma, though it has a rhinoscleroma diagnosis from before, and a repeat biopsy suggested a lymphoma. So lymphoma can occur in sinonasal cavity. Remember, necrosis is uncommon compared to other malignancies in lymphoma. On MRI, it is iso-intense to other soft tissues on T1 with homogeneous enhancement. A characteristic feature of NHL is hypointense signal on long, that is T2-ated images or stir sequences. Now, just quickly going to the different spectrum, that is increased bone density. This is ground glass opacity involving the zygoma as well as the maxilla, basically encroaching the maxillary sinus. This is nothing but fibrous dysplasia. One quick example of a 3-year-old child with nasal blockage due to a lesion which they could see in the nasal cavity. The child had a nasal breathing. So axial coronal sagittal plane images shows a hypodense lesion in the nasal cavity, which is expanded with displacement of the nasal septum. On contrast study, there is no enhancement. And maybe there is a kind of a defect seen in the level of the cribriform plate. So it went ahead and they did MRI. MRI shows that it's a hypointense lesion in the nasal cavity with few septae. On T2 sagittal and coronal image, you can see hyperintense signal within the lesion, which is involving the anterior nair of the posterior choana. And there is this stalk-like area with a defect, which I showed you on the CT scan. We usually don't do flare below the age of 2 years, but in this patient, we did flare to show that this is nothing but CSF because the signals have got suppressed. Post contrast also did not show any enhancement of the lesion per se, but peripherally there was enhancement. And patient was operated for this encephalocele, frontoethmoidal encephalocele. So basically, there are 3 types of frontoethmoidal encephalocele, nasoethmoidal being the most common, which was the case I showed you, nasofrontal being second, and the least common being nasoorbital. Few quick examples of mucoceles. There is complete opacification of the involved paranasal sinus, like in this, the ethmoid paranasal sinus. Pressure erosion of the adjacent bone, like in this patient, here is the lamina pepricia erosion, and there is extension of the lesion into adjacent compartments. Like in this is the extraconal compartment of the orbit, causing mass effect on the medial rectus, stretching the optic nerve and also causing proptosis. So basically, it is complete opacification of the paranasal sinus, whichever it is involved. Like here, it is involving a part of the frontal sinus, supraorbital air cell, complete opacification, non-enhancing, pressure erosion, and it is abutting the eyeball. So mucosal, just showing you the bone window that it is pressure erosion. So I've already told you complete opacification, expansion, thinning out or bony resorption, and extension into the adjacent structure. Now hyperdense lesion, like here, this is a bony lesion seen in the ethmoid air cell. This is nothing but an osteoma. What is the importance? Smaller osteomas or the size is important because it can hamper the drainage side. This was a large cartilaginous tumor which is seen in the region, or you can say a hyperdense lesion, expansile lesion seen in the nasal cavity with chondroid matrix and expansion of the nasal cavity. It is not extended into the orbit, neither has it extended into the maxillary sinus, except the osteomeatal unit is compromised, so there is maxillary sinusitis. So this was a chondroid tumor. Some other hyperdense areas in the nasal cavity or in the paranasal sinuses. Like in this is a rhinolith. or it could be a foreign body with, if there is no history of foreign body insertion. And this, if you can see, you can safely call it a rhinolith. If something similar is there in the sinus, it can be a sinolith, like in this patient where there is sinusitis with high density area within the opacified maxillary sinus. This is nothing but a sinolith. So before we end, I would like to summarize by saying sinonasal neoplasms are rare, accounting for 3% of head and neck malignancies and 3.6% of upper aerodigestive tracts malignancies in the National Institute of Health Surveillance Epidemiology and Result Studies. CTR and MRI are complementary modalities. CT diagnoses common pathologies. As regards to neoplasm, location and overall size of such masses and then potential extension into the adjacent lesion. Thus, what is our role is to help them plan their therapy, either surgical resection or at least debulking, if not complete resection, basically to prognosticate and tell the patient what are the chances of their losing the eyesight or losing the, they have to open up the cranium, because to open up a cranium or the skull and to tell the patient is a very important part of the ENT surgeon. And you should tell, yes, there is a extension into the intracranial. That finishes my lecture. Thank you so much for having me here.
Thank you so much for sharing your knowledge, ma'am. There are no questions in the box yet.
Let me stop sharing. Just go to the arrow. Thank you, Abhishek.
Thank you so much, ma'am. Before we move on to the next session, we have Dr. Patkar stepping in for a quick word.
Thank you, Naga. I think you go back to a match, right?
Yes,
Naga?
I have a table tennis match to go, so I'm running.
I know.
I've already changed for the lecture. I'm already in my costume.
So best wishes for your match. Dear friends and all of us here, congratulations to all of us as we are about to conclude yet another successful session by Indian Radiologist on Oncoimaging. Rest be assured that there are a few more coming up in upcoming months, and we hope that all of them receive such great response as this one and all our previous ones. All of us know that medicine has witnessed a paradigm shift in all senses. We've seen great changes, whether it is treatment of cancers, whether it is treatment of cardiac ailments, stroke, etc. Whereas all other branches and businesses usually talk about vertical growth, radiology seems to be creating its own metaverse with its various branches of super specialization, taking a big leap in all directions. This is the way ahead for all of us, and we need to focus on further strengthening our skills in terms of learning, teaching, and working in concurrence with all our physicians and surgeon friends. Our entire IR team has been working towards bringing up academic programs with focus on subspecialties like onco, breast, musculoskeletal, neuroimaging, etc. Oncology, as we all know, has seen significant growth in terms of imaging advances, a role of genetics, and several new treatment platforms that are available. All young radiologists interested in oncoimaging need to be well-versed with the newer advances and learn to provide the most appropriate information that our oncosurgeons, oncologists, and radiation oncologists need. My sincere gratitude to the entire esteemed panel of speakers today, including Dr. Saugata Sen, Dr. Seema Sood, Dr. Jayalata, Dr. Arvind Chaturvedi, Dr. Shiv Kumar Swami, Dr. Binay Kumar Chaudhary, Dr. Anirban Dey, Professor Andrea Laggi, Hemant Patel, Harsh Mahajan, Melvin, Dr. Akshay Saxena, Dr. Gaurav Goswami, Samarjit Guman, and Professor Clements. Dr. Sonal, Dr. Abhishek Mahajan, Malini, who is going to follow, Dr. Anaga Joshi, Mitusha, Ritu Verma, and Dr. Surita for their precious time and valuable contribution to this day. A special thanks to Dr. Sikandar Sheikh and Ahmad Chaudhary for curating out a wonderful program, and to my entire team for always providing the backend support. I would like to thank Dr. Sanjeev Mani, Dr. Jignesh Thakkar, Dr. Gauri Ahuja, Dr. Gayatri Harshe, Dr. Abhishek Patkar, and the entire organizing team for their efforts and hard work. I would again like to remind you about upcoming events by Indian Radiologists, including 2 MSK masterclasses, 1 breast imaging masterclass, and of course, the ever popular 21st MRI teaching course, which will be held in August 2022. The Radiology Journal Club that we started about 6-7 months back is an interesting concept which was initiated and is showing a lot of interest and a huge viewership amongst radiology students. So make the most of these opportunities and keep learning. As aptly said by Steve Jobs, keep learning continuously. There's always one more thing to learn. We all hope to see you soon in person as well. Thank you all. Take care. Abhishek, you can take over. Malini.
Thank you for your wise words. Just a quick reminder that for the MRI teaching course, we have paper and poster submissions that we will be accepting till the 31st of July. Taking over our next session today is Dr. Malini Lawande. She will be speaking on the approach to MSK tumors. She specializes in musculoskeletal imaging. She is a senior consultant at Innovation Imaging and Nanavati Max Super Specialty Hospital in Bombay. She is an ex-lecturer at Sion Hospital and has over 35 publications in national and international journals. She has done her fellowship in musculoskeletal MRI from Singapore and has several gold medals and awards to her credit.
Thank you, Abhishek. I'll just share the screen.
Yes, ma'am.
Am I audible?
Yeah.
Yeah, okay. And my screen is visible?
Yes, ma'am.
Yeah, okay. Thanks, Abhishek, for that introduction. We are on the second day of the Oncoimaging update, where I think all the topics of the related to Oncoimaging have been covered. The topic was approach to MSK tumors, which becomes a very large area to cover. So what I have done is I'm sticking to soft tissue tumors today in this session, because bone tumors becomes a completely different topic. Soft tissue tumor imaging is very important. It's quite commonly done. And if you look at the imaging modalities, the main imaging modality is MRI and ultrasound. So superficially located lesions, ultrasound is useful. MRI is good for the spatial and the contrast resolution. Radiographs have a limited role to play. Yes, they can show you calcification within the lesion. They can show you if there is underlying bone erosion or not. But other than that, they do not help to characterize the lesion. CT, again, similarly, may not help in characterizing the lesion, but only helps in showing you calcification, ossification, or underlying bony involvement. So MRI and ultrasound are the mainstay. Now, one interesting thing about soft tissue lesions, soft tissue tumors is the general rules don't apply to it. For example, in bone tumors, we all know something which is well-defined, slow growing is benign. As against that, ill-defined, more rapidly growing is malignant. But in soft tissue tumors, that doesn't matter. You can have a well-defined lesion, which could be malignant. You can have a lesion which has been there for some years and now is suddenly increasing in size, and that may not be benign. So the general rules of well-defined versus ill-defined, slow-growing, fast-growing do not exactly apply here. So now, when we look at soft tissue tumors, they can be from any of these tissues. They could be from the fat, from the vessels, fibrous tissue, neural tissue, or muscle tissue. And when you look at soft tissue lesions, today I'll be talking on MRI. I'm not going to be covering ultrasound really in this. When you look at MRI, there are two kinds of soft tissue lesions. The ones where you can make a diagnosis and the ones where you cannot make any diagnosis, as simple as that. But what is important is to be able to distinguish between these two, because when it is not of a determined etiology, you need to make sure that a biopsy, a tissue sampling has to be done to exclude the possibility of an aggressive malignancy. So there are certain conditions where you can for sure make the diagnosis. We'll discuss that. And many other times when you cannot make a diagnosis, the role of MR would still be important to talk about the extent of the lesion, which compartments it's involving, but the diagnosis would still be indeterminate on MR and a biopsy would be essential. So the conditions which can be diagnosed with confidence on MR could be hemangioma, what is now known as low flow venous vascular malformation, myositis ossificans, lipoma and liposarcoma, peripheral nerve sheath tumors, abscess, bursitis ganglion. Okay. Other than this, other lesions, you may say that it's a sarcoma, but which particular one may not always be possible. You can try to hint at it, but may not always be possible. Before looking at imaging, it's very important to know the history, age of the patient, change in the size of the lesion. Is it single or are there multiple conditions like neurofibromatosis? You'll have multiple lesions. Has there been a recent trauma? Now, again, this history can be a little controversial because when you ask somebody leading question, is there trauma? Is there trauma? Most of the people will end up saying, yes, there is some trauma. So is the trauma significant enough to have caused this particular swelling? Is it mobile or is it fixed to the underlying structures? That would be important. What is the overlying skin look like? Is it inflamed? Is it red? Or does it have a bluish discoloration? This would be important. Next, you want to characterize where is the lesion located. Is it within the muscle or in the intermuscular plane? Is it adjoining the joint or in the joint? Is it subcutaneous? Is it in relation to the tendon or is it in relation to the neural structures? So these are the things before you even look at the imaging findings, the characteristics, you look at these particular findings. Sequences, we need to do T1 and T2 weighted image. STIR or FATSAT T2 would be essential to look for whether it, and when you are trying to distinguish fat from subacute blood, remember STIR is not the best sequence because STIR can sometimes suppress subacute blood too. So make sure you get a FATSAT T1, fat saturated T1 weighted image to distinguish fat from hemorrhage. Contrast should always be given. If somebody is not able to afford contrast and you want to distinguish whether it is solid or cystic, an ultrasound would help. But otherwise, giving contrast would be important. Coil, always use a surface coil so that you get good resolution images. Place a marker at the site of the pain or swelling. A vitamin E capsule or other available markers can be used. Except conditions like glomus tumor in the finger, you don't want to place a marker because they are such tiny 2 millimeter ones, and you place the marker, it gets all squashed. You can get artifacts like phase wrap artifact, inhomogeneous fat suppression, susceptibility artifacts. So all of them you want to avoid as far as possible. So now let's look at cases. Here's somebody who's come with a swelling in the forearm just below the elbow. Plain radiograph shows this lucency here, a lesion. There is no involvement of the bone. There is no calcification. And we know that this lucency looks like fat. So we are thinking of a fat containing tumor. On T1 weighted image, it is hyperintense. And on fat saturated sequence, it is homogeneously suppressed, suggesting it is fat. Post contrast image, it just shows very subtle peripheral enhancement. There are no solid areas. There are no thick septations, no areas of heterogeneity. So this is what fits into a lipoma. Now, sometimes it may not be that simple. This again is a lipoma where you can see it is T1 hyperintense, getting suppressed on fat-sat sequences, but there are some these very ill-defined, hazy, hyperintense area, if you see here, showing slight minimal enhancement also, but predominantly it is very hazy, fluffy area, not exactly like a solid component. Now, this can just happen because of some area of inflammation or fat necrosis in lipoma and does not mean liposarcoma, just small ill-defined areas. So lipoma is the most common soft tissue tumor. You can diagnose it definitely on MR. It can have changes of necrosis, calcification, inflammation, and these can lead to confusing appearance on the image. Here's another case, a patient who's middle-aged person who's come with increasing swelling in his lower thigh. And what we can see is a very heterogeneous lesion on the FAT-SAT T2-weighted image. And you can see this lesion is located in the posterior compartment of the thigh. So it's important to know the compartmental anatomy to describe with respect to that, know which other compartment it's involved. And when we look carefully on T1, the rest of the lesion is hypointense. But here, peripherally, you have a T1 bright area, which is fat. It is getting homogeneously suppressed on this. So this is fat within the lesion, and that tells you that this could be liposarcoma. But remember, liposarcomas may not have fat because the rest of the heterogeneous tissue may be too much and the fat may not be seen. But when we are seeing fat and areas of heterogeneity, solid component, we know that this is liposarcoma. So this is the second most common soft tissue sarcoma, common in extremities, especially thighs, seen in adults. You have multiple varieties, well differentiated, dedifferentiated, myxoid, pleomorphic, mixed. So these may not show that much of fat component. They will have thick septas and the solid components which enhance. And if you look at it, fat will be less, all these additional heterogeneous soft tissue component will be more. Here's another example. And now what can you see? You can see a very heterogeneous lesion with areas which are solid. And here you can see areas which are more bright, areas which are less bright on T2-weighted image. On T1, it is showing heterogeneous appearance. And on post-contrast, it's the peripheral area which is showing enhancement. And this was myxoid liposarcoma. So this is all the myxoid component, which is bright on T2, almost cyst-like, and does not enhance on post-contrast images. So here you don't see too much of a fat component. These are large, well-defined, multilobulated, intermuscular usually. Fat will be very less, so you may not really be seeing them. But remember, this is a liposarcoma. You may have just a myxoma, which will look very much bright like fluid and mimics a cyst. So if you have a lesion which is looking almost like a cyst, but it's not in the expected location of, say, Baker's cyst or a known ganglion, there is no thick wall or surrounding edema. It has barely perceptible wall. And when you look carefully, you'll see some little soft tissue-like appearance inside. Ultrasound would be very helpful to detect whether it is solid or cystic. Think of a myxoid neoplasm. Contrast enhancement, again, in a myxoid lesion may be from very minimal enhancement to more areas of heterogeneous enhancement to not much enhancement. This is another case. And on the radiograph, all that we see is soft tissue intensity here. You can see here, no bony involvement, no calcification thing. This is the MR of the same patient. And what we can see is there is a lesion which on T2, peripheral more bright area and central less bright area, like a target-like appearance. And it is elongated along the tibial nerve. Here you can see on T1, it is isointense. There is fat planes surrounding it are maintained. On contrast, you can see enhancement. So this is quite classic for a peripheral nerve sheath tumor. Whether it is neurofibroma or schwannoma may be difficult to say. Neurofibroma is more central and shows target appearance. Schwannomas are peripherally located because they arise from the sheath of the nerves. So target appearance, where you have a central different signal intensity and surrounding peripheral different intensity. And another appearance is the split fat sign. So you can see on T1 weighted image how the fat is getting split around it. The fat plane is still maintained. So that's a peripheral nerve sheath tumor. But remember, you may not always be able to distinguish a benign from a malignant nerve sheath tumor on imaging. So if there is something which looks like a nerve sheath tumor but shows recent increase in size, shows recent increase in pain, be careful that it could be a malignant peripheral nerve sheath tumor too. Here's another case. a patient has come with some recurrent episodes of pain in the shoulder and some swelling like feeling. On T2-ated image, this is again T2 fat sat, and this is T1. You can see this lesion has multiple spaces, multiple channel-like appearances, what you can see here. Inside them, you have these hypointensities, which are like phlebolith. On T1, they are slightly bright. Again, there is no edema around it. It's not invading the surrounding structures. You can see fat interspersed, fat intensity areas. This is classic of low flow venous vascular malformation, which was earlier termed as hemangioma. Okay. The correct term for that now is low flow venous vascular malformation. And these are very common, seen. They may be asymptomatic. They may be symptomatic when the phleboliths form because of thrombosis within these areas. There may be trauma to this, and that can lead to pain. So here you can see all these phleboliths characteristically seen these areas of density like this due to thrombosis within these areas. And this here is the low flow venous vascular malformation. On T2, it is bright. And on T1, so you can see the fat interspersed between these areas. It is, the fat is still seen in between, and this is a low flow venous vascular malformation. Sometimes they can involve the underlying bone. There can be a reaction of the bone. So here you have solid periosteal reaction here in the distal radius, and MR shows you an ill-defined low flow venous vascular malformation. So when you have a vascular malformation, you classify them as high flow or low flow. High flow are the ones with signal void areas. They are the AV malformations, AV fistulas. Low flow are venous, lymphatic, venolymphatic, or capillary. So the role of MR is to talk about the extent of the lesion and also which muscles are involved. Is it going into the joint? Is there underlying bony involvement? Because if it's large and involving lots of muscles, when you do sclerothermy later, there can be contractures. Okay, so that's why you want to know the extent on MR. Here's this boy who came with right hip pain, about 8-year-old boy. And on MR, you can see a lesion with very disproportionate soft tissue edema around it. So the lesion itself is this much, but the edema is much more. And when you look on T1 weighted image, you can see a peripheral dark rim in this lesion. So significantly disproportionate edema, which is odd for a neoplasm. A neoplasm will not show so much disproportionate soft tissue edema. And this peripheral hypointense signal should alert you that this is myositis ossificans. And if you take a radiograph was not done initially in this patient, directly came for an MR, which happens quite often. But you insist on a radiograph and you can see there is peripheral ossification. This is myositis ossificans. Could be related to trauma, may not be, trauma history may not always be evident, but the ossification extends from periphery to the center. Then it becomes a more ossified mass. Tumor will show more of central ossification and more chunky ossification. So it's localized, non-neoplastic, heterotopic ossification in the muscle. You have multiple stages and zonal phenomenon. So even on ultrasound, you can see the 3 different zone-like appearance, which is important. And the ossification begins peripheral. Okay. And a radiograph, as I said, would make things easy, or you can take CT cut there if it's very early. Because if you biopsy these lesions, even the pathologist will get confused and may call them osteogenic sarcoma. Here's someone, and there was some asymmetry in the chest wall for which scan had been done. And what you can see is, you can see this lesion out here. This here is the serratus anterior, and this is the subscapularis. Between them on the left side, there is a lesion, iso-intense. On T2, it is hyperintense. It may be iso or hyperintense. This location is very characteristic of an elastofibroma. It's a benign fibroelastic tumor. The location is very characteristic, deep to the latissimus dorsi and the rhomboids major, adjoining the infromedial border of the scapula. This is another case with pain and swelling along the arm. What MR shows is there is a T1 hypointense lesion, and it has got very spiculated margins. On T2, it has some bright areas, but also very dark areas. Again, the spiculated margin is identified well. On post-contrast images, again, this peripheral spiculated margin. Dark signal and spiculated margins tells you this is fibromatosis. So deep fibromatosis, it's also called as desmoid tumor. It can involve the abdominal wall. It's a locally aggressive. It's a benign lesion, but it's locally aggressive. And it has got an infiltrative spiculated kind margin and a facial tail. So this is what is called as a facial tail. So along the fascia, you have the speculation. Sometimes these can be quite extensive, like here in this patient, it was involving the rectus abdominis on the right side, as well as along the iliac vessels, and showing enhancement, and it was going into the inguinal region. So again, the clue is the dark signal on all the sequences. T2 as well as T1, dark signal. On contrast, they usually show enhancement. Another case with pain and swelling in the foot. And now you can see a similar darker looking lesion in the plantar compartment of foot, heterogeneous and adherent to the plantar fascia. You're not seeing the plantar fascia separately from it. And this lesion is again fibromatosis. So you can have superficial fibromatosis, which can be along the plantar or the palmar fascia. This is a very large lesion. Normally you have smaller ones, plantar fibromas. This is a large lesion. But see, you have T2 hyperintense areas with it, in addition to the dark fibrotic areas. So T2 bright areas are more cellular. And what that means is there is a higher risk of recurrence even after resection of this lesion. If the lesion is more T2 dark, it's more collagenous, and the risk of recurrence would be lesser. Similarly, you can have fibromatosis coli, typically in the sternocleidomastoid of children. So this is like a neonate, and you had a swelling in the neck, and you can see this lesion, central, very dark area, which is not enhancing. And then you have cellular component peripherally in the sternocleidomastoid, well defined. This is fibromatosis coli. Another case, and you have a very well-defined lesion superficially in the subcutaneous tissue. Patient had very severe pain, especially on here on palpation, there was severe pain, very well-defined small lesion. And this can be nodular fasciitis. So along the fascia, you can have these lesions. It's a benign lesions, can be facial, subcutaneous, or intramuscular, and it can be very tender. Here's a lesion which is bright on T2. T1, it is hypointense. This is not a common location for a nerve sheath tumor for any ganglia or bursa. And on T2, it is bright, looks almost like a cyst. So this is a juxtaarticular myxoma. Here again, there is a large cystic lesion outside the medial collateral. So whenever you have a juxtaarticular cystic lesion, try very carefully tracing it to any underlying structure like the meniscus or the labrum. So when you trace it, you can see an extension going from it into the medial meniscus, which has a tear. So this is a medial meniscal tear with a large parameniscal cyst. So if you have cystic lesions adjoining the shoulder, hip, or the knee, look very carefully for any labral or meniscal tears. This is another young person with a lesion juxtaarticular. T2, if you see, it's not as bright as a cyst. You can see here. So this kind of bright is cyst, or it can be myxoid at times. It's not that bright, which tells you it is solid. On contrast, it is showing enhancement. And this is very important because this is synovial sarcoma, which you don't want to miss and call it as a bursa or a ganglion, because that will be very bad for the patient. So especially if you have a juxtaarticular lesion and you have non-specific calcification within it on radiographs, a lower extremity mass, you should always think of a synovial sarcoma as a diagnosis of exclusion. So what doesn't look clearly like a ganglion or a cyst, if it is solid, that's why you need to give contrast. It can be a synovial sarcoma, which is a misnomer. Synovial sarcoma does not arise from the synovium in the joint. It is juxta-articular. It's just that its tissue look like similar to synovial tissue. Here's somebody who's come with thigh pain, acute onset, say about few days with fever. You have a lesion in the thigh muscles. T1, it has got a bright periphery. On contrast, it showed peripheral enhancement. There is edema all around it, and this is abscess due to Staph aureus. Here again, you can see there is a foci of osteomyelitis in the bone. There is a defect in the overlying cortex, and through that, it's communicating with the large lesion. Again, it has got T1 bright periphery. This is a large abscess. This was a tubercular abscess. Another patient with recurrent swelling in the arm, small, well-defined cystic lesion with disproportionate edema around it. Again, you can see cystic lesion here with edema around it, enhancement around it. The lesion itself is not enhancing. This is cysticercosis. So you can have cysticercosis in the muscles, and that can in between get, there can be inflammation, and that can lead to recurrent pain and symptoms. This is a lesion in the muscle, and you can see multiple cystic areas, multiple daughter cysts. This is classic of hydatid cyst, not very common in muscles, but yes, we do see them. And this is one where it has ruptured and giving you this kind of an appearance. The inside the membrane has ruptured. This is a hydatid cyst. Another case, you have a bright lesion on both T1 as well as T2-weighted image in the intermuscular plane between the medial gastrocnemius and the soleus. This location is very typical for what you call as tennis leg injury. It's bright on fat sat also, bright on T1. So this is subacute hematoma. And when you have hematoma here, look carefully for plantaris tendon that could be ruptured, or there could be just an injury of the medial gastrocnemius. This is another case, lesion bright on T2, bright areas on T1. On post contrast, you're not sure whether, so another important thing is always have plain fat sat T1 as well as post contrast fat sat T1 so that you can subtract them. When a lesion is bright on T1, do fat sat T1. 1, to distinguish fat from hemorrhage. 2, because you can subtract the post contrast images to know whether there is enhancement or not. So except for the small area, there was no enhancement, but this small area was odd. This location itself, if you look at it, this is what hematoma looks like. This doesn't fit into small hematoma. Marker is placed there. There was no known trauma. So if you don't have definite significant trauma history, and if the mass is not decreasing in time in size over time on follow-up, remember it can be a hemorrhagic neoplasm. So what looks like a hematoma, if it's not fitting in the classic, there's no significant trauma. If it's not decreasing in size, sometimes you may want to follow them up till resolution. This could be a hemorrhagic neoplasm and should be biopsied. A well-defined lesion, again, indeterminate, you don't know what it is. It is in the deep subcutaneous tissue enhancing. This patient had she's a known case of breast carcinoma, and this was metastasis. So metastasis from melanoma, breast carcinoma, multiple myeloma, melanoma mets can be T1 bright. Melanoma itself can be T1 bright. That is possible. Here's a lesion along the dorsal aspect of the dorsal scapholunate interval. Pain marker is placed here. Very characteristic of a cystic lesion. So this is a ganglion. So pain marker also helps because sometimes patient may have an incidental ganglion and that may not be causing any symptoms. So putting a pain marker tells you that yes, this is what is the cause of the pain. This is a scapholunate interval ganglion. Very common. Here, there's a swelling behind in the elbow joint posteriorly. You have this large lesion which was not enhancing. It has all this synovial debris within. So this was an olecranon bursitis. So you have classic locations of bursa. These are pressure points. You can have these bursa get inflamed. You can have adventitial bursae along the plantar aspect of the first or the fifth metatarsal head along the foot. That there you can have adventitial bursa is where bursa develop at pressure points. So you can have bursa along the surface of an osteochondroma. Okay, so all of these can get inflamed. Again, a cystic lesion in the subcutaneous tissue, barely any thick wall. It's not like an abscess. There is no thick wall. And on finding out history, this patient had a motorbike injury just a month or two back. So this is what is called as Morel-Lavalley lesion. This is a shear injury. The different layers of subcutaneous tissue and then the fascia, they kind of shear against each other and you get these fluid collections. Okay, so this is a Morel-Lavalley lesion post-traumatic. Here this patient came with a swelling and symptoms similar to tarsal tunnel syndrome. When you look at T1 as well as T2-weighted image, all the images, this looked just like muscle, just iso-intense. And when you trace it, this was an accessory muscle, accessory flexor hallucis muscle. So you have a large number of accessory muscles, and this is the tarsal tunnel here, which it is close to. That's why it was leading to neural impingement and tarsal tunnel-like syndrome. This is the pain marker again. So always place pain marker in these. Similarly, again, somebody felt a swelling on the back of the hand, and you can see this muscle, it's muscle intensity. It's not too bright on stir. This was extensor digitorum brevis manus, which is an accessory muscle. So if you find something which looks very similar to muscle, go search, and you may find the accessory muscle out there. So to summarize, soft tissue lesion characterization is always not possible. MR is the best imaging modality for lesion characterization. Yes, ultrasound can be a good modality in superficial locations, but it may not always be possible to characterize on ultrasound. MR with contrast would be ideal. If you systematically use the available clinical history, location of the lesion, radiographs to look for calcification or bone changes, if any, and the MR features, you can differentiate between the determinate and the indeterminate lesions. And very clearly, the indeterminate lesions need to go in for biopsy to exclude a malignancy, a sarcoma. So the clue is look for T1 weighted image. If T1 it is bright, it's either fat or blood. So look for T1 fat saturated image. If it gets suppressed, it's fat. If it doesn't get suppressed, it's blood. So accordingly, it's hematoma or it is fat. It's a fat containing lesion or a hemorrhagic lesion. Next, look at T2. Is it cystic or not? Remember, what looks like cystic can be a myxoid lesion also. You need to give contrast. Contrast also helps us to look at these solid areas because that's where you have to do the biopsy from. You should not do biopsy from the cystic or the necrotic areas. You want to do biopsy from the solid areas. Next, look at the contrast enhancement. Is it enhancing peripherally? Is it showing central heterogeneous enhancement? Is there no enhancement? So T1 weighted image first, followed by T2, and post contrast. Together will help you make a diagnosis. And if you're not able to characterize a lesion as benign with certainty, you should report it as indeterminate and a biopsy should be done rather than report something as a ganglion or a bursa if it's not in the characteristic location. See, like for example, Baker's cyst, you know the typical location. If it's not in the characteristic location and if it's not clearly cystic, be sure that you don't label it as a ganglion or a bursa because that may be something like a synovial sarcoma. And if you do not biopsy, that may be missed. So by following these kind of rules, you can try and narrow down your differential diagnosis significantly and make sure that you are making a difference in the patient management. Thank you very much. Any questions? I would be happy to answer.
Thank you so much, ma'am. Just one question. Should DCE MRI be used for soft tissue tumors?
Okay, so dynamic. See, dynamic contrast, what happens is usually when we give contrast, we are any which way is giving contrast. So it's always a good idea to do a dynamic sequence so that you get an arterial phase also. You can look at what is happening, especially in same vascular malformations. So you want to see in the arterial phase what is enhancing or not. So if you're going to give contrast, adding a dynamic sequence, I don't think takes any much more time. It may not help you always, but it's there. And since you have given contrast, you have that sequence, you can use it whenever you need to. Another sequence, I didn't put it too much here, but diffusion also can be used. So we use it as an adjunct to the routine sequences. We do not use it as the only sequence on its own, but that can also be used.
Okay, thank you so much, ma'am. No more questions. Just a gentle reminder to the participants, you can ask questions to the panelists in the Q&A box. So anything that you might have, please put it on there. Quick thank you again to our to Bayer for supporting our education endeavor. Taking over the next session, we have Dr. Abhishek Mahajan. He's a consultant at the Clatterbridge Cancer Center in Liverpool. He is a former consultant at Tata Memorial Hospital. He has worked at Hodgkin's Lab in London on HPV and hypoxia and head and neck cancers. He's a member of the Respond Consortium and BRAT's Challenge Consortium. He has over 250 publications, and his special interests are artificial intelligence, radiogenomics, biomarker imaging, neuro, head and neck, and thoracic imaging. So his topic for today is radiogenomics in glioma. I'll let you share screen, sir.
Is my screen visible?
Yes, sir.
Thanks, Abhishek. Yeah, at the outset, I would like to thank Patkar sir and Sikandar and the whole team, organizing team, for having me give this opportunity. I'm still connected to India and then lecturing from here, so it's nice. Feel at home always while lecturing from here. So I'm going to speak on radiogenomics in glioma. This topic might sound a little bit over the board, but I think with the recent advances in the molecular staging, which is used by the WHO for classifying the gliomas, it becomes imperative for a radiologist to understand how the radiogenomics is dealt with in the glioma by imaging, which can have correlates with the molecular status of the tumor. So gliomas, we know that they are graded on the basis of histology, but recently the molecular status has been included to grade gliomas and stage gliomas. The important mutations, which I'll be discussing subsequently, form the basis of the molecular classification of gliomas. The reason to include this molecular subtyping was that all the tumors do not behave similar, and the biological heterogeneity comes in terms from the mutations which are involved in these gliomas, and they have a significant impact in the clinical outcomes. So the clinical outcomes of two similar tumors wasn't actually similar, and that was because of the number of mutations or the hits that the tumor had an impact on the outcomes. So for that simple understanding, the gliomas are divided into two categories: the primary and the secondary gliomas. The primary are the ones which are usually seen in older population. They arise de novo. They usually have an EGFR amplification, and they do not have an IDH or IDH mutation. They usually are MGMT unmethylated. So these are the tumors which occur in the elderly age group, tend to have a worse prognosis, are larger at time of presentation. Compared to the secondary tumors, they are usually seen in younger population. They have a pre-existing low-grade, grade 1 or grade 2 and grade 3 astrocytoma, which undergoes dedifferentiation and have some certain other mutational hits such as PDGFR amplification, IDH mutation, and RB1 gene mutation that leads to formation of a secondary GBM. So why this is important is because having understood the pathogenesis and the tumorogenesis, it becomes important that different clinical behavior or the diagnostic behavior can be understood, that can become a diagnostic marker. Understanding the prognosis, that it guards the prognostic markers, and also some of these mutations have been currently used as an anti-therapy agent also, and they become the predictive markers. So for the understanding, I will just highlight what is the tumorogenesis in a primary and the secondary GBM. So if you see here, the primary neuronal progenitor cells, which are closely seen in the subendothelial region, close to the ventricle, are the ones which get tumorified, and they have IDH mutation. After the IDH mutation, if they have P53 mutation, they become astrocytomas. If they have 1p19q co-deletion, they become oligoastrocytomas. And once they have a EGFR amplification, they become IDH mutant GBMs, that is the second GBMs. If the IDH is wild type and they have direct EGFR or Fetal loss, these are the tumors which are the primary GBMs, and they are very aggressive and tend to be seen in the elderly population. They have mesenchymal signatures, and they have the secondary GBMs have the proneural signatures. So this is the usual pathology description which we used to get way back in 2014. This is a slide from Tata Memorial Hospital, where there was not much of information on these mutations, and the whole tumor was analyzed as a single entity. Because the whole tumor was analyzed as a single entity, we could not understand the heterogeneity of the tumor. And with the more advanced techniques, then the pathology report also improvised. So you can see the tumor tissue is divided into multiple parts: the marginal biopsy from one end, another marginal biopsy, cavity biopsy, another cavity biopsy. That means what the surgeon or the treating oncologist is trying to look at is the heterogeneity within the tumor, because GBMs per se can have very aggressive components, and those aggressive components have an impact on the outcomes, because the overall outcome of GBMs is under 24 months. So this whole exercise of giving these many biopsies can be challenging, and not all patients undergo surgery. Then it becomes important for a radiologist if he can tell that these are the areas which look aggressive or may have aggressive behavior or are high-grade areas. So imagine that remember all the gliomas do not undergo biopsy. Many gliomas are treated on the basis of the imaging characteristics, and our imaging characteristics can actually guard the molecular behavior and tell the treating physician or the oncologist whether these are aggressive or non-aggressive tumors. So this exercise started way back in 2018 in radiology, and where this Dian et al. Group from PNAS, they studied the different aspects, that was contrast necrosis ratio, contrast enhancement, infiltrative pattern, mass effect, and SPZ, that is subventricular zone involvement. So they found that the high contrast enhancing tumors were the ones which were aggressive. The higher the amount of mass effect were also the aggressive. These features correlated with the heat maps of the overexpression of EGFR and also with the hypoxia markers. And not only that, they found that the tumors which were infiltrative in nature on imaging had poorer outcomes as compared to the patients who had edematous area, T2 areas. So the similar finding was seen both in terms of the overall and the progression-free survival. So the first gene I'm going to discuss, I'm discussing is the MGMT gene, that is the O-methylguanine DNA repair methyltransferase gene. This gene is involved in the stability of the whole genomic sequence, and it helps into the DNA methylation of the DNA. If there is an increase in the MGMT, it's a carcinogenic risk factor, and GBMs with MGMT promoter hypermethylation are more likely to have longer survivals, which I'll show you in the next slide. So what happens is, in a hypermethylated case, the normal drug which is used for GBM treatment is nitrosoureas, that is carmazine and temozolomide. They lead to alkylation or methylation of the O-guanine at the 6th position in the DNA, and it leads to induction of cell death or apoptosis. Once the apoptosis and cell death occurs, there is reduction of the tumor volume. If the gene is hypermethylated, that means it is hyperfunctional. The DNA repair does not happen, and it leads to more apoptosis and higher chemosensitivity. So the tumors which are hypermethylated tend to have better response as the tumor which are either negative for hypermethylation or are unmethylated. Now let's look at the unmethylated tumor. The unmethylated tumor will also have the similar pathway, but because the O-guanine is functional, it will remove these alkyl groups, and the apoptosis will not take place, and it will reduce the chemosensitivity. So MGMT hypermethylation is seen with secondary GBMs. It is seen over 50% of the GBMs. It is more frequent to be associated with the 1p 19q deletion, which is a marker of oligodendroglioma. And if it is seen, it improves the sensitivity to temozolomide and radiotherapy. These tumors, this is the Brandas et al. JCO paper, which showed that the MGMT methylation hypermethylated were better in terms to the survival as compared to the unmethylated cases. Also, the tumors which are hypermethylated, they tend to show pseudoprogression. So pseudoprogression, if seen on the imaging, it's an indirect factor which tells you that the tumor might be MGMT hypermethylated. If the tumor has true progression very early in the course of treatment, these tumors are usually unmethylated tumors. So the imaging characteristics for MGMT hypermethylation are that they are commonly seen with secondary GBMs. That means you will have a slower course or a progressive course of the disease. The tumors will be seen in younger population who have a previous grade 2, grade 3 astrocytoma, which has transformed. They are usually non-temporal in location. They are mixed nodular, they show mixed nodular enhancement, and they show pseudoprogression. That is a very typical hallmark of hypermethylated cases. As compared to the unmethylated cases, they are usually seen in elderly population, which are primary GBMs. They are temporal in location because of their mesenchymal origin, and they show ring enhancement. And pseudoprogression is a rare phenomenon in this. So let's look at a mixed nodular enhancing tumor. In this particular case, vis-a-vis a ring enhancing tumor, which is an unmethylated case. The tumors which are commonly located in the non-temporal location tend to be hypermethylated as compared to the ones which are located in the temporal location with ring kind of enhancement. They are usually unmethylated cases. And as I said, that the pseudoprogression, if seen, it is a true hallmark of hypermethylated case, and these cases should be labeled as hypermethylated. They tend to show better outcomes as compared to the unmethylated because pseudoprogression is a sign of good response to therapy. So it at times becomes challenging to differentiate pseudoprogression versus true progression on the routine contrast enhanced sequences, as seen in this case before concurrent chemoradiotherapy. the patient after the CRT concurrent chemoradiotherapy developed this solid enhancement. However, on the perfusion imaging, this was hypoperfused area, which was suggestive of a pseudo progression, as compared to the other case where you see the solid enhancement, which is actually more than the previous one. However, on the perfusion scans, you can see that the areas are hyperperfused, and this is a true progression. So true progression is usually seen in unmethylated cases, and pseudo progression is seen in hypermethylated cases. Next gene I'm discussing is the IDH1 gene. The IDH1 gene is the isocitrate dehydrogenase catalase that oxidates the decarboxylation of the isocitrate to 2-hydroxyglutarate. So 2-hydroxyglutarate is a molecule which you tend to see if the patient has IDH mutation, and it can be seen on ex vivo spectroscopy. What this IDH gene does is it leads to cytoplasmic enzyme, which has a role in the NADPH production, which is the house power of the cell. So once the mutation of the IDH happens, these are usually seen in secondary GBMs, and it leads to formation of the high-grade GBMs. See, IDH mutant are usually seen in the younger population. They are seen in secondary GBMs. They tend to occur in the previously present tumors such as grade 2, grade 3 astrocytomas or oligodendrogliomas. They are usually uncommon in primary GBMs. The IDH mutation is commonly associated with MGMT hypermethylation. That means MGMT hypermethylation and IDH mutation go hand in hand, and if they are present, they favor these patients have favorable prognosis and improved outcomes. They have better sensitivity to the temozolomide. They are very uncommon in tumors which are primary GBMs, which have EGFR amplification, and overall the presence of IDH mutation is a good prognostic indicator. So IDH tumors usually are larger at the time of diagnosis, and they are multifocal. That means this was a tumorogenesis which was happening in a previously present low-grade astrocytoma. They have prevalence of cystic and diffuse components. They can be a very diffuse hemicerebric tumors. They have increased frequency of contact with the brain ventricles because they tend to occur from the neuronal progenitor cells, and they tend to have 2-HG molecule, that is the 2-hydroxyglutarate, which is the byproduct of the oxidative cycle, that is seen at 2.2 parts per million. So let's look at some of the cases of IDH mutant. They are less necrotic, multifocal at the time of presence, and they show less perilesional edema. At the same time, they can also show non-enhancing areas which are solid in nature, or they can have cystic and solid components, which are again feature or hallmark of transformation of a previously present low-grade astrocytoma. You can see the low-grade astrocytoma component is there on the contralateral side as well. The tumors tend to be larger at the time of presentation, and they have greater contact with the ventricles because of the neuronal origin of these tumors. And as I said, the 2-hydroxyglutarate molecule, which is a typical hallmark of these tumors, can be seen in this cases which is seen on spectroscopy of the brain lesions. Next marker, which is important to understand the tumorogenesis, is the Ki67 or the MIB1 index. The glioma cells, when they become highly mitotic, the high mitotic index is represented as the MIB antigen, and this represents high Ki67 values. So Ki67 is done by immunohistochemistry, and it is the MIB antigens are picked by that. The higher the MIB index, the higher is the mitotic activity, the higher is the grade of the tumor. So understand that the higher the cellularity, the higher is the mitotic activity. That means the cellularity is going higher, and there is restriction of the water diffusivity. That means they are low on ADC. So diffusion can tell you whether tumor is high grade or low grade, whether the MIB index is higher or lower. At the same time, when there is higher mitotic activity, there is new angiogenesis, and that means it leads to higher vascularity, which is the high CBV and CBF ratios. These are very classical hallmark of a tumor which is having high MIB index. So let's look at the first case, the high ADC value, which is associated with low MIB index in this particular case. That means it has higher diffusibility as compared to the non-diffusible cases. This is a diffuse astrocytoma, which was non-enhancing, but the RCBV maps are low, very hyperperfused. That means it's a low-gradish tumor. Compare this tumor with the previous ones. This is also a non-enhancing tumor, but at the same time, if you see the perfusion map, it's highly perfused. That means erroneously you can label this on the routine conventional post-contrast sequence as a non-enhancing low-grade tumor, but it is hyperperfused on the perfusion maps. That means it's a high-grade tumor. It correlates well with the MIB index. The last gene is the EGFR gene. The EGFR gene is a is a receptor actually. It has an extracellular component, a cell membrane component, and an intercellular component. It leads to activation of the tyrosine kinase pathways and other signal transduction pathways, and overall it leads to higher cellular proliferation. So once the EGFR gene is hyper functioning, that means there is increased cellular proliferation with increased activation of the tyrosine kinase pathways. And the drugs which are anti-EGFR drugs, they act on the tyrosine kinase pathways mostly at the internal receptor. And having higher EGFR proliferation is a marker of a primary GBM. It is seen in elderly patients and usually tend to have large necrotic areas. So EGFR amplification is commonly seen in primary GBMs. It is rare in secondary GBMs, and it confers an unfavorable prognosis. The various enhancing patterns I've shown over here, which correlates. So the higher the T2 to T1 ratio, the higher is the amount of EGFR amplification. That means you have a large amount of T2 component with less T1 component. It tells you that it is non-infiltrative, low EGFR mutant case. If it becomes very high bright on the T2 with large necrotic area, that means it is a highly amplified EGFR case. So let's look at what is the imaging hallmark. You do a T2 to T1 ratio, and the higher the T2 to T1 ratio, this confers the higher amount of EGFR amplification. The 1p19q genotype, which is a hallmark of the oligodendrogliomas, and now is used specifically to classify the gliomas which have this mutation into oligodendrogliomas, and they confer good prognosis, better sensitivity to radiotherapy with prolonged survival, and they are usually they melt away with chemoradiotherapy. Having 1p19q co-deletion on histology is a good prognostic indicator as compared to the partial deletion, which is usually seen in astrocytic tumor and is a poor marker. So if you have only 1p partial deletion, that means it is a poor prognostic indicator as compared to the 1p19q co-deletion. So the imaging features of 1p19q co-deletion is that usually they're non-temporal in location. That means they will be in frontal, parietal, or occipital. They on conventional MR sequences, they are more likely to have indistinct border due to the paramagnetic susceptibility artifacts and high T2 edema. They have mixed signal intensities on T2, and they are more likely to have infiltrative pattern, but they tend to show better outcomes as compared to the ones which are 1p19q non-deleted. So let's look at some cases. They have indistinct border. The border differentiation between the edema and the tumor is very difficult. Paramagnetic susceptibility artifact due to the calcification present in these tumors is a very classical sign of 1pq19q co-deleted oligodendrogliomas. And if you have mixed signal intensity with solid cystic areas with closeness to the ventricular system, that means it's a slow-growing secondary GBM. And if you compare the ADC values of these cases, the higher RCBV and lower maximum ADCs are seen with patients who have 1pq19 co-deletion. So I'll discuss two clinical scenarios here. The first clinical scenario is a molecularly where the molecular pathway revealed that the MGMT promoter gene was negative. It was IDH wild type and EGFR amplified. So if you see the tumor here, mixed nodular enhancing in the non-temporal location, which is showing a restricted diffusion and the breakdown of the fibers on tractography, high perfused, which shows high MEB index. It was a primary GBM as compared to this particular tumor, which is on the high temporoparietal location. And it shows some enhancement, but not the RCBV values are lower. It is facilitated on diffusion. And there is no 2Hg molecule seen over here, but it was actually a MGMT positive IDH mutant. Remember that in your routine clinical practice, you will not see the 2-hydroxyglutate. It has not been possible to replicate in clinical practice, and it has only been seen in the clinical research papers. So this was a secondary GBM case. You may not see all the features. You have to keep in mind the diffusion perfusion values and the spectroscopy values, which helps you into gauging the overall aggressiveness of the tumor. If you need more information, I suggest reading two of our articles, which is one of the systematic reviews on all the radiogenomic biomarkers in glioma, and the other one is also radiogenomics of the glioblastoma, which is in cancer imaging. And we have defined each and every criteria in both the publications for heterogeneity, vascularity, non-Gaussian, and metabolic changes to kurtosis, which are the parameters to be used, what are the cutoffs which are essential for predicting the radiogenomics of these tumors. Also, there is a pathway which is explained, complete pathway of the tumorigenesis and the features which are seen on imaging. I think this is beyond the scope of this particular lecture in the given span of time, but I recommend if you need more information on this topic, kindly read this topic, article. With that, I would like to conclude that given the non-invasive nature of the molecular imaging, the approach which we've used, the radiogenomics, gives you a molecular signature which is readily identifiable without doing the actual biopsy and tells you the overall tumor heterogeneity. And not only this, that we can move more individualized therapy approaches based on the imaging findings which we see and give better outcomes to the patient. So with that, I thank you for your patient hearing. Any questions, I'll be happy to take.
Thank you for taking the time, sir. No questions.
Thank you.
But if you could hang around for a couple of minutes in case
Sure,
of you
sure.
turn up in the chat box.
Thank you so much.
Thank you. Thank you so much, sir. The next talk will be taken by Dr. Ritu Verma. She is a consultant at Max Super Specialty Hospital in Vaishali. She did her MBBS from AIMS and PG from RML Hospital in Delhi. Her special interest is interventional radiology, and her topic for today is PM nuclear medicine and oncology. Can I request you to share your screen, ma'am? Ritu ma'am, can I ask you to share your screen, please? Yeah. Got it. You'll have to unmute yourself, ma'am.
Hello, good evening. Am I audible?
Yes, ma'am.
Okay, thank you so much. But the introductory slide was, I think there was a miscommunication. I am Dr. Ritu Verma, and I am consultant and head Department of Nuclear Medicine and PET-CT at Mahajan Imaging Center at Gangaram Hospital. And my topic, it's all right. My topic for today, I'll start my topic now. My topic for today is diagnostic applications of nuclear medicine in oncology. So as you know, this is a vast topic. So I have tried to just touch upon the main aspects of nuclear medicine in oncology, starting with conventional nuclear medicine, which is done on the gamma camera, and then PET-CT imaging, which is done on the PET-CT camera. And then we have also forayed quite far into therapeutics, which is termed as theranostics. So these are the three aspects of nuclear medicine that is usually present in the field of oncology. Earlier, when we started nuclear medicine, gamma camera and the scans which were done on the gamma camera had a lot of role to play in oncology, with liver scans, bone scans, HIDA scans, a lot of CT mammography. But with advent of PET scanners, most of the indications are better assessed on the PET scanner. So nuclear medicine has taken conventional nuclear medicine has taken a back seat in oncology, but still we have a few niche indications where the gamma camera and the scan which is done there is beneficial in oncology. A few of them are lung functional analysis to calculate expected FEV1 after before planning pneumonectomy or lobectomy. Again, skeletal imaging, that is bone scan to assess skeletal metastasis, and this has been the mainstay of conventional nuclear medicine to assess bone metastasis, and it's still routinely used. Thyroid is a large and a separate topic, wherein thyroid diagnosis as well as treatment with radioiodine it has its hold, and thyroid cancer treatment, management, everything revolves around radioiodine. So that's again a separate topic. Parathyroid tumor scans with detection of parathyroid adenoma with sesame B scan. This is also routinely done. DTPA, MUGA, MPI, that is myocardial perfusion imaging study. These are usually done when the patient is on chemotherapy, cytotoxic drugs, and renal function and cardiac function is assessed around the chemotherapy as well as prior to surgery planning. There is another indication of assessing lung shunt fraction prior to yttrium therapy before giving radio-labeled subsphere or thalasphere. Breast imaging with scintimammography, now with the advent of PET scan, again, this is not so routinely used. Sentinel node scintigraphy has established its hold, and now it's indicated and routinely done in a lot of malignancies. It had started with head and neck malignancy, breast malignancy, melanoma, and it is now also done in pelvic malignancies. So that again is a separate topic. And brain tumor imaging with thallium, technetium labeled MIBI and GHA, although not so routinely done now, but it still has a role to play in assessing brain tumors. So just a few images and indications of conventional nuclear medicine. So this is lung segmental analysis. This is a functional imaging of the lung, and this is to calculate expected FEV1 prior to planning pneumonectomy or lobectomy of the lung. And if we try to see whether the expected FEV1 post surgery is going to be more than 1 liter or not, because 1 liter is the cutoff margin to live a proper life after surgery without needing ventilatory aid. So this is how we calculate the lung fractions in different zones of the lung prior to lung resection, and this is quite routinely done, and it helps in assessing the lung function prior to surgery and to calculate FEV1. This is rest MUGA scan. This is also used routinely to assess the cardiac wall motion abnormality and overall cardiac function, especially if cytotoxic or cardiotoxic drugs are being used in chemotherapy. Bone scan, as you know, the workhorse is technetium labeled methylene diphosphonate, and this is how a normal bone scan looks like. And this is how a bone scan, which is showing multiple skeletal metastasis, looks like. So bone scan is not only done to assess or diagnose skeletal metastasis, it is also routinely used in follow-up of skeletal metastasis, especially if the person is on bone-directed therapy. When it comes to endocrine imaging, as I said, thyroid is in itself an entire chapter. I will not be dealing with that today. And sesame B scan for parathyroid adenoma, just a few images. This is how a normal butterfly-shaped thyroid gland looks like. And this is a vascular cold nodule. As you can see, the blood flow is increased, and vascular cold nodules have the propensity to hide malignancies in 5 to 15% of cases. So whenever we image a multinodular goiter or a goiter and we see a vascular cold nodule, then we alert the clinicians that this needs to be biopsied or FNAC'd to proceed further. So this is a sesame B parathyroid imaging scan, where we do technetium scan first and then we do the MIBI scan, and this is the subtracted image. And here we can see the parathyroid adenoma beautifully, which is obtained after subtracting technetium from MIBI scan. With nowadays we are doing SPECT CT images, so the localization of the parathyroid adenoma has become better, and even subcentimetric lesions sometimes we are able to catch, although the resolution of gamma camera prohibits us to appreciate very small lesions, 4 to 5 millimeter lesions. Well, in that case, nowadays we do have F-choline scan also, which can help us in localizing subcentimetric parathyroid adenomas or adenomas which hide behind the thyroid in the tracheoesophageal groove. So this was the extent of the nuclear medicine, conventional nuclear medicine that we do in the setting of oncology. But the mainstay of oncology is on the PET scanner. The routine tracers which are commonly available throughout India now are FDG, gallium labeled PSMA, gallium labeled DOTA, F18 bone scan, and F18 F-DOPA, which finds its use in brain tumors. So when it comes to FDG PET scan, FDG is the workhorse of the PET-CT scanner, and oncology has the maximum contribution when it comes to the number of scans. Approximately 80% of our scan is related to oncology. And today I'm going to discuss only the indications of PET scan in general. In various malignancies. It's not possible to cover all the malignancies. I will just discuss the NCCN guidelines for few common malignancies and where PET scan stands in the present day matrix of the treatment planning according to NCCN. Although it has a role to play in staging, in assessing response to therapy, in guiding metabolic biopsies, in assessing recurrence, surveillance, and screening. That means it has a role to play in almost all the aspects of treating a patient with cancer. But still, NCCN has very grudgingly given us a place only in a few cancers. The few cancers where we have a larger role to play are lung cancer, lymphoma, wherein it is indicated in almost all the stages. But the rest of the cancers like GI malignancies, breast malignancy, we still are struggling to make our place. So I'll discuss the role of FDG PET in various malignancies, the NCCN guidelines only. As we all know, the guidelines are based on these categories. Here, all the recommendations I'll be citing are category 2A unless otherwise mentioned. Starting with esophageal and esophagogastric junction malignancies, according to the latest NCCN guidelines, PET-CT does find a place in the initial staging as an option along with CT chest and abdomen, to determine the location of the primary tumor, and it does say that PET-CT has higher sensitivity than CT alone, but it has limited ability to determine or distinguish among T1, T2 and T3 tumor, but its major role is in M staging. In all the cancers, nothing can supersede PET-CT when it comes to M staging, because it's a whole body scan, so we can M stage with almost 100% sensitivity. The specificity may be poor in some cancers, as I'll discuss further. If there is no M1 disease, PET-CT also has a role in preoperative staging to understand nodal distribution prior to EUS and prior to surgery to assess resectability of the primary tumor. In radiation treatment planning also, in esophageal and esophagogastric junction tumors, it is used for estimation of gross tumor volume and field borders. During surveillance, it is indicated every 4 to 12 months for up to 2 to 3 years. In treatment response assessment, it is recommended in following pre-operative chemoradiation or definitive chemoradiation. This is category 2B recommendation. But PET-CT, we have to remember, PET-CT should always be done at least 5 to 6 weeks after the completion of radiotherapy. Otherwise, false positive results may come. These recommendations are valid both for squamous cell carcinoma and adenocarcinoma. So the standard rule is if we perform PET-CT, after completion of chemotherapy, we should wait for at least 4 weeks after completion of chemotherapy and at least 6 weeks after completion of radiotherapy. But of course, if we have to assess early treatment response, especially in cases of lymphoma, it can be done after 2 weeks of chemotherapy. It is usually, they always ask us what is the standard timeline, when should we get it done. So if we are doing an interim PET CT, that means if we are doing a mid-treatment PET CT, it should be scheduled just before the next chemotherapy is planned. That would be the ideal time for doing an interim PET CT. So this is just an example to show a localized CA carcinoma esophagus image. You can see the whole body beautifully, and this is a tumor which is localized to the esophagus. There is nothing else elsewhere. So this person can be taken up for definitive treatment, whatever is planned. This is another CA esophagus with locally advanced disease. As you can see, there is nodal metastasis as well as skeletal metastasis. So nothing beats PET CT when it comes to M staging in cancers. Coming to gastric cancer, according to the latest guidelines, FDG PET CT is recommended in initial staging if there is no evidence of M1 disease and if clinically indicated. So that means it's not indicated in all stomach cancers, and it is not at all appropriate for T1 disease. It is indicated in primary treatment response assessment, and it is indicated in restaging, that is post-treatment assessment for medically fit, unresectable tumors or for non-surgical candidates who could not undergo surgery due to renal insufficiency or allergy to contrast. It is again indicated in surveillance in stage 2 or stage 3 cancers or stage 1 to 3 treated cancer who were treated with neoadjuvant therapy. Again, it is indicated in radiation planning for determination of target volumes and field borders. So this is a CSG junction, which is also involving the cardia and fundus of the stomach. But although it's a locally advanced disease, there is nothing else elsewhere. Coming to rectal cancer, according to the latest guidelines, it is not routinely indicated in pre-treatment staging. It is only indicated when there is equivocal finding on CT scan, or a proper CT scan cannot be done due to allergy to IV contrast. Usually biopsy, colonoscopy, CT chest, abdomen, pelvis, EUS, MRI and serum CEA levels are what is recommended during initial staging. PET CT does not replace or supersede contrast enhanced CT in preoperative staging. But since we do most of our PET scans along with a contrast enhanced CT scan, I am hoping that slowly we'll replace CT chest, abdomen, pelvis with whole body PET CT with contrast CT in initial staging of carcinoma rectum and carcinoma colon. Again, in surveillance, it's not routinely indicated. It is very strongly indicated when there is when we evaluate serial rise of CEA level with non-contributory routine imaging. So whenever the CEA levels rise after completion of initial therapy and the routine ultrasound or CT scan does not reveal anything, a PET CT should be done. Likewise, in colon cancer, it is not routinely indicated in during staging. Only when there is equivocal finding on CT images or the person is allergic to IV contrast. Here in colon, in selected patients, it can be considered for image-guided therapies, for example, radioembolization or ablation. During surveillance of colon cancer, it is again not routinely indicated, but it is indicated for serial rise of CEA level and no findings on physical examination, colonoscopy and CT whole body. So whenever there is rise of CEA level and nothing else is contributing, a PET scan is always recommended. Another indication is proven or suspected metastatic synchronous adenocarcinoma. PET CT scan should be considered if potentially surgically curable in selected cases. Although it does say that there is a strong recommendation that PET CT can help detect additional sites of metastasis identified extrahepatic sites of metastasis, and if there is oligometastasis, more than less than 3 sites of metastasis which are potentially resectable, then PET scan can assist in diagnosing them. So, but for all routine purposes, we have seen that PET scan does tend to upstage or downstage the disease if done during staging, and it should be done whenever available. Again, it is indicated in assessing response with liver recurrence after image-guided liver-directed therapies, that is ablation or radioembolization. So this is just an image showing a locally limited FDG avid lesion in the rectum, rectosigmoid colon rather, but there is nothing else elsewhere. But this lesion, the primary lesion does look big, but there is nothing else elsewhere. There is some amount of perilesional soft tissue stranding on CT, but no abnormal FDG uptake outside the rectum. But here there is FDG avid lesion in the rectum. Although the primary lesion looks small, but there are multiple lesions on FDG PET in the liver. So this was FDG avid lesion in the rectum with multiple liver metastasis. So it does help in certain cases if we do PET scan at the time of initial staging. Again, in hepatobiliary malignancies, FDG PET scan has no role in either screening nor during staging, because HCC conventionally does not take up FDG. So for M staging, it is definitely indicated. One indication is if we are planning a transplant, a liver transplant, then FDG PET scan is indicated to exclude M disease, metastatic disease, prior to liver transplant. But it does not help much in staging or assessing the tumor confined to the liver, because FDG by and large does not go to well differentiated HCC. But if FDG PET scan has been done and if it does show increased metabolic activity, so that is a marker, biological marker for aggressiveness, and it may respond less to loco-regional therapy, because FDG avid hepatocellular carcinomas, they tend to be poorly differentiated, and in most of the cases they tend to be to harbor metastasis as well. So FDG PET has limited sensitivity in HCC but high specificity, and it should be considered when there is equivocal finding on triphasic CT scan or MRI, which are these two modalities are more ideal to assess hepatocellular carcinoma. Likewise, gallbladder cancer, although we know that gallbladder cancers are usually very FDG avid and we routinely use it for staging gallbladder cancers. However, in NCCN, they still haven't placed it high up. They say that role of FDG PET scan has not been established in gallbladder cancers. However, there is evidence emerging from retrospective studies that it may be useful in detection of lymph node metastasis as well as distant metastasis with otherwise potentially resectable disease. So they say that it has limited sensitivity but very high specificity, and it should be considered in whenever there is equivocal finding. So this is a lesion of the gallbladder, FDG avid lesion within the gallbladder, but here we can see FDG avid portocaval and peripancreatic lymph nodes. So this was a gallbladder carcinoma with nodal metastasis. Again, intrahepatic cholangiocarcinoma, similar to gallbladder, the role of FDG PET scan in staging has not been established well as of now. However, emerging evidence from retrospective studies say the same thing, that it may be useful in detection of nodal as well as distant metastatic disease, and it should be considered whenever there is equivocal finding on conventional imaging. However, for all practical purposes, we see that cholangio is again intensely FDG avid most of the time, and the primary tumor as well as the metastatic disease, when present, are beautifully imaged with the help of FDG PET scan. So our recommendation would still be that in GI malignancies, if you have access to PET scan, it should be done. Again, in pancreatic adenocarcinoma, according to the latest 2022 NCCN version, the role of PET-CT remains unclear in initial diagnosis and staging. They say that PET-CT may be considered after formal pancreatic triphasic CT protocol in high-risk patients to detect extrapancreatic metastasis. So, who are the high-risk patients? Patients who have borderline resectable disease. As earlier in the day, Dr. Samarjit beautifully defined borderline resectable disease. So, whenever there is borderline resectability on triphasic CT scan, whenever there is markedly elevated 90 CA19-9 level, when the primary tumor is large, or if there are large regional lymph nodes on CCT abdomen, then a PET scan is warranted. It is very well warranted when there is recurrence suspected after initial treatment. It is warranted in restaging. So this role is more or less established. Initial staging, it's still confined to high-risk patients. So this is an FDG PET scan of a person with suspected recurrence post-Whipple's with rising CA19-9 level, and here we see FDG avid disease in the operated bed, suggestive of recurrence. Lung cancer is one cancer where FDG PET scan is recommended and established now in almost all the stages of cancer, in pre-treatment staging after biopsy, along with MRI brain and bronchoscopy, in pre-surgery evaluation, either pre-chemotherapy or post-chemotherapy. It's again indicated during surveillance after completion of definitive treatment, and it is indicated whenever there is a recurrence suspected, along with MRI brain, because they say that FDG PET scan, owing to the brain being obligate glucose user, small brain metastasis may be missed on whole body PET scan. So MRI brain is routinely indicated in lung cancer. PET-CT is again recommended after radiotherapy, preferably within 4 weeks before radiotherapy to improve targeting accuracy. A randomized trial of PET-CT versus CT-only planning radiotherapy demonstrated improved preemption of futile radical radiotherapy, decreased recurrence, and trended to improve overall survival. So in lung cancer, FDG PET scan is indicated in all the stages, as I said. Another indication is risk assessment in incidental finding of nodules suspicious for lung cancer. So on the basis of FDG uptake in the nodule, we try to assess whether that nodule is potentially benign or malignant. In a high-risk solid nodule more than 8 mm in size, a CT scan is recommended at 3 months. After that, a PET scan or a biopsy is recommended in high-risk patients. The high-risk patients are patients who have a history of smoking, history of lung cancer in first-degree relative, person who give history of exposure to asbestos, radon, or uranium. 6 mm solitary part solid nodule is also considered a high-risk nodule. PET scan is also indicated before a diagnostic biopsy site is chosen in case of high clinical suspicion for metastasis in aggressive advanced stage carcinoma. It is preferred to biopsy the pathology which confers the highest stage to the cancer. That means lung cancer is one special cancer where metastatic disease is the biopsy is the preferred biopsy site rather than the primary, because it would confer the higher stage to the cancer. It will upstage the cancer. So this is the whole body PET scan of a person who had an FDG, a nodule on chest CT scan. This nodule, as you can see, is FDG avid, and it came out to be malignant on histopathology. So this is a solitary malignant pulmonary nodule, and this nodule, the size was maybe around 5 to 6 mm, but it is still showing FDG uptake, suggestive of a potentially malignant condition, and it did came out to be malignant. Vis-a-vis this treated case of carcinoma esophagus presented with this lung nodule on CT scan. But as you can see here, there is no FDG uptake, and we said that it is likely benign, and it was biopsied, and indeed it came out to be benign. So FDG uptake in lung nodule does give us some indication of it being potentially malignant or not. Coming to gynecological malignancies, according to the recent NCCN guidelines, let's start with carcinoma cervix. In staging of carcinoma cervix, if a non-fertility sparing surgery is to be considered, a whole body PET scan is indicated in FIGO stage 1B1, 2 and 3. But if fertility sparing surgery is considered, whole body PET scan is considered in FIGO 1B1 and 1B2. In stages 2 to 4, whole body PET scan is indicated to evaluate metastatic disease. For patients who underwent total hysterectomy with incidental finding of cervical cancer, consider whole body PET CT to evaluate for metastatic disease, and pelvic MRI to assess pelvic residual disease. So this is the role of FDG PET CT in carcinoma cervix staging. During surveillance, if the person had stage 1 cancer and had undergone non-fertility sparing surgery, patients who had FIGO stage 1B3, or patients who required postoperative adjuvant radiation or chemoradiation due to high risk factors, either due to positive nodes, positive parametria, positive margins, or local cervical factors, a whole body PET scan may be performed at 3 to 6 months after completion of treatment. In subjects who had stage 1 cancer and had undergone fertility sparing surgery, FDG PET scan is not indicated just to avoid radiation to the pelvis. A pelvic MRI with contrast 6 months post surgery and then yearly for 2 to 3 years is indicated. Other imaging should be based on symptomatology and clinical concern for metastatic disease. So this was about cervical cancer and stage 1. In stages 2 to 4, whole body PET scan is preferred during surveillance or follow-up as compared to CCT chest, abdomen, pelvis with contrast within 3 to 6 months of completion of therapy, along with pelvic MRI with contrast. Whole body PET scan is indicated whenever there is clinical suspicion of recurrence or metastatic disease beyond this timeline of 3 to 6 months. That means whenever it is suspected, even if it is suspected at 1 to 2 months post surgery or post treatment, it can be repeated. The guideline is PET scan is to be repeated whenever there is clinical or ultrasound or any imaging suspicion of metastatic disease. So this is an FDG avid lesion in the cervix infiltrating the lower uterine segment. Although there is no involvement of the parametria on this scan as well as on MRI, there was no involvement of the parametrium, there was no nodal involvement, but as you can see there is an FDG avid lesion in the sacrum. So this was a metastatic disease. So sometimes we do end up finding googlies, although the local imaging may suggest regional disease. Coming to CA vulva, squamous cell carcinoma vulva, FDG PET scan is indicated during initial staging in T2 or larger tumors, or if metastasis is suspected. For the condition, the conditions are abnormal physical findings, bulky vulval tumors more than 4 centimeter, close to critical structures, vaginal, urethral or anal involvement, delay in presentation or treatment, and pelvic, abdominal or pulmonary symptoms. So whenever any of these criteria is fulfilled, a PET scan is recommended. So during follow-up and surveillance, along with CT chest and abdomen, this can be an option to assess recurrent disease, and or whenever metastasis is suspected, it can be done. So this is a 54-year-old lady with recently diagnosed lesion in the vulva. As you can see, the primary lesion is so small. There was another lesion in the cervix, and there was an FDG avid left inguinal lymph node. So PET scans, just because it's a whole body scan, it may end up spotting synchronous or malignancies and unexpected sites of nodal as well as distal metastasis. Coming to endometrial carcinoma, PET scan is recommended during staging when non-fertility sparing, whether non-fertility sparing or fertility sparing treatment is being considered. PET scan is recommended only if metastasis is suspected in select patients. So it is not a part of routine staging, but whenever metastasis is suspected, either due to clinical complaints or due to some suspicion on any other imaging modality, a PET scan is recommended. During follow-up and surveillance, imaging should be based on symptomatology and clinical concern for metastatic disease. And for suspected recurrence, consider whole body PET scan in select patients who may be candidates for surgery or loco-regional therapy. So in potentially resectable candidates, PET scan is again recommended to exclude distant disease before performing regional surgery. So this was a 54-year-old postmenopausal lady with her FDG avid mass lesion in the uterus. But here we can see that apart from pelvic lymph nodes, there are lymph nodes, there are retroperitoneal lymph nodes as well as left axillary lymph nodes. So cancer, we are taught that cancer do not read books. So axilla is no place for a metastasis from the uterus, but we never know where it will end up because of the tumor biology and tumor heterogeneity. So this left axillary lymph node was biopsied and it did turn out to be metastatic. So although the guidelines do not recommend PET scan in initial staging of carcinoma endometrium, but still whenever it is possible, it should be done, especially in large regional tumors. In uterine sarcoma, consider whole body PET scan during staging to clarify ambiguous findings on other conventional imaging modality, or if there is concern for metastatic disease. Again, surveillance and follow-up PET scan is indicated whenever there is metastasis suspected in select patients. Here, there is a 71-year-old lady with recently diagnosed sarcoma, uterine sarcoma. There is lesion in the uterus and nothing else elsewhere. So she can safely taken up for surgery. In ovarian cancers, PET scan does not have a very large role to play in characterizing adnexal masses and in staging of ovarian cancer, although it is being routinely used, but NCCN still does not confer a place in staging. It is indicated very strongly whenever there is recurrent disease suspected in the face of rising CA-125 levels. So this is one established indication of FDG PET scan in CA ovary, wherever there is rising CA-125 level in a primarily treated case of carcinoma ovary. However, it may have a role in treatment response assessment and follow-up. Early peritoneal metastasis can be picked up very beautifully on a PET scan, especially if a baseline PET scan is available. So, as you can see, these are PET scans of the same lady. This was a pre-treatment PET scan. This is a PET scan after treatment with rising CA-125 level. This is a contrast enhanced CT, but there is nothing here as of now. Later on, when the disease would progress, there may be more metastasis, but PET scan is very good in picking up early metastasis in carcinoma ovary with rising CA-125 level. This is also acknowledged in NCCN guidelines. So this is now there are papers now which say that there is no statistical difference found between the patients evaluated with PET scan or second look laparotomy for evaluation of peritoneal spread. Therefore, PET scan may be used as an alternative to avoid too many surgeries. In lymphoma, again, lymphoma is now wholly acknowledged and established role of PET scan in all stages of lymphoma, both Hodgkin's and non-Hodgkin's. Initially, it was recommended only in Hodgkin's lymphoma, but now it has found a place in almost all sorts of lymphoma except for a few cases of lymphoma which are known to be not FDG avid, and that is usually decided after they give doing the initial PET scan. And if the primary disease is not FDG avid, then these patients are not followed up on PET scan and rather followed up on conventional imaging. But by and large, the garden variety diffuse large B-cell lymphoma and Hodgkin's lymphoma, all the stages, the interim response assessment as well as surveillance and follow-up is routinely done with the help of FDG PET scan. And another use is in restaging in refractory disease or suspected relapse. In stage 1 to 4 lymphoma, interim PET scan is recommended after 2 cycles. If the dual score, which is usually done scored, if we have a baseline PET scan, we score the patient during response assessment, and if the dual score is more than 4 to 5, then again repeat PET scan after another 2 cycles is recommended. Usually interim PET scans are done at 2 cycles, and then another PET scan is only recommended at the end of therapy. But if the first interim PET scan has shown dual score of 4 to 5, then a repeat PET scan after another 2 cycles is recommended in lymphoma. So during follow-up, documentation of complete response, including reversion of PET to negative within 3 months following completion of therapy is recommended, and a follow-up is recommended up to 5 years. PET scan is only recommended during follow-up if dual score was 4 to 5 or above. Otherwise, whole body CT scan can also be done. Due to a small risk of false positives, PET scan is not routinely recommended, and management should not be based on PET scan alone. Any new lesion or any new site of FDG uptake should always be either biopsied or followed up before altering management. So this is just to show in one slide how PET scan helps in response assessment. This was a child with Burkitt's lymphoma, extensive disease here, and this is post chemotherapy, and during surveillance also he is doing well. So PET scan can be used for response assessment and surveillance due to small radiation risk. In children, we try to avoid contrast enhanced PET scans during surveillance period, and we try to minimize radiation as much as possible by taking only images whatever is required, and lowering the CT values of the CT current so that we give less radiation. In breast cancer, unfortunately, breast cancer, it is not routinely recommended in stage 1, 2 and operable stage 3 breast cancer. And it is only recommended in inoperable stage 3 and above. So they say that routine systemic staging, that means routine FDG PET scan, whole body, is not indicated for early breast cancer in the absence of symptoms. But if it is done and if it does show metastasis, especially bone metastasis, a separate bone scan is not recommended. This would suffice as evidence of bone metastasis. And FDG PET scan is most useful in situations where standard staging studies are equivocal or suspicious, especially in the setting of locally advanced or metastatic disease. PET scan may also be useful in identifying unsuspected regional nodal disease or distant metastasis in locally advanced diseases. So in inoperable stage 3 and stage 4 and above, PET scan is routinely indicated. It's also indicated in locally advanced disease, but in stage 2 and below, it's not routinely indicated unless there is a clinical or suspicion on a conventional imaging modality like ultrasound of a metastatic disease. But just to disprove my earlier point, I'm showing you this image. This is a dense breast, and this side is already operated, and this is a small tiny lesion here that we picked up on routine surveillance for the breast cancer of this side. And although this lady was undergoing routine mammography and MR mammography, but owing to the dense breast, this lesion was not picked up on conventional mammogram. But we picked this up, and it was lying so deep inside the breast, and it was hidden, it was asymptomatic, and it was so tiny, 4 to 5 millimeters, and an image guided biopsy was done, and it came out to be a metachronous site of malignancy. So PET scan, we say that it should be done whenever possible and whenever it is monetarily allowed. So the take-home message is that the conventional nuclear medicine still has a niche role in oncology, and FDG PET scan is steadily gaining a place in the NCCN treatment matrix, and we hope to establish ourselves more in the NCCN guidelines. Actually, the guidelines are governed by the government policies and also the cost factor. And it's not like India. Indians are more lucky; they can get whatever scans they want without much hassle. So we hope to find a better place in the NCCN treatment matrix in the future. With newer digital PET-CT scanners with less dose and shorter imaging time, with resultant lesser radiation dose, the response assessment and surveillance is going to become better, and with lesser overall radiation dose to young people. So we hope that FDG PET scan finds a better place in NCCN guidelines. And last but not the least, this is a separate topic, but the future of nuclear medicine lies in theranostics. And we got approval, FDA approval for lutetium labeled PSMA for treatment of metastatic prostate cancer. The treatment for neuroendocrine tumor is already there in place. So with more and more radioisotope guided imaging as well as radioisotope guided treatment, we hope to play a more important role in oncology. Thank you.
Thank you, ma'am. Just the one question.
Yes.
To differentiate between high grade and low grade gliomas, other than low ADC value and high CBV for high grade, are there any other differentiating features?
I think you have asked the wrong person. I think Dr. Abhishek should answer this question. My talk was on FDG PET scan and high-grade gliomas. Traditionally, if you want to know what is the role of FDG PET scan and DOPA scan in glioma, I can tell you that usually conventionally they used to say that high-grade gliomas they tend to be more poorly differentiated, then FDG can be considered a surrogate biomarker because it usually accumulates in high-grade gliomas. But nowadays this theory is not totally correct. We have seen a few high-grade gliomas which do not take FDG uptake, and we have seen few low-grade gliomas which do take up FDG. So on the basis of FDG, it's very difficult to differentiate. But few classic high-grade gliomas, they do tend to be more and more FDG avid, and low-grade gliomas, they are not FDG avid, or in fact they are hypometabolic. They are less than the surrounding brain, and as you know, brain is an obligate glucose user. So the tumors which are isodense or isometabolic to the brain, they are not picked up on FDG. They F-DOPA, ammonia, and these are the amino acid tracers are more suitable to assess brain tumors rather than FDG. But by and large, for classic tumors, FDG avidity means the grade should be higher, although it does not hold true all the time.
Okay, thank you so much, ma'am. My apologies again for the mix-up. Moving on to the next lecture for today. We have Dr. Sunita, who is a senior consultant in the Department of Nuclear Medicine in AIG hospitals in Hyderabad. She has been practicing diagnostic and therapeutic medicine for the past 12 years, and she has worked across the country in places including Chandigarh, Tirupati, Bangalore, Hyderabad, and Gurgaon. The special interest is in functional hepatobiliary scintigraphy in patients planned for major liver resection, therapeutic nuclear medicine, nuclear cardiology, and nuclear oncology. She's an executive member of the Southern chapter of the Society of Nuclear Medicine. And her topic for today is PET-CT in gastrointestinal malignancies. Can I request you to share your screen, ma'am? Ma'am, you'll have to unmute yourself, please.
Thank you, Dr. Abhishek. Today, my topic will be on role of PET-CT in GA malignancies. So I work in a GA center. It's predominantly a GA center, though it is a multi-specialty center. So we do see cases around 80% of our cases around GA malignancies. So my topic is easy because Dr. Ritu Verma has already explained in detail regarding the NCCN guidelines regarding the role of PET-CT in GA cancers. So I will just touch upon the basics of PET-CT and then go in detail regarding all the GA malignancies. What is the workhorse of nuclear medicine, that is radioactive material which is available, and then later on the other radioactive material which are used in the case of GA malignancies. So this is my overall talk. It will be like introduction, that is what are the basic advantages of PET-CT, why PET-CT is used. Next, what are the various radioactive radiopharmaceuticals that are routinely available in our hospital, and also how patient is prepared, when to plan the PET-CT. These are all very important. In nuclear medicine, history is very important regarding the patient, so that appropriate report can be issued. Regarding the GA malignancies, I will discuss in detail regarding all the malignancies and also the miscellaneous like neuroendocrine tumors and GIST, and a little bit about other radioactive material like DOTA and also FAPI. So the points of discussion in GA malignancies will be first initial staging, therapeutic response assessment, and RT planning, recurrence assessment, and in few malignancies in diagnosis. Otherwise, nuclear PET-CT has no role in the case of diagnosis. So what is the advantage of PET-CT? PET is nothing but positron emission tomography. It's highly sensitive. This is the basic advantage of PET-CT, and it is highly quantitative. And the other major advantage is temporal monitoring, that is we can assess the response assessment, but it has its own disadvantages like radiation. If we use a typical contrast enhanced CT with the 10 to 12 millicurie of FDG, the radiation is around 15 to 18 millisieverts. And the other biggest disadvantage is a cyclotron facility should be available nearby, because most of the radioactive material has a very short half-life. So either in-house or nearby cyclotron facility is required. And spatial resolution is relatively low with a newer PET images around 0.3 means around 3 mm lesions can be detected. These are all the various diagnostic and therapeutic nuclear radioactive material available. So my discussion will be only on the diagnostic radioactive material. Among these first 5 are cyclotron produced and the lower 3 are generator produced. My point of interest is F18, which has a half-life of 110 minutes. This is the workhorse of nuclear medicine. This is the most commonly used. We use almost 90% of our scans using fluorodeoxyl glucose labeled with F18. The next is gallium-68. It has the main advantage is it's a generator produced, that is in-house generator facility can be available with a half-life of around 230 days. So we can produce whenever we require, and it has a half-life of 68 minutes. So these two, I will stress upon these two. So what is the advantage of fluorodeoxyglucose? It utilizes glucose metabolism, and it is a marker of tumor glycolysis, and the uptake is proportional to the GLUT receptors. So let's see what is the difference between the glucose and fluorodeoxyglucose. So this is the structure of glucose. In glucose, this OH is replaced with F18. So only one molecule is replaced. So fluorodeoxyglucose is similar to the glucose. So better we have to prepare patients because this acts as a a COMT2 inhibitor. Then what is the difference? What is the main mechanism of fluorodeoxyglucose for tumor imaging is metabolic trapping. Means glucose and fluorodeoxyglucose, the uptake is taken up similar to the glucose using GLUT receptors, and once enters into the cytoplasm, it undergoes phosphorylation. But it is not further enter into the glycolytic pathway. That is, this is called metabolic trapping. So what are the various mechanisms of uptake of fluorodeoxyglucose is? It is a dynamic balance between the increased transporters or increased phosphorylation or decreased phosphatase activity. These three mechanisms helps in the increased uptake of fluorodeoxyglucose in majority of high-grade malignancies. So because fluorodeoxyglucose is similar to glucose, better the patient is prepared in a very good way. That is, fasting at least 6 hours is required. Otherwise, the endogenous glucose acts as a COMT2 inhibitor, and also this glucose induces insulin production. This causes increased FDG uptake into the muscle. So semi-quantitative parameters are also becomes low, and erratic values will be there. And we should be cautious that intravenous dextrose or parenteral nutrition should be withheld. And at the time of injection, we routinely check the glucose levels. If the glucose levels are more than 300 milligram per deciliter, better to postpone the patient, because if we drastically reduce, electrolyte imbalance may be there. So if it is between 200 to 300, we inject intravenous short-acting act rapid and check the sugars after 1 hour. If the sugars are less than 200, then we inject, and the waiting time is around 45 minutes to 1 hour, and the scan time with our time of flight PET CT is around 3 to 4 minutes. And there is some appropriate timing for PET. So if the patient had undergone biopsy, better to wait for 1 week, because post biopsy inflammatory changes may be there. Or we can just, if we have the history, we can mention that biopsy changes are there. Otherwise, it becomes as a false positive. If the patient had undergone surgery, better to wait for 6 weeks at least. And if the patient had undergone chemotherapy, better to wait for 4 to 6 weeks. Or in the case of interim response, that is, if we want to know whether the patient is responding or not and planning PET CT after 2 to 3 cycles, better to plan the day before the next cycle of chemotherapy. And in the case of post radiotherapy, better to wait for 12 weeks to avoid post radiotherapy inflammatory changes, that is, false positives may be seen. So in nuclear medicine, each radioactive material has physiological uptake. So whenever we say any radioactive material, please note the physiological distribution. In the case of FDG, there is an intense uptake in brain, because brain depends exclusively on glucose, and the route of excretion of FDG is through urine. So variable intense uptake is seen in the kidneys and urinary bladder. So before the scan, the patient is asked to void the urine, and also during the waiting time, we ask the patient to drink at least 1 to 2 liters of water and void frequently to reduce the radiation exposure, and also to for background clearance. These are the advantages we by giving fluids, that is only plain water or oral contrast mixed with the water. So now coming on to the various GI malignancies. So I will just touch upon a few case scenarios, because Dr. Ritu Verma has already spoken about NCCN guidelines. So I will just mention about the level of evidences and where exactly it is useful in each type of malignancies. So first, coming on to the esophageal or GE junction malignancies. So in a case of initial staging, whether it is a resectable or unresectable, that is the T and M endoscopic ultrasound is, and contrast enhanced CECT is sufficient. So PET CT is useful only in the case of locally advanced disease to rule out metastatic disease, and also in the case of normal sized lymph nodes. So in all the malignancies, this is the basic scenario. If it is by CT wise, if it is a normal, then PET CT, if it is increased uptake, it has a high suspicion of malignancy. And also in the case of differentiating inflammatory and metastatic disease, in these cases PET CT is quite useful. And it's an unsuspected synchronous. Nowadays PET CT is done for staging, restaging. We do see synchronous malignancies, and especially in the case of esophageal malignancies, around 5% of the synchronous malignancies is there. This is just an incidental finding. Next, for endoscopic ultrasound is the gold standard to know the T staging. For N staging, contrast enhanced CT, it has limited role, especially in the case of celiac axis. And EUS is better compared to the CECT to know the depth of the tumor. So what is the various summary of evidence of PET-CT is it performs well, better than morphological imaging, detecting regional and distant lymph node mets, and also in the case of before patient is planned for a new adjuvant chemoradiotherapy. So to know how the patient respond, whether it is means before patient is planned for major surgery like total abdominal hysterectomy or transthoracic esophagectomy, this is a major surgery. If the patient is planned before the major surgery, then better to do a PET-CT so that unavoided surgery can be avoided if metastatic disease is there. So this is a case of upper use of a 45-year-old male with a history of dysphagia. This patient had primary lesion in the upper esophagus with level 4 lymph node, which is means it is a normal according to CT, but PET wise it is increased uptake, and the biopsy confirmed it as a metastatic lymph node. This is the maximum intensity projection image. This is the axial CT and a fused CT images. Later on, I will explain in detail in this only, in the same scenarios only. So in the case of assessment of therapeutic response, it has a high performance, especially to assess early and also end of treatment response. So mainly it is a prognostic indicator. If the patient is having complete metabolic response, is a good prognostic indicator. So this patient do well after after chemoradiotherapy and also after major surgery. So there is a study, it's a the prospective randomized study. This study included biopsy proven esophageal and gastroesophageal. The primary endpoint is major histological response, and the secondary endpoints are overall survival, progression-free survival, and loco-regional recurrence. These are the secondary endpoints in this prospective randomized study. This study included 124 patients. Among the 124 patients, only 66 are non-responders. So according to this one, they included only T2 3 diseases where these patients are planned for neoadjuvant chemoradiotherapy. So PET-CT is done in 122. In this study, they used only C and F, cisplatin and fluorouracil, and interim PET is done. If the interim PET is responding, the patient undergo 2 more cycles of chemotherapy followed by surgery. If the patient is non-responding, there are 2 arms. In one arm, 31 patient has received 2 cycles of docetaxel plus CF, and in another arm, 35 patients along with this radiotherapy is used. So these are the results of this study. Early metabolic response is associated with a better overall survival, and addition of docetaxel, it improves the response and also survival outcomes, and addition of radiation to this DCF, it has high tumor response rate and less local relapse rates. But main disadvantage is only 66 patients were non-responders. So better we can follow up these study so that we have a good results later on. And survival benefit is not studied in this study. So this is an example. This is a baseline PET-CT which shows intense primary lesion in the GE junction. This patient is planned for neoadjuvant chemoradiotherapy. This is post-therapy, almost complete response to the chemotherapy. These are the axial CT and fused images with a primary lesion in the GE junction, which is responding both the morphologically, a significant reduction in the thickness is there, and complete metabolic response is there. So there is a tiny node adjacent to it, though it is CT wise insignificant, PET wise uptake is there. This also had complete metabolic response with an interval reduction in size. So this patient did well after surgery, after neoadjuvant chemotherapy followed by surgery. So PET has a prognostic indicator and also the response assessment. Both these can be evaluated if the patient is planned for neoadjuvant chemoradiotherapy. Next, in AIG, we routinely used RT planning used PET-CT because it helps in the target volume definition. There is a significant improvement is there, and also all these tiny lymph nodes can be included into the GTV, which improves the loco-regional disease control and also reduces the radiation-induced complication because it clearly indicates the volumes based on the PET-CT. So we can avoid the extra radiation to the nearby critical organs, and also the definite tumor can be delineated using the PET-CT. So next, in the case of recurrence assessment, it's useful modality to detect recurrent and distant metastatic lesions. So a meta-analysis with 8 studies, with including 486 patients. This meta-analysis, there is whenever there is a clinical suspicion of recurrence, the sensitivity is very high, that is around 96%, but specificity is low. So better if there is any positive lesion to prove by biopsy, because the specificity is very low. So this is the baseline PET and follow-up PET CT. This patient had undergone esophagectomy and there is a recurrence in the gastric pull-up, which is biopsy proven. So after esophageal malignancies, next we come upon to the gastric malignancies. So in gastric malignancies, the role of PET CT is less because there is a low uptake, especially in the case of signet ring cell tumors, mucin tumor, and also diffuse linitis type of tumors. In all these cases, FDG uptake is low, so it has limited value. And regarding the T staging, as we all know, EUS is the best, and but PET CT has high specificity only for the detection of lymph nodal metastasis. So whenever there is any high suspicion of locally advanced malignancies, better to do PET CT because it's a one-stop shop imaging, including the whole body, which leads to the changing management in around 1/3 of the patient before the patient is planned for major surgeries, especially in the case of locally advanced malignancies. And also whenever there is a high creatinine levels where contrast enhanced CT is contraindicated, in all these cases PET CT is quite useful because PET acts as the contrast agent. In this patient, this is the primary lesion in the pyloric antrum of the stomach and incidentally detected focal uptake in segment 5, which is biopsy proven as a metastatic disease. So in CKD patients, FDG is quite useful. So in the case of recurrence or restaging, a meta-analysis including 828 patients, they show around only 85% sensitivity and 78% specificity. So PET CT is useful only in the case of equivocal anatomical imaging or whenever there is a high suspicion of distant metastasis. Otherwise, routine use of PET CT in recurrence or restaging of gastric malignancies is not indicated. So this is a post-gastrectomy. This patient had a tiny lymph node, which is which shows a intense uptake and biopsy proven to be positive. So this, whenever there is a suspicion, better to do PET CT so that surgery can be planned appropriately, which increases the survival. Next, coming on to the colorectal malignancies. So in colorectal malignancy, as such, it is not useful for diagnosis, but whenever there is a focal uptake of FDG in the case of colon, better to evaluate by colonoscopy or colonoscopic guided biopsy, because there is a study around 75 to 80% of these focal lesions may be pre-malignant or malignant. So focal uptake of diffuse uptake we may see in metformin, but focal uptake better to evaluate. In the case of initial staging, there is an insufficient data to use the routine PET CT in initial staging of colorectal malignancies, but it can be used as a problem solving, especially in the case of indeterminate liver lesions and also in the case of detecting extrahepatic liver metastasis. And there is a good scientific evidence as to utilize PET CT whenever there is a undetermined findings in morphological imaging like CT and MR, and also in patients where contrast is contraindicated. So in this case, this is a liver metastasis. He's a 65-year-old male with a diagnosis of primary lesion in the sigmoid colon. So this patient had a resectable liver metastasis in segment 7. So this patient had undergone PET CT to know whether the patient is having any distant metastasis. There is an incidental detection of 2 liver lesions and the local lymph nodes and a focal uptake, which is an incidental finding, which is biopsy proven to be as a high-grade dysplasia. So whenever there is a resectable metastatic lesion in the liver or extrahepatic metastatic resectable one, then better to do PET CT before the patient is planned for metastatectomy. And in a case of recurrence assessment, it is useful whenever there is a raised CA levels, but morphology is inconclusive. It's not that every patient with raised CA levels, the patient has to undergo PET CT. No, only in the case of inconclusive morphology, morphological imaging, that is either CT or MR in the rectum, we do routinely MR, and in the case of the colonic malignancies, we do CT contrast. And in these cases, if findings are inconclusive, better to do PET CT. So the 66-year-old male who had a carcinoma descending colon treated, this patient had a rising CEA levels. So this patient was referred to PET-CT in our department. There is an intense uptake of soft tissue lesion in the pelvis abutting the rectum, which was biopsy confirmed later as recurrent metastatic adenocarcinoma. So this is a small lesion which may be missed up. So it is quite useful as in PET-CT. Next, in the case of therapeutic response, in the case of colorectal malignancies, it has very good performance, especially after local treatments to the liver metastasis. That is, if we are planning any resectable liver metastasis or any interventional radiology procedures like TACE, TARE, PET-CT is quite useful because it has a very excellent negative predictive value. And in the case of rectal malignancies, nowadays a little bit stage 2 and 3 patients are planned for neoadjuvant chemoradiotherapy. In all these patients, better to perform baseline PET followed by after chemoradiotherapy to know the response assessment. So this is our patient who had a primary lesion in the lower rectum. He had undergone chemoradiotherapy, which shows both morphological and metabolic complete response. So this patient has a good prognosis. So PET has again predicts the prognosis of the patients who are responding. So a patient who are responding have good prognosis, but who are not responding have a poorer prognosis. So next, coming on to the rectal cancer. So among all the colorectal malignancies, only in the case of rectum we do routinely use PET-CT for RT planning. So it has a good performance in volume delineation. So last is anal malignancies in the case of gut malignancies. Later on, we discuss about the hepatobiliary pancreatic malignancies. So in the case of anal malignancies, it has a limited role. It is useful only in the case of staging of squamous cell. So the FDG uptake is intense in the case of squamous cell carcinoma of the anus. So it helps in the detection of nodal disease, which acts as a prognostic indicator, and also in the case of RT planning. Next, it is especially useful in the case of locally advanced, that is T2 to T4 and N plus disease. In all these cases, better to do PET-CT to see the distant metastatic disease, and also in the case of end of chemoradiotherapy to know whether the patient is responding or not. So this is a baseline, the maximum intensity projection image. This patient had a polypoidal lesion in the sigma. This is an incidental finding, polypoidal lesion in the anal canal, and also sigmoid. This is an incidental finding in the sigmoid colon with the common iliac lymph nodal masses. So it leads to the upstaging in the case of anorectum. So according to the NCCN guidance, it only considered in the case of anal malignancies, considered PET-CT for staging. Next, coming on to the hepatobiliary and pancreatic malignancies. So in HCC, NCCN and IAEA do not recommend the routine use of PET-CT for diagnosis and also for the case of initial staging, but it helps in the case of prognostication. If FDG uptake is high, the patient has poor prognosis. So poor prognosis. So it is useful only in the case of multifocal lesions and also in the case of extrahepatic disease and also in the case of pre-transplant evaluation. So Dr. Ritu Verma also explained the same thing, that before the patient is planned for liver transplant, better to do PET-CT because if the FDG uptake is high, these patients have a high chance of recurrence. And also it's an excellent tool, that is local treatments like RFA, TACE. It has excellent negative predictive value. So better to do PET-CT to evaluate the response to these treatments. And whenever there is a rising AFP levels and morphological imaging is inconclusive, then better to do PET-CT. It has high sensitivities around 93%. So a 49-year-old female with a known case of HCV related CLD with a HCC and post-TACE. This is the MIP image and this is the CT image. This patient had undergone TACE. So there is no FDG uptake, so complete response post-TACE. But this patient had raised AFP levels. So whole body PET-CT is done, which revealed lytic lesion in L2 vertebra, which is later biopsy confirmed as metastatic adenocarcinoma. This patient had undergone local RT and she had complete response to treatment. So whenever there is a high suspicion of recurrence, better to do PET-CT so that targeted treatment can be done for this patient. Post 2 years follow-up, the patient is doing well. Next, in cholangiocarcinomas, in general, PET-CT has no role. Only CCT and MRI has a very good role. PET-CT is only useful in the case of intrahepatic mass-forming cholangiocarcinomas, where the sensitivities are around 90%, and it is especially useful whenever there is inconclusive morphological imaging. Coming on to gallbladder malignancies, it's very useful, especially in the case of locally advanced malignancies, to detect the occult metastatic disease before the patient is planned for a radical cholecystectomy. So if a 55-year-old male with a history of the GB malignancy, locally advanced, this patient had raised creatinine level. So without contrast, we had done PET-CT. This is the primary lesion. Primary lesion with a loss of fat plane with the liver with adjacent lymph nodes, but to surprise, this patient had also supraclavicular lymph nodes, that is metastatic disease. Next, in pancreatic cancer, this is the indication where PET-CT is quite useful, especially in the case of chronic calcific pancreatitis with a mass form in the head of the pancreas. To differentiate whether it is a chronic inflammation or malignancy, PET-CT is quite useful. So it is superior to CECT in discriminating IPMN also. So whenever there is an IPMN and malignancy is suspected, that is, then these are all the independent predictors, that is intense uptake, CA levels more than 1, and also neutrophil to lymphocyte ratio more than 2.6. All these three are predictors. So whenever there is a IPMN with a solid component, enhancing component, better to do PET-CT because it acts as a predictor and also as a metastatic workup. And also it is superior in characterizing pancreatic masses. So this is a known case of chronic calcific pancreatitis with a bulky head and uncinate process of pancreas. This patient had undergone PET-CT because there is a raised CA levels. There is no FDG uptake. This patient is followed for 1 year. The serum CA levels reduced. So it's only just a chronic inflammation. This is one of the good indication of PET-CT in the case of chronic calcific pancreatitis or recurrent pancreatitis with a bulky head and neck, or whenever there is a suspicion of malignancy with raised serum CA levels. And other indications of pancreatic malignancies are especially useful in the case of initial staging, but it is not useful for recurrence, and also the recurrence assessment and also response assessment. Usually PET-CT is not done, but whenever there is a locally advanced or borderline malignancies, we can do after completion of chemotherapy. So this is the MIP image. This patient had a mass lesion in the body and tail of the pancreas with adjacent lymph node. This patient had undergone chemotherapy. Post chemotherapy, this patient had undergone PET-CT. There is a good response, almost a significant decrease in the primary lesion size and also uptake. And this node, there is a complete metabolic response with no significant change in size. So this patient had undergone later distal pancreatectomy and splenectomy, and this patient is doing fine because PET acts as a prognostic indicator. This patient responded well to neoadjuvant chemotherapy. Next is GIST. So in GIST, the only indication of PET-CT is to response assessment to imatinib. That is whenever the patient of GIST is had undergone surgery, or if the patient is having a recurrence or metastatic disease, these patients are started on tyrosine kinase inhibitors, that is imatinib. So to know the response assessment, because it is a cytostatic drug, so as such we do not see the reduction in size. So we don't know whether the patient is responding or not. In these cases, PET-CT is quite useful. So a 53-year-old female with a known case of recurrent GIST, this patient had undergone surgery. This is the MIP baseline and post-imatinib. So this patient had a hypodense lesion in the lesser sac and also along the greater curvature. This patient was on imatinib and referred to our department for PET-CT. So there is a complete metabolic response with significant decrease in the size of these recurrent lesions. And a lesion along the border of the spleen, this also has responded very well on imatinib. So these are all the indications of the FDG in GA malignancies. So apart from the fluorodeoxyglucose, I explained in the start of my lecture, there is a generator produced, that is gallium-68 dotatate, which is useful for the neuroendocrine tumors. Other less commonly available, actually studies are there, but for us we are not routinely doing F18 choline C11 acetate. But gallium-68 extending, the only indication is whenever there is a suspected of insulin insulinoma, it has sensitivity around more than 95%. And the fluoride, it is alternate to the bone scan. Compared to the bone scan, the resolution is high, and it has along with it a CT image. So it is useful for both lytic and osteoblastic lesions, whereas the bone scan, the resolution is low because it is done in the gamma camera, and there is no associated anatomical imaging. So it is useful only in the case of osteoblastic lesions. So it is means a lesser cost if the patient is having financial constraints and there is a high chance of skeletal lesions. Better we can, as an alternative to bone scan, we can do F18 fluoride sodium fluoride scan. So let's see what are the various indications of dotatate. So dotatate, it is useful in the case of staging, especially in the case of pancreatic malignancies, and also in the case of to know the primary site of malignancy, if the patient is presented with a metastatic disease, to know the site of primary, and also to know the benefit of octreotide, because these patients, whenever they have metastasis, they are started on somatostatin receptors to know the response, and also these patients, whenever they are planned for peptide receptor radionuclide therapy, to know the response also, because gallium-68 theranostic pair is beta is lutetium and alpha is an actinium. So it's a theranostic pair. Whenever the patient is planned for PRRT also, gallium-68 dotatate scan is mandatory, because only the patients with positive scans, the patients are benefited with the PRRT. So whenever there is a suspicion of insulinoma, gallium-68 exendin is done, which has sensitivity around more than 95%. So this is the physiological uptake. Intense uptake is seen in the spleen, and the variable uptake is seen in the liver, kidneys, and bladder. So physiological distribution is quite useful before we interpret the images. So let's see an example of dotatate staging. So this patient had presented with a multiple liver lesions with a mass lesion in the ileocecal junction. So there was the pathology suspicious for adenocarcinoma or NET. So IHC was pending. So this patient was, as a staging workup, referred to our department. So intense dotatate tracer avid lesion in the ileocecal junction with a multiple FDG, multiple DOTA avid liver lesion. So it is a metastatic NET ileocecal junction. So before the IHC, this patient was planned for initial staging. Next is, this patient was referred to our department with a history of multiple liver lesions to know the site of primary. So whole body gallium-68 dotatate PET-CT was done, and the primary was a polypoidal lesion in the lateral wall of the rectum, which was later confirmed by the biopsy. So dotatate is useful for to know the site of primary, and also to know the response assessment. And whenever there is a biochemical evidence of recurrence and anatomical imaging is inconclusive, then PET-CT is indicated. So a 37-year-old male with a treated case of carcinoma rectum had undergone DOTA. There is a tiny left iliac lymph node which was positive. Next, the other traces which we are not routinely used because of not availability is fluorochlorine. It demonstrates high sensitivities around 89%, especially FDG, where it is less useful because FDG uptake is less in well differentiated, and it is also useful before the patient is planned for transplant. Next, less commonly utilized for radioactive material in GA malignancies is C11 acetate, that also in HCC in combination with FDG to demonstrate the initial staging. So this is the choline. So choline uptake, whenever there is an inconclusive anatomical imaging, F18 choline may be useful, which shows intense uptake in the lesion. But the main issue is the availability. Next, nowadays, almost from past 2 to 3 years, we are seeing everything about FAPI. So let's see what is FAPI. FAPI is nothing but it's a fibroblast activation protein inhibitor. It says that it's a specific inhibitor that targets cancer-associated fibroblasts. So what is the advantage? Why people are very much fascinating about FAPI is low background signal, that is minimal or less uptake in the brain, heart, and liver, and it is it's a complete cellular internalization. So it is almost more than 20 malignancies, it shows high uptake. So especially where FDG has its fallacies like cholangiocarcinomas, stomach carcinomas, and also in the case of HCCs, FAPI is better compared to that of the FDG. And also it is an in-house, that is, it is gallium-68 labeled. And the other major advantage is the theranostic pair. This FAPI can be linked with the lutetium or actinium, and therapy can be planned whenever it is locally unresected unresectable or metastatic disease. So this is the normal physiological distribution of FAPI. No uptake in the brain, liver. So these are all the various malignancies. So almost 15 malignancies we see. Cholangiocarcinomas, intense uptake is there whenever there is an unknown primary or pancreatic malignancies where FDG is a little bit less useful. In all these cases, FAPI is showing better results, but we have to wait to know whether what are the false positives and false negatives. Like FDG has a lot of false positives and false negatives, but this is a new drug which is coming, which has in last 2 to 3 years. We have to wait for more papers to come. But recently, AIMS has come up with a good paper showing that it is excellent, useful for malignancies. So tiny lesions where there is an intense uptake of FAPI and also multiple lesions. So FAPI helps in upstaging of the disease. So as I said, in FDG, it's not that whatever I showed is very easy to interpret, but no, FDG has very much false positives and false negatives because it's similar to that of the glucose. As we all know, inflammatory cells pick up glucose because it's like increased glucose administration. So these are all the long the list of false positives and false negatives. False negatives like small size, but this is resolved with a newer generation PET-CT where up to 3 mm lesions can be detected. And whenever the patient had undergone high dose of steroid therapy and hyperglycemia and well differentiated carcinomas like HCC, in all these cases false negatives are there. And also in the case of mucinous and signet ring cell carcinomas, these patients FDG uptake is very low. And this is a long list of physiological uptake and also inflammatory lesions which are picked up FDG. So whenever we are interpreting in, images, be cautious while interpreting to avoid false positives and false negatives. Thank you so much.
Thank you for your wonderful talk, ma'am. There are no questions in the chat box yet, but if I can ask you to hang around for a couple of minutes.
Yeah, please.
Thank you, ma'am. Our next lecture for today will be taken by Dr. Sikandar Sheikh. It is the last lecture for today, but we will have a oncoimaging quiz after that conducted by Dr. Sikandar. So please hang around after the lecture. We have some exciting prizes as well. Sir is a consultant in PET-CT and radiology at Yashoda Hospitals in Hyderabad. He is an assistant professor of radiology at Shadan Medical College and an adjunct assistant professor in the Department of Biomedical Engineering at IIT Hyderabad. He's the Indian ambassador of the European Society of Hybrid Molecular and Translation Imaging. And he's a research committee member of the ESOI. His specialty is in oncoimaging, and his topic for today is molecular imaging in oncology. So if I can ask you to share your screen, please.
Yeah, Dr. Abhishek, this one thing I will be taking first a quiz, then followed by my talk actually, because we will finish with the quiz, and by the time they will, you can finalize the winners, and then I will finish my last talk.
Okay, sir. So that works.
So I'm doing quiz first.
Okay, sir. Okay, so the format for the quiz is there are 17 questions in all. The last 5 questions of this quiz will have prizes. You can put the answer in the chat box, and for the last 5 questions, the first answer will win a prize. The first correct answer.
Yeah. And after each question, I will be giving some 30 seconds or 40 seconds based on the number of images. And then please have a look by the time, and then you can start typing in the chat box. So as mentioned, first 12 questions are straightforward. Means I will show the case, and immediately followed by the case, there will be answer which I will show you, and probably I will just tell you findings very shortly, very briefly, not having any text. So hope this works. So this is my case 1. 5-year-old boy with dry cough and cervical lymphadenopathy. So you have 30 seconds. You can type answers in chat box. Yes, the time
You
is
put
out.
your answers in the chat box, guys.
Yes. So I'm giving some 15 seconds. Okay, I think there are no answers. Somebody has answered. Papillary CA thyroid. So definitely, what are the findings? These are lung window, which shows the significant slit-like narrowing of the tracheal air column. And intestinal window, the thyroid is bulky, demonstrate heterogeneous enhancement. Same with heterogeneous ecotexture with diffuse increased vascularity. So what is it now? See, one of the feature here is you can have a thyroiditis. Thyroiditis will also have sometimes of thyromegaly with heterogeneous ecotexture, multiple tiny calcification, and diffuse increased vascularity. But the thing which goes against the thyroiditis is slit-like narrowing of the tracheal air column. So this is something like which is a mass which shows heterogeneous enhancement, obviously seen in thyroiditis. But one thing which makes differentiated from thyroiditis is the slit-like significant narrowing of the tracheal air column. So this tracheal air column is something which we have to see. And as given stated by a couple of answers, it goes more in a favor of carcinoma thyroid. So papillary can be one of the differential and one of the diagnosis here. Thyroiditis definitely would have been the diagnosis without tracheal narrowing. Moving on, second case. You have 30 seconds.
Please put your answers in the chat box, and the correct answers we are going to tap, and there are prizes to be won. So one person has given as lymphoma.
Yeah.
So all of you please participate in the quiz. It's just for interaction and better learning.
Giving another image. Same case, MR image. Pediatric age group. Neuroblastoma. Perfect. So this is a large neuroblastoma which is involving the upper abdomen and infiltrating the trachea and the major structures, abutting displacement of the adjacent visceral organs. So if you go and see this is nuclear scan which shows a significant amount of uptake here, that is MIBG scan. which shows a diffuse uptake. So this is done for seeing the evaluation once it is diagnosed as neuroblastoma. And another important aspect of neuroblastoma is very notorious. It has extensive destructive metastasis. So case number 3. Just a minute. No history. Pre-contrast CT and post-contrast CT. Yes, none of you I answered. Ganglioglioma, PXA. The MR images.
So few answers have come in the chat box.
Oligodendroglioma, PXA, ganglioglioma.
Yeah.
So it is DNA. You see the pre-contrast elements and post-contrast. It doesn't have much relevance in the as far as the enhancement is concerned. So there are different. Yeah, somebody has answered DNAT. Perfect. So non-enhancing hypodense lesion in the temporal lobe, which is high on T2 and low on T1. This is one of the important things by which you can differentiate. Supratentorial, mostly cortical, associated or partial complex seizures are cystic and may have a glioneural component. And the differential is again the CVA, that is a infarct, then low-grade glioma. Case 4. 30 seconds. Chondrosarcoma. Right. This looks like little simple. Iliac bone, punctate calcifications, erosion, destruction. Now, MR image. Again, chondrosarcoma. So it is a perfect. So it has aggressive matrix, rings, arcs, T2 bright MR. So the chondrosarcoma and other differentials are osteosarcoma, malignant fibro, histiocytic tumor, then you have lymphoma. But this doesn't dictate. So the classical feature is chondrosarcoma. Next case, 50 years old male with constipation and anemia. constipation and anemia clinically. Any answers? What is this? CA colon, CA splenic fracture. Perfect. It is a CA descending colon. You see the caliber here, it is narrowed. So whenever you see a radiograph also, you have to see the normal markings or normal presentations of the gas versus abnormal presentations. And for that, you have to see little carefully. Unless and until you are oriented for that, you will not be able to identify that. But here, if it is very clear, it is significant narrowing is there. Usually colon, whatever is there, again, you will see the classical hostrations which will be seen. So here there is a loss of hostrations with history of constipation as well as the anemia. So obviously there is some sort of a bleeding that is happening that is leading to the anemia. So it is a classical carcinoma colon. Now next case, 62-year-old male, neck discomfort, upper GI bleed, history, a floor of mouth squamous cell carcinoma, which is treated 6 years previously. Neck, upper GI bleed. And there is a history of floor of mouth squamous cell carcinoma. So known case with these findings. Barium swallow. Radiation stricture. Anything? You are getting close. Any further? So there is a focal nodularity at the level of pharyngoesophageal segment. This extends into lower piriform sinus. And there is a focal collection due to the ulceration. So it is again a squamous cell carcinoma of pharyngoesophageal segment. You see this. There is significant narrowing, pooling of the contrast, irregularity, long segment, known case of square floor of mouth. So floor of mouth is obviously you can have a extension and then can involve the upper GI tract. And this is there where in different views you are able to see the significant narrowing. Next case, no history. Very simple. Thymic carcinoma. Okay. So it's very simple actually. You know all, especially residents. Another image. So anterior mediastinal mass, if you see multiple irregular hypodense area, probably it is like a coalescent mass or something like that. So these are all the presentations. So if you go by differentials, the thing somebody has mentioned, thymic neoplasms, that is one of the differential. Thyroid masses can be there with substernal extension. Then you have germ cell tumors, mediastinal tubercular lymphadenopathy. So this is, if you see the part of necrosis, the only two things, still it can be possible in thymic neoplasm, especially in thymic carcinomas. Lymphoma possible, that too in a form of Hodgkin's, where you will have a necrosis. Otherwise, other types of lymphomas, it is not seen usually. And again, the closest differential is conglomerate tuberculous lymphadenopathy, where they are necrotic. Next case. Very simple. GCT. It's a large lesion. Iliac bone. OGS. Please try to write the full form. I'm supposed to write the full form. If somebody doesn't understand, even they understand GCT is giant cell tumor, then probably you will lose marks. So make a habit, what you write in exam is a full form of the thing. Don't use abbreviations unless and until they are very standard, like PCPNDT. Osteogenic sarcoma or metastasis hemophilic pseudotumors. Is large multiple punctate calcifications, expansion, distortion, displacement, deformity. So everything is seen in here. So it is again same chondrosarcoma what we have seen previously. Case 9. Dermoid cyst. Okay. Dermoid. Dermoid. So I think everybody is going with dermoid. So it is mature ovarian teratoma. What is dermoid and what is teratoma? You see the calcifications. The moment the calcifications are seen, you can use the terminology of teratoma or teratodermoid. That is also there. Now regarding sex cord stromal tumors, which is not correct. Which is not correct. It's called stromal tumors, which is not correct. Yes. E. Somebody has written E, which is not correct. So E is a answer because it affects all age groups, not elderly age group. So this is the correct answer. Next, 58-year female, erosion of bone. What is it? Lacrimal gland, CS. What is CS again? Lacrimal neoplasm, carcinoma. Okay, so there is erosion, destruction with extensive soft tissue component encroaching into the superolateral aspect of the eyeball, probably infiltrating the superior and lateral recti as well as superior oblique muscles. And there is a displacement of the eyeball. Myosarcoma, rhabdomyosarcoma will not cause that much erosion or destruction. So it is adenoid cystic carcinoma. The more aggressive, see, rhabdo will not cause this much of erosion, destruction of the bone, even though it is a malignant. Next, what is the diagnosis? PET CT whole body, FDG. Carcinoma colon with hepatic metastasis. Gastric carcinoma, stomach looks okay. Disseminated metastasis. Liver metastasis. Does it look like liver metastasis? So it is a cholangio with large peritoneal and hepatic metastasis. So these are peritoneal in this and hepatic metastasis. See the pattern of enhancement in the liver. It is permeative lesion. There are no defined lesions. There are no clear-cut defined lesions. These are permeative lesions, ill-defined, hypo, low, conglomerate. So it is like a permeative lesions, not discrete lesions. So one of the differential agreed it is a hepatic metastasis, but this sort of coalescent lesion, again, one of the differential can be again abscesses. healing abscess or chronic abscess where there are coalescent form of abscesses. So that is also one of the differential. And again, on PET CT, they will be seeing and representing as a metabolically active lesions. Okay. So this is large peritoneal nodules, small peritoneal nodules, and this is the liver lesions which are seen. Now we are coming to the questions of proper quiz. I think Dr.
Yes, sir.
Yeah, the fastest will get the prize, no?
Yes, sir.
What are
The
the rules
first correct
now?
answer.
First correct answer. So I am showing this 5 now. So these 5 are based on that only.
Okay,
So
sir.
try to answer as fast and probably correct answers. Yes. 30 seconds. IVP image, ultrasound image. Yes, your time is up. You can just type it. This first is IVP image, second is ultrasound images. Still giving 10 seconds. So it is a multilocular cystic nephroma. So you see that this is a cystic lesions which is there, and along with that there is a normal pelvic ileal system, ureter, pelvic-ureteric junction, proximal ureter. They are normal. So there is associated cystic lesion. This is a renal cortex. So it is a multilocular cystic nephroma, and the closest differential is a cystic RCC. It doesn't look like any way chondrosarcoma. So please try to see the findings. Next, infant with thigh mass. Ultrasound image, Doppler image. 20 seconds. MR images, T1, STIR, GRE, FAST T2, post GAD T1, fat set. Myxoma, rhabdomyosarcoma, proximal thigh, sarcoma, abscess. It doesn't know where it looks like an abscess. Ten more seconds. Rhabdomyosarcoma, no. So it is dermatofibrosarcoma protuberans. So I think you can give marks based on sarcoma somebody has written. So it can be considered. Okay.
Okay, sir.
Yeah. Next, moving on, again 2-year-old male with foot lump. 2 years foot lump, ultrasound images. Oh. So T1 STER PD T2 GAD post GAD enhancement STIR. GCT tendon sheet. No, it is again undifferentiated round cell sarcoma, sarcomatous variant. So it is low signal, it is hyperintense on STIR, PD still hyperintense, T2 hyperintense, and gadolinium it is enhancing. So it is undifferentiated round cell sarcoma. So if somebody has written sarcoma, you can give the marks.
Okay.
Next case 16, last but one case. CS stomach. So it is a small bowel metastasis. So what are the things you are able to see? You see this. It is like a target sign involving the proximal first part of duodenum, then followed by again target sign at the fourth part of duodenum. Then there are multiple filling. Again, this is a target sign. So multiple target signs or bullseye signs which are seen in the small bowel loops, and that too visualize duodenum and jejunum. So what are the differences for that? So the commonest thing which we see with this presentation in the bowel is bowel metastasis. It doesn't mean to say that bowel metastasis, that too small bowel, is very common. No, it is exceptionally rare, and the commonest cause is melanoma followed by breast, lung, or Kaposi's sarcoma. It is because of direct extension of the lesion or by intraperitoneal seeding, and the classical eye sign is a bull's eye appearance. Last case. This is again a PET CT image. You have PET image, fused combined PET-CT image, CT image, and pure PET image. Glioma, medulloblastoma, colloid cyst. Where is the colloid cyst? Pineal carcinoma. Mild expansion of pons, densely enhancing lesion, lobulated, involving pons. Post-contrast. So post-contrast enhancing, definitely glioma is one of the differential, but there are other differentials too. And what is the diagnosis? So in this, these are the differentials. You have tuberculosis, neurosarcoid, hemorrhage, and glioma. So these are all differentials except hemorrhage. So post-contrast hyperdense is not an hemorrhage. So pre-contrast, you can have the hemorrhage. So remaining you have tuberculosis, neurosarcoid, and glioma. So somebody who has given correct answer in this, I request our quiz referees to make a note of that.
Yes, sir.
Okay.
Yes.
So I think we have finished the quiz part. So can I proceed with my talk? So by the time you can
Yes, sir.
analyze
Yes,
the
you
quiz
start
part.
it off. I'll give you a list of the winners.
Yes, sir. So I will continue with this. My topic today is something related to the molecular imaging in oncology. So the word molecular imaging is, we know that molecular imaging is defined as visualization, characterization, and quantification of biological processes at the cellular and molecular levels in living organisms. So this was a definition which is currently being used, and it allows the study of cellular and molecular pathways, various pathways and disease mechanisms in their own physiologically authentic environment, so that molecular abnormalities, which are the basis of the disease, can be revealed easier, faster, and very precisely. And it also includes identification of various biotargets and designs and preclinical evaluation of the various probes. So measures of oncological imaging is to detect and differentiate a tumor from the normal tissue, and necessary to understand the fundamental cellular changes which occur in tumor forms. So what is the role in oncoimaging? First is to differentiate from the normal tissue, that is a tumor. And again, in the tumor, you have to understand the cellular components and how this can be used to generate the various tissue contrast. So this is how the molecular imaging is there. So if you see this diagram, this is something like a linker of molecular imaging where you are dot on the target. So it is based on the imaging of SPECT, optical imaging by using fluorescent dyes. Then MR molecular imaging has evolved a lot by using gadolinium chelates, iron oxide nanoparticles, dynamic nuclear polarization, para hydrogen. Then ultrasound, you have microbubbles, liposomes, and still with that you have multimodal agents like MR PET is being there, CT PET is there, MR optional, CT optical, then MR fluorescence or bioluminescence. So multiple blend of the molecular imaging components can also be used for the molecular imaging. And there are targetings like viruses, small molecules, peptides, proteins, antibodies, nanoparticles, and dual recognition parameters. And again, in the target, you have enzyme, receptor, DNA, RNA, and physiological state. We all know the cancer metabolism, what it is based on altered cellular mechanism. So metabolism is always change, and that is where you have to identify that. This is important for the growth of the cancer and the malignancy. And these various biochemical pathways like glycolysis or pentose phosphate pathways or various types of TCA cycles are also subjected to various regulations. And here you have to do the monitoring as well as understanding the cancer metabolism in vivo, which improves with the diagnosis and treatment planning of the cancer. So Otto Warburg, who demonstrated the high glucose consumption and lactate production in cancer, they compare to healthy tissues and conceptualize that tumor metabolism differs from that of normal tissue. And you have metabolic and molecular imaging of tumor. So you can do a metabolic analysis as well as along with the molecular basis. So you can see the changes in various technological and physiological aspects, which will lead ultimately to the tumor grading more precisely. You can characterize the tissue, whether it is low grade, high grade, what sort of cell transformation it is being done, and how aggressive it is there. To define the available anatomical modalities, we can just grossly see, but is there any microscopic infiltration into surrounding tumors? Like simple, you have a intraventricular lesion which is extending into the spinal cord, or there is infiltration of a particular tissue in the surroundings. And again, the most important aspect of the molecular imaging will be planning as well as monitoring the response to the therapy. So we have seen various cellular molecular changes. Cancer increasingly due to various factors can be studied, and to counter this, a lot of development of new imaging biomarkers are being done, and these are more specific and sensitive for cancer detection than as compared to morphological information alone. So you have a CT and MR contrast agents can have angiogenesis or PET tracers, or which are capable of detecting the various cellular energetics and proliferation. So this is something which is a new concept of molecular imaging actually. So this I'm just based because I have just now my another book has been released, which is the advances in molecular imaging, a concept towards precision medicine. So precision is nothing, it is a personalized medicine. So this is defined by the President's US Council of Advisors on Science and Technology, stating that the tailoring of medical treatment to individual characteristics of each patient, to classify individuals into subpopulations that differ in their susceptibility to a particular disease or their response to specific treatment, so that preventive or therapeutic interventions can be concentrated on those who will benefit, sparing expense and side effects for those who will not. So this is like a more precise this thing. So again, this is a coalition of the personalized medicine, which I'm not telling. This is given. This is a bigger statement. Ultimately, it states the like you can have a mechanism of disease state prediction, future disease states, drug response, and treatment prognosis to help physicians individualize treatment for each patient. So among this, now there are different modalities which I will be telling very shortly. So you have ultrasound molecular imaging. It is by using the molecular contrast agents. Advantages of contrast enhanced ultrasound is the easy availability. It can characterize the neoplastic processes on a molecular level by using this on contrast agents. Now, imaging genetic and cellular alterations can also be done along with the morphological or anatomical changes, which we are using ultrasound as a routine modality for our day-to-day practice. And another is preclinical evaluation has to be done with the use of contrast micro bubbles, which are gas-filled emulsions of several micrometers in size that are confined to the intravascular space. So applications of ultrasound molecular imaging easily can detect the ulcer cancer detection, and you have a tumor characterization to monitoring treatment response and guiding cancer therapies. So theranostics for the delivery of chemotherapeutic drugs and gene therapies can be done. And you have multimodality imaging, which combines ultrasound with photoacoustic or MR modalities to further characterize malignancies. So molecular ultrasound for cancer imaging are in preclinical stage, and this will give the trial expose the safety and efficacy of targeted contrast micro bubbles for ultrasound molecular imaging in patients. So if you see different criteria are there, you are able to see the aspects of the imaging and treatment. Then they have possible roles of ultrasound, then early detection and tumor characterization by tumor angiogenesis, use of nanoparticles, multimodality imaging with photoacoustic imaging, then you have molecular profiling. This is for the detection and characterization. Now, second, you have monitoring treatment response. So you can do anti-angiogenic therapy, radiation therapy, and traditional chemotherapies. An imaging guided delivery of therapy can be done, that is in a form of use of microbubbles in chemotherapeutics, microbubbles, therapeutic genetics, and you have ferromagnetic microbubbles for therapeutic drug delivery. So this is again the another aspect which you are able to see by using different components. You have micro bubble, nano, then you have nano droplets, you have nano bubble, nano particle, and you have nano liposomes. So what is there? This is a vascular endothelial cell. These are the liposomes, so they can be easily transported from the cell. And these are the macro bubbles which can be seen in the lumen, and by which they can be circulated and coming to the particular area of interest. Like you have solid nanoparticles, you have liposomes, you have nanodroplets, and you have nano bubbles. So that is how the nano bubbles because of the use of the ultrasound. And the size of nano bubbles, as they are very small, they can easily extravasate through the vascular endothelium due to defective tumor neovascularization. And it has been proposed that once in the extravascular space, nanobubbles can coalesce with the micron size collections, allowing for the ultrasound detectability. So this is another same principle here, malignant cells. So microbubbles contrast, they can pass through the therapeutic drug vehicles, and then they can be easily demarcated the area of interest in a particular tissue earlier than our routine anatomical imaging or any other molecular, any other structural or anatomical imaging modalities. So here there is a different aspects are there. So you have various possibilities which can be seen by the obstacles which are there can be overcome by using this ultrasound, but still the designing microbubbles and nanoparticles can use the target ligand specifically and with high affinity, such as small tumor or number of target receptors can be detected and imaged. This is one concept of interaction between the micro and nano bubbles, which are target is to apply the so-called radiation force enhanced targeting. So this acoustic radiation force of substantial magnitude can be generated even at a low acoustic pressures when the ultrasound probe is perpendicular. And this increases the interaction between the targeted contrast agent and the endothelium. So proposed with the use of external magnetic field and directing magnetic microbubbles is also the thing which we will see. So microbubble nanoparticles, so these are the components, and these microbubbles are easily detectable by the ultrasound, and the range of frequencies same 2 to 10 megahertz, which coincides with the radiation resonance frequencies of most of the ultrasound microbubbles. So we have different nanoparticle contrast agents, which I have shown, like liposomes, nanodroplets, and solid nanoparticles. So the size of liposomes are the smallest. They are the largest because it is a micro, nano to micro, but solid nanoparticles and nanodroplets are very smaller. Response to therapy and one of the important oncological imaging components which are seen. So here you can detect cancer early, you can see the outcome, and every malignancy you can define the survival rates based on the cancer stage at the time of diagnosis. So earlier the diagnosis, the better the prognosis and better the survival rates and better the outcome. So these are all interlinked, interrelated. And again, you have blood-based and imaging biomarkers for various malignancies that has been discovered. Very few have acceptable sensitivities and specificities to be clinically useful for early cancer detection. So here you have imaging of tumor angiogenesis, development of new vessels, target of ultrasound molecular imaging using microbubbles in cancers. And you have angiogenesis of early cancer developments in most tumors, they rely on increased vascularity, and once they grow beyond 1 to 2 millimeter in size. So ultimately, it is a new vascularization or angiogenesis which can be defining the aggressiveness of the cancer. Other than that, you have multiple modalities like combination of modalities using microbubbles and nanoparticles. Like you have seen the ultrasound as well as another modality. So you can combine ultrasound with photoacoustic imaging, that is PA, and can be integrated into one imaging machine like what we do in PET-CT. So ultrasound with photoacoustic imaging, and where both the acquisitions can be done as a single examination. So what is there in ultrasound now? It has one of the powerful tool of cancer imaging, early cancer detection, early cancer characterization and molecular profiling, and targeted and non-targeted contrast agents for drug and gene delivery. So this is something new concept which is coming in a form of a theranostics. You have this commonly detects the metabolic changes in various tissues, including cancer, and there are different markers like choline, creatinine, Na, and so many things which are there based on the biochemical changes and can differentiate metabolic tumor phenotypes. And we all know proton MR is already established, so I'm not going in detail. So this is something like MR spectroscopy imaging. So it is another form where you have spatial mapping of endogenous metabolites, which provide heterogeneous distribution of these metabolites in cancer tissue. And there is a spatial mapping of choline proton signal, which can reveal aggressive areas in tumor tissue and to help the monitoring therapeutic response. So ultimately, it improves the diagnostic specificity of malignant humans cancer, and it is an important clinical tool. Now, hyperpolarized component is there. So you have hyperpolarized MRI in cancer. So hyperpolarized cancer label pyruvate infusion to monitor the increased glycolysis in cancer can also be done. So there is a use of 13 carbon pyruvate as a hyperpolarized substrate in preclinical, and even the lactate can also be used. So hyperpolarized lactate is one of the studies it is being used is transgenic prostate cancer models shows hyperpolarized level progressively increasing with cancer aggressiveness and histological grading. So there is again imaging of mobile protein and peptide in cancer. So we know that all metabolites are there. There is a derangement of metabolism, metabolites. So you can do that amide protein transfer imaging, that is APT imaging. And there is also a CST based method where you can do the MR imaging by using this components like proteins and peptides for evaluation in vivo. And this method depends on exchange between protons of free water and those of amide groups. So these are like promoter and reporter genes. So you have reporter MRA, reporter protein, and substrate of PROR, and then ultimately the MR signal is being generated. So now molecular MR imaging in cancer immunotherapy. So this cancer immunotherapy is also there important in for evaluation in chemotherapy because a lot of advancements are also there in this field. So cancer immunotherapy is getting widespread attention and it provides a novel approach to manage the cancer by triggering patient's own immune system to induce a potential anti-tumor response. So this is something very new concept which is being used, and this is immunotherapy by use of lymphocytes, dendritic cells, and natural killer cells, which show their therapeutic efficacy to treat cancer patients. Provide highly selective to kill cancerous cells with significantly less side effects of normal. So we all know the component of molecular imaging. Now only the addition will be the MR. So again, the same thing which plays is use of early detection, diagnosis, staging, personalized treatment, and treatment monitoring. So there are many types of cancer which are being used like prostate, ovarian, and lung cancers, where molecular imaging has truly changed the direction and outcome of the entire patient outcome. And another thing which I already mentioned is about the nanoparticle imaging, where there is a high potential to improve cancer diagnostics for increasing efficacy of the therapeutics, nanotherapeutics, that is theranostics, treatment management, biomedical research, and clinical practice. And these nanoparticles will also serve as label or labeled carriers for monitoring drug delivery or serve as imaging agents for analyzing contrast, as well as providing improved signal sensitivity and specificity for in vivo imaging of molecular and cellular processes. So these qualities offer exciting opportunities for nanoparticle-based imaging agents to address current limitations in oncological imaging. So these are the different nanoparticles which are used. So they are polymers, dendrimers, liposomes, polymerases, polymeric meshels, polymeric nanoparticles, inorganic nanoparticles, carbon nanotubes, and fermin nanocages. So the shape, their presentation, and they are there. So these are reporting molecules which are coded in the pink, targeting probes are in yellow, and amphiphilic polymer is in this wavy pattern. So again, we have seen the different aspects of optical imaging, PET imaging, SPECT imaging, ultrasound, MR, and CT imaging. So every modality has their own radio tracers, their own biomarkers or substances which can be used for diagnosis. And blending this, again, you can use a combination of ultrasound or optical. Then you have PET with CT and PET with MR, SPECT CT. So there are multiple multimodality imaging components which are being evolved in. So we all know this nanotechnology has operated to a very high extent. It's used to overcome the limitations of this to image guided survey efficiency, and they are already moved into the first line human studies. So some of the studies are for intraoperative sentinel lymph node mapping and dissection. So there are some limitations for primary tumor dissection, sentinel lymph node biopsy. Then again, if the tumor cells are found in biopsy specimen, additional lymph nodes might be removed about the same biopsy procedure. And again, nanoparticle guided radiation therapy can be there because nanoparticle based radiosensitizers is used to amplify the effect of radiation within tumor cells and spare surrounding tissues from damage. And these are based on materials or construct detected by using imaging techniques like by using the theranotic approach with improved efficacy. And presence of gadolinium and bismuth can also amplify the radiation dose under clinical irradiation that was delivered at the time of maximal nanoparticle uptake in 30 seconds. Aspect of this cancer is stem cell imaging. So we all know that stem cells are being used for the management in various forms of the treatment protocols, especially in the tumors, to study the response to therapy and predict the outcome of therapy as well as the prognosis. So various imaging modalities are being investigated for in vivo imaging for the cancer stem cells like PET, SPECT, MR, or optical imaging modalities, including bioluminescence imaging and FMT and near infrared fluorescence reflectance imaging. They are very important for in vivo imaging of CSC. And the sensitivity and specificity of molecular probes targeting genes have greater role in cancer growth and progression, which can be a key factor that determine the accuracy of the cancer protection. Optical imaging, it is again a new versatile modality, non-invasive, very important in molecular and cellular imaging. It is very cheap in comparison to with other modalities. Imaging cancer stem cells using optical imaging is very precise, which can be used by reporter signal and imaging modalities because cancer stem cells constitute only small percentage of population of the tumor cells. So same, you have bioluminescence signal imaging where the signal is emitted, you can identify the low sensitivity and specificity of the tumor growth, regression, and metastasis, as well as molecular and physiological processes in real time, such as cell survival and gene expression. And reporter signals are needed for the bioluminescence imaging. So we have seen the multimodal combination of imaging like PET, CT, PET, MR, optical imaging, ultrasound optical imaging, because one modality always have its limitations and some strengths. So combining two modalities will definitely have a better aspect, better sensitivity, and more precise for imaging different modalities. Now, genetic imaging is also there because this is something new which has been evolved in these years, and a lot of research, a lot of in vivo studies are being done for the use of this genetic markers which can be used for identifying the cancer cells in either minimally and by the use of their activity. So these are tumor-specific promoters of the genes which are seen. So promoters of the oncogenes can be seen in the angiogenesis cancer progressions. These are selected markers which are being seen here. So you can just go through, there are different, and there are a lot of things which are coming in future. So last, I just want, before concluding, there are a lot of new things has come in a form of a theranostic. So what is theranostics? You use the diagnostics, then the treatment part is theranostic. So you are using MR, fluorescence, photoacoustic, PET scan, and these things. But the use of this therapeutic aspect becomes photodynamic therapy, chemotherapy, gene therapy, radiotherapy, thermotherapy. So the treatment aspect has become the therapeutics. And the concept of theranostics is the use of the component or modality where you can diagnose as well as treat both the things. So this is something related with the nanostructures. I'm not going in detail. So I think with this, we can conclude our talk. So this was my last slide. So that is how the theranostics appears, because this is a base nanoparticle, targeted nanoparticle, and this is targeted nanoparticle for imaging, targeted nanoparticle for radionuclide or specific therapies, and again you have targeted nanoparticle for the drug therapy. So in theranostics, you are identifying the disease and using that therapeutic options like radionuclide therapy or drug therapy also by tagging that particles to the delivered to the particular area. Like you use nanoparticles for diagnosis, nanoparticles for the therapeutics also. So first you are diagnosing by the use of nanoparticle, then you are using that nanoparticle for the diagnosis. So that is how the theranostic approach has come, and probably in future that is one of the important aspects which will be there. And one of the commonest used theranostic which was existing in older days is iodine therapy. So iodine is used for the evaluation of the thyroid carcinoma as well as for the analysis and the treatment form of the thyroid carcinoma. So it is being used for both diagnosis as well as treatment. So both the things. So that is how the theranostics has evolved. And with this, I really am thankful to all the our organizers of Indian Radiologists for giving me this opportunity. It was wonderful having all these extreme faculties who have taken part for deliberations since yesterday. Most of them foreign faculties and eminent national faculties also. Excellent talks, excellent deliberations, and excellent stuff. And it is heartening to see that a lot of encouragement from the attendees also, who has been consistently present since yesterday till today, and till now also they are there. So I really thank you all for your special time which you have spent for learning this onco. And as it has been mentioned by various speakers, that learning is a continuous process. Every time something we learn, sometime we learn in class, sometime we learn in webinars, sometime we learn with the patient in our day-to-day practice. So medicine is ever learning process, and we will be going on learning. So thank you all, and thank you Indian Radiologist Deepak Patkar sir, Dr. Mitusha, Dr. Gauri, and then Dr. Amit and Dr. Abhishek. So thank you all, and with this I conclude my session.
Thank you so much, sir. Thank you for your lecture and thank you for your kind words, sir. That brings an end to the Oncoimaging Masterclass. A gentle reminder about the breast imaging masterclass, which is in a couple of weeks, and the 21st MRI teaching course, which will be in August. We will be accepting paper and poster submissions up till the 31st of July. So please send yours in soon. A small word of appreciation for all the faculty and organizing committee of this conference. Thank you all for watching.
And Abhishek, somebody is asking venue of the MRI teaching course. Is it online, offsite, or both?
So both, hopefully offline. The venue will be somewhere in Bombay. We'll get back to them soon on that.
Okay, thank you. So Mitusha, we can conclude.
Yes,
Yes,
Mitusha
you are
ma'am is a little busy, I think.
Yeah, I think you can conclude.
Yes, we.
Yes. Over to you,
Thank you.
please.
Thank you all for watching.